1 minute. Thank you.
Okay. So that was published in The Lancet in 1878. This image that you see here is basically the first documentation of the term telemedicine. So they talked about how they have telephotography, so now they need to have telemedicine. This was in 1927. Obviously, at that time, everyone thought this guy was crazy, but now it's actually happening. After that, we started having satellites, and with satellites came remote monitoring. NASA started using the satellite technology to monitor the physiological measures of astronauts in space. Now, that same technology, the image you see here, that's the ATS satellite in NASA. This was in the late 60s. They started using the same technology they used for the astronauts. The image you see there is a 1985 earthquake in Mexico. That technology was combined with the 1985 earthquake in Mexico to help people with telecommunication and aid in the relief support during that earthquake. And that was the first time that telehealth or telemedicine at that point in time was used in a mass casualty incident. Present day, this is present day, the image you see here. This is our incident command center in the Ministry of Health. As you can see, there are tons of screens. All these screens are part of a completely integrated telehealth system. They're connected to all the hospital incident command systems and to the ambulances. So you can see exactly what's going on just by sitting in one room. I'll talk about that a little bit later. So why am I talking about telehealth? Because the current management of any disaster scenario or a mass casualty incident, it has holes. What telehealth does is fill in the cracks. The cracks that we currently have in our management, telehealth fixes them. So this is the systems that we currently have in Kuwait. It kind of matches the majority of international systems. You call 112. 112, the call is dispatched to the EOC, which is the Emergency Operations Command. Then they will activate the HICS, which is the Hospital Incident Command System, which then activates the ICS, or they can directly activate the ICS, and the ICS can activate the HICS according to the scenario. So, sit, close your eyes for like 20 seconds, a little medical meditation. Imagine that you're receiving multiple calls in a metro station, and they're telling you there are tons of patients, they all have shortness of breath, they're all vomiting. What do we do? Most of these patients seem like they're going to be tagged red. What happens currently without telehealth? Imagine that scenario, and I'll go through the scenario with what happens with telehealth. This image is basically the sarin attacks that happened in the metro station in Tokyo. So this scenario that I'm running through is similar to those. What's going to happen? Step one, you're going to get a dispatch of ambulances. These are ICU ambulances. All the monitors you have here are also integrated in the telehealth system. You can get ultrasounds that can be integrated in the telehealth system. So basically, it's complete. You can re-triage, you can manage your patient through the ambulance. This is another option that you have in case it's needed. This is the HEMS, so the Hospital Emergency Medical Services or the Air Medical Services. They can also be activated as necessary. So this is basically dispatch. Now, what happens on scene? This is on scene. This was a triage scenario that we did, an MCI scenario that we did. You're going to see patients. They're going to be attached to monitors. So they're going to be tagged according to the start triage system. Now, in telehealth, what changes? This is what changes. On site, your paper triage tag is going to be changed to a PDA, which is basically a handheld first responder device. The handheld first responder device, you just scan, and it triages your patient. When you triage that patient, that information automatically goes into, it becomes data. How does that help me? Number one, it makes everything faster. Number two, I automatically have data. I don't have to have a paper and collect paper, and the paper gets lost. This is not going to happen. This also helps me with research, which you'll see how it later on affects preparedness. En route. En route, what happens? So you have the EOC, which is the image you see on the right, and you have the image on the left, which is the Hospital Incident Command Center or the telehealth center in hospitals. If you see at the EOC, you have two screens. One screen where you can have a video of the patient, and the other screen where you get the vitals. You can get full ICU set through that screen. So why is it relevant to toxicology? If you have a patient with a toxidrome, what you see on those screens is basically all you need to make your diagnosis, give your patient the antidote en route, and then re-triage them. If necessary, they might start red. You give them the antidote, they become green. What does this help with? You're decreasing, when you're re-triaging your patient, or you're treating your patient en route, you're decreasing ED flow. You're decreasing the flow to specialty centers. You're helping out the EMS, which are overrun and overwhelmed at that point in time. So this is basically what happens. Studies have shown that if you use telehealth, the number of deaths that occur during transfer from scene to a specialty center decreases. Total transfers decrease. Total number of ED beds used decrease. That increases your medical surge capacity. And ED waiting times also decrease. So it's a win-win situation. It's a lot of technology. It may be new to people, but actually putting this into our practice helps us out a lot in many, many ways. So if you think of telehealth and you think of the phases of the disaster response, it affects every single phase of the disaster response. So with preparedness and mitigation, we already talked about how what you are doing with telehealth is collecting data. Anything you get from your patient that is on your screen is automatically data. You use that, you can publish research. It's easy. You have an EHR system, you take the data from the telehealth, publish research. What does research do? It enhances our planning. It enhances our preparedness. we know what went wrong last time, and we can make sure it doesn't happen next time. What were we missing last time? We'll apply it next time. Response, we already talked about PDAs, assisting in field triage, electronic triage tags. Another point that we need to take account is virtual increase in medical surge capacity. So what is that? That's basically, you're on field, you're lacking physicians, or you're lacking any healthcare providers to triage your patients. You can virtually have another physician on the site, and that physician is going to tell you, well, triage this guy red, triage this guy green, triage this guy yellow. That increases your surge capacity. Also with transport and treatment. Like, as we said, we can treat the patient en route, or we can retransport, or we can send home. Recovery. There are certain pandemics or MCIs that usually have a very prolonged recovery. Things like pandemic flus, earthquakes, tsunamis. You can assist with the recovery of the patient via telehealth. You can provide like doctors virtually to assist patients at home, to follow them up. You can follow the labs of your patients virtually, especially for psychotherapy services or family support after a disaster. That can also be all done virtually. Also, you have inter-hospital communications. So let's say you have an ED and you have a specialty center, and the specialty center wants to downgrade so they can provide more beds. Telehealth gives you that. It allows inter-hospital communication. Another thing that you can take into account is the EMS. Now, if the EMS is transporting one person to another place and you don't have a physician to assess that patient, you're going to overwhelm the EMS capacity. So basically, that inter-hospital communication really decreases all the weight on the EMS services. That is basically the telehealth. These are my sources. That's it. Thank you. Any questions?
Thank you very much. We'll take questions actually at the end of the session.
At the end. Okay. Thank you.
So this morning, I've been asked to talk about occupational chemical exposures and the role the Poison Center plays in managing these cases. And I have a unique perspective because we do have relationships with other agencies that allow us to work on these cases. So just a little bit of housekeeping, so I don't have any disclosures, but today what I want to do is make sure you understand the ways that poison centers can impact, the impact we can have when dealing with occupational chemical exposure events, understanding the importance of developing partnerships with other agencies, and then I want you to think about the last time there might have been a chemical event. I want you to assess in your mind what role your poison center or what role you played as a toxicologist in that event. So just a reminder for those of you who weren't at my talk yesterday, I am in Atlanta, Georgia. We are a population less than half of what it is here in Istanbul. We have a population of 10.5 million people, and we are housed in one of the largest teaching hospitals in the southeast. Dr. Kazi, is it an 800-bed hospital? So yeah, something like that. 800-bed hospital in our institution, and the Poison Center is a department in that institution. We're one of 55 in the United States, as you probably know, and we are quite busy. You know, around 300 or so calls every day handled by our Poison Center. Now, in order to handle these calls, we have fairly advanced call handling capabilities. and you could compare them to what you have in your area, but communication technology and making the connection is important for us to report these cases. So for us, we have a very feature-rich telecom system. And what do I mean by a feature-rich telecom system? Well, we have various ways we can affect the queuing of the calls that come in. We have in our system what is called skill-based routing. If you're unfamiliar with skill-based routing, is say for example, we have someone who speaks the Turkish language calling in, and they only speak Turkish language, and many of us speak English. If there's one person in my department that could speak Turkish, we will give them a special designation, so even though they're still waiting for a call and they may be fourth in the queue to answer the call because they've waited a short amount of time, if you speak Turkish and you're looking for someone who speaks Turkey and they're available, the call will immediately go to them. And in our situation, we do get calls from Spanish-speaking people. Most of us speak English, but if I'm waiting for a call for English and I do speak Spanish, even though 3 of my colleagues are next to answer calls, the call will be routed to me first so the patient doesn't wait long. So it's called skill-based routing, and we're able to do fancy maneuvers with the way the calls are accepted. We also have the capability of working from home, and that's always a good benefit. In fact, some of our poison specialists work from home about 70% of their work. So 7 days out of 10, they may be working from home. They don't have to come into the hospital. They don't have to come into the office. We give them equipment. We give them a phone. We give them our resources, and they work from home as if they were in the office. One of the unique things about contacting us is that we were the first poison center in all of the United States to start accepting chat messages and email live. So these chat messages and these emails would go and mix with our phone calls, and so whether you're chatting, whether you're emailing, you could contact the poison center. Now, I don't know about some of you, I have older kids. They're in their late 20s. They don't use the phone anymore to call. They only use texting, and they only use messaging. So we have to adapt our practice so that we can attract some of these people who use alternative ways to contact us. One of the things that we're going to be adding in 2020 is accepting emergency calls by text messaging. So we have very elaborate equipment, so you can call us, you can chat with us, and you can email us, and the call or the encounter will be happening in real time. So that's what's important. Now, when you look at our technology in the Poison Center, not only do we have one phone system, we have a backup phone system. Whether that system goes down, we have to be able to provide 24-hour support to our service area. So we have 2 phone systems in the office, we have 2 phone systems in people's homes. So we're able, if in the event of an emergency, to be able to provide our services without interruption. We also have 2 different lines coming into the Poison Center. So if one of these lines get cut off, we still have backup lines to provide telephone services to the people and the public who use our phone system. So there's a lot of redundancy. And as you think about what you're doing in your centers, what you're doing in your poison service area, for us, we have a contract with public health, and we told public health, we will be available every minute of every hour of every day, regardless of the technological failures. Because all of us know things break. It's never always perfect to have communication lines open. So we have all these systems that allow us to have service. So when we have a chemical event, people will be able to call, even if one of our phone systems is not working. Now, I don't know about your capabilities, but because we're so busy, we can handle almost 70 calls simultaneously into our office. Now, the problem is I don't have 70 people working at the same time, but 70 people can simultaneously call into our area, into our phone system without getting a busy signal. Now, what happens in the event of a chemical event, a mass exposure? Will your phone system be able to handle the extra calls coming in, or will they always get busy signals? We invested our money in technology that allows us to increase the number of calls that come in to our center without a busy signal. We can handle almost, and you'll see shortly, we could handle almost 10 times the amount of calls without someone getting a busy signal. Because there's nothing more frustrating if you're calling emergency and it's busy. So we have the capability to turn on the programs that allow us to increase capacity. And I'll talk about the technology here. So it's called the SUFER phone system. I mentioned it the other day. I didn't really elaborate. But SUFER stands for Surge Public Health Emergency Response. This allows our system to increase our and expand our capabilities, but it's a technology that we've had for almost 10 years now. And not only does it provide access to more people, it also has a unique feature of being able to put messaging as if you were choosing messages from a phone tree. Press 1 if you want to hear about the common signs and symptoms. Press 2 for treatment. Press 3 for should you leave your area because of chemical gas. So instead of talking to a human, you can listen to live messages that are built for that specific event. Instead of talking to a human, I may only have 12 or 13 people in the call center. But if there's a mass event, we have in place a way that we could give people messages. Now, if they want to call us, listen to the messages, and still want to talk to a human being, there's a way for the system to route that call to a live person. So, when you look at this hotline, if there's an emergency in the state that requires messaging, we can handle up to 580, almost 600 calls at the same time without our phone system breaking. Because you've heard of crashing the internet, right? You've heard of crashing a website. Well, why does that happen? Too many people are accessing the website, and now you can't do it anymore. The same thing works in phone systems. So in the event of an emergency where you have many more calls, your capabilities have to be increased or they will break your phone system. So we have the ability to handle almost 600 calls, and the reason why the state wanted us to have this technology is they wanted us to be prepared in the event of chemical exposures, chemical emergencies, mass exposures, for the public to be able to access us. Now, the beauty about the messaging in chemical events is it's all text to speech. So if a message is developed, we type it, we type the message, and then the translator for the computer converts it to words. And so we can put many messages, as you could see here, you could put many messages into the system and many options for someone to listen to various messages. You can, when we are asked to do special messaging, it probably takes us 30 minutes to 1 hour to fully configure the system. The one thing that we ask our partners in the health department to do is write the messages for us. we'll load it into our system, we'll type it in, we'll load the program, and then automatically the messages start talking in computer voice. So it's a great system to have in the event you're looking at developing messages in the event of a mass emergency. Now, when someone's calling in, if there's a fire in Istanbul, and you want to just let the people in Istanbul know, as opposed to if you're in Cappadocia, if the fire's only here, then you will hear specific information about the fire here that has toxic fumes. So what you need to do is call the special number, put in the designated area number that you want to hear messages for, and then you choose the message that you want, and then choose the options if you want to listen to all the messages or you want to talk to a live human being. So that's what's that's the beauty of this system, is you could listen to the computer messages as well as listen to the live voice. Now, the whole purpose of this talk is to talk about chemical occupational exposures, and we have a unique perspective in that we actually published a paper not too long ago, I think in 2017, about the relationship that we have with a governmental agency to enhance and to recognize those exposures that happen while someone is in the workplace. So these are occupational chemical exposures, and we are working with a government agency called OSHA. I don't know if they have a similar organization here in Turkey, but who is OSHA? If you're unfamiliar, back in the 1970s, the US government and the Congress passed legislation that called for a law that requires safety in the workplace. And the name of that organization they called the Occupational Safety and Health Administration, or OSHA. And what this was to promote and enforce standards for safety in the workplace. And so we have this government agency that really tries to enforce safety regulation, because when you look at the incidence of injury, there are millions of people who suffer, in the workplace. In fact, reported on a yearly basis, over 4 million workers suffer some kind of serious job-related injury or illness. And that's a lot of exposures. And so in 2014, we started doing exposures in the workplace, and we started not only tracking them, we were getting the calls already, but we were starting to report the calls to the government agency. They never asked for those calls before, but we had the database. So we would collect information about the patients. The poison specialists and the doctors would give advice on how to treat these patients. Now, the one thing that was different is when you call into our poison center, every call is kept confidential and private. We don't release the information to anybody, even the government. So we asked the patient, if you were having a problem in the workplace, will you give us the permission to notify the government that you had an injury at work? Some people, they were worried about retaliation, and so they don't want to give any information. Other folks said, yes, I want the government to investigate. So I'll give you my name, I'll give you my number, I'll give you the company that I work for. So we have to ask everybody for the permission to release their name.
But what about if they tell you, yes, let them know, but don't tell my name?
Yes, that's the first thing we do, is we release the information to the government, but what we do is we blind all the cases. So the government doesn't even know the patient. We are just trying to get permission to release the fact that an incident occurred. We don't ever release the name, but we do identify the company, so that there's the possibility of investigation. Now, with OSHA, every week we collect data from the workplace, and every week we submit them all the cases. In 2018, we had over 800 cases from the workplace that were reported to us. Of the 800, 10 cases, only about 25% allowed us to release information. So not everybody, because they may be worried about job security. Now, one of the things that you have to do when you're having a program like this is you have to educate your staff. As I was talking earlier, Doctor, about the poison specialist, all our cases are documented. Now, the beauty of our specific EMR is that if someone has a workplace exposure, once they code and they use the code that the exposure happened in their place of business, automatically a reminder comes up. So if you tell the computer this happened at work, a reminder comes up that says, hey, what kind of occupation is this person? You know, will they allow us to pass their information to the government, so that our intakers of the calls will be reminded, so they don't forget that this is a unique case. So we have unique tools that allow us to remind us that we must ask more questions, okay? So I'm going to give you a couple of examples of cases where they called into the poison center and then we released the information to the government. For example, in this case, you have a 23-year-old who went to the emergency room after they were exposed at work to chemicals in their eye and their skin. They suffered burns to the cornea. The patient allowed us to give this case to the government, and when OSHA came in to investigate, they found some interesting things about this company. This company is an oil change company, and they failed to provide eye wash stations and other decontamination stations at work. They did not have the proper documentation at home, and after the government investigated, they fined and gave serious citations to the business of around $21,000. So the government said, you're not making your workplace safe. You have to fix the issues here before you can open your work again. In this case, case number 2, there was a 50-year-old who was exposed to chemicals for swimming pools. These chemicals fell onto his head, face, and chest. He was washed at the scene. He went into the emergency room with respiratory distress and altered mental status. OSHA came in and investigated, and here's what they found. When they investigated the company did not even report to the government that one of their workers was injured. There's a requirement for the government in these kind of businesses to report when a patient goes to the hospital. So failure number 1, they did not report the incident. Number 2, they did not provide a place that had that was free from hazards. They did not have body washing or eye exposure capabilities. They did not have the proper documentation in place for the chemicals, and they too were also cited and given tickets, and they were fined almost $30,000 for their issues. So there are many work-related exposures that get called into our poison center. We were able to collaborate with our government organizations to make the workplace safer by being able to report these cases to the government. And it's important for us that we had this relationship to forge with OSHA. So in summary, if you're looking at starting with a good communication lane for your patients to call, make sure you have a robust communication strategy. Do your job well, but once you've done your job well, look for other ways you can impact your community. And for us, it was a matter of recognizing that there were exposures happening in the workplace, that safety was being neglected. So we formed a partnership with the organization that looks for safety in the workplace, and we wanted to make, at least in Georgia, the patients that much more safer. Thank you.
Thank you. I think we have time for one question. Okay.
Thank you for your presentation about the technology, using technology in your system PCC consultation. I would like to ask, in the future, using the virtual intelligence applications, if these applications replaced by the PCC specialist.
We'll take.
Is it any risk?
Is there any, so the question is there, because of technology and the explosion of technology, will there ever be a point where we'll replace human beings and only have a technology?
Yeah.
I don't think there's any risk for that.
No.
Because you could write a document, you could have an algorithm, but you need someone to interpret it. You need someone to understand it. And so I don't see technology being the only answer. You have to rely on experience.
Yeah.
You have to have bedside consultations. So technology
I agree with you. Thank
will,
you.
will never.
Thank you, Yellow. I'm totally agree
And
with
Andy,
you.
I could talk to you, Andy, afterwards. I could talk to you, Andy, afterwards.
Okay, so next speaker is Dr. Suad Alabri from Oman, and she's talking about cardiovascular complication of performance-enhancing drugs. Please.
I had a question for Dr. Sultan. First, I wanted to ask what happened to the camel, but you already answered that question. Secondly, is you talked about how grammar has changed from one research to the other. What is your opinion on using websites like Grammarly, which automatically changes the grammar for you in whatever whatever you have?
Yeah, I use Grammarly sometimes. There are many softwares you can use, but sometimes you have, even after you use the software, you have to read it to make sure that it makes sense or not. You can ask sometimes a colleague, because even if you hire native English speakers, sometimes when they change things, the meaning would be changed. So you have to follow up after them. Was this the answer for you? Yeah, regarding the camel, usually they slaughter the camel quickly so they can get benefit of the meat. Yeah, but mostly he was killed instantaneously.
For the most question, I kind of request you to ask your question and break, because the time is over. We have to run to catch the time. Thank you very much. We are going to finish the section. Dr. Kasi, one time we have to be here again.
Yeah, so the next session starts in just 6 minutes. Thank you.
As I would like to present the next speakers, Dr. Sultan Al-Waji. He is an epidemiologist and independent researcher working in Jeddah, Saudi Arabia. Graduated from Al-Qurra University in Mecca with Bachelor of Medicine, Master of Public Health from Johns Hopkins School of Public Health. Dr. Sultan, you are welcome. You have 25 minutes, please.
Although case report is underestimated sometimes, For one reason, because many people read it, but few people cite case report, because usually case report about rare things or atypical presentation. It's not about something common. That's why it's not very widely cited. That's why the editor of the journals sometimes do not like case report. But if you want to write a case report, you have to make sure that you are submitting the case report to a journal that is interested in case report, or they are publishing case report, because you don't want to go through a lengthy process, then you figure out the answer from the editor that actually we do not publish a case report, which it happens sometimes. So at the beginning, what's case report? Can you report anything, or it has to have specific like feature or criteria? What do you think? Can you hear me now? Or do I have to go back to the mic? So case report, it's not necessary to be very rare. Sometimes when you want to report a case and you ask a friend or a colleague, and they would ask you that, you want to put the time? They will ask you, okay, that's fine. They will ask you, this case has already been written. So why you are writing this case? So somebody published it already. Why you are writing this case? It's not necessary to be atypical or very rare. Sometimes for educational purpose, let's say sometimes to increase awareness about specific disease that's not common in specific area. Because the main idea is to communicate with your colleague, to communicate with the other healthcare providers, that we start to see these things. For example, in Saudi Arabia, let's say that, I remember a friend of mine said that female, she was a back passenger, and she asked the driver to drive. He refused, but she insisted, and she was coming out of a party, and she was drunk. This is new. So she drove, and she was involved in road traffic injuries. The driver was in the ICU. So it was critical. We are not used to see these things, but start to happen. So you want to increase the awareness of law enforcement people and the clinician that driving under influence start to happen in this geographical area. I said the journal editor usually do not like it because it's not cited, but sometimes because it's at the bottom of the evidence-based pyramid. We usually start from expert opinion, then we go up, and the case report usually it's down. It's not like randomized controlled clinical trial. But for rare things, you cannot actually do randomized controlled clinical trials. So sometimes the case report is the start of, let's say, a systematic review meta-analysis. Most of the bigger research started with observational study or even case report. Like Dr. Lisa, when she mentioned about the HIV in the 1981, it was a case reported in the CDC, the weekly morbidity and mortality report. Then another case came from San Francisco. A third case came from New York. Then it became as a case series. Then somebody started to do official research to figure out what's going on. Sometimes atypical presentation of common disease, challenging sometimes case, sometimes. So the main thing is a learning opportunity or like highlighting a message of this case. What's usually it's not reported a lot, failure story. We need people to write about their failure. Let's say that you use something new, but you missed it miserably. We need to report about this because that's fine. Because if you do something and you fail at it, and you report it or you communicated with other physician, you are increasing the awareness that this technique does not work. So I mentioned all these, not necessary to be the first case. This was the Kaposi sarcoma in the 1981, published in the Mortality and Morbidity Weekly Report. Case series is 3 or more. Some of the people said it's 4 or more of the cases. You can call it case series. But if it's 1, 2, up to 3, you can report it as a case report. So what's the structure of the case report? Generally speaking, in research, we have specific form. We call it IMRAD, which is introduction, method, result, and discussion. And you put conclusion. So this is the main structure we usually put it for any research. But for the case report, it's a little bit different. And the good thing that case report mimic your clinical documentation. So you put an introduction, why you are writing this case, brief sentences about the disease you are describing, then case presentation, clinical history of the patient and the significant things the management or the outcome, then discussion, what do you think about this, compare it with previous case, and then you conclude. So it's very easy, you can write it in one day. But you have to know how to write the citation, the references, and usually it's preferred to use a software. So you make sure that you put the citation in the proper style, because each journal asks for specific style. Sometimes you submit it and they said this is Vancouver, we need Harvard, or we need the AMA style. So usually when you want to publish something, you have to know which journal you are submitting your paper to, take the author instruction, look at the instruction, and try to commit all the things, all the changes based on what they are looking for. So this is the structure of the case report. Title, abstract. Usually abstract is less than 100 or 200 words. And for the case report, they usually ask less than 1,500, 1,500, sometimes less than this. And this is all through the journal. You go to the journal and check what they are looking for. Introduction or background, then the case presentation, discussion, and conclusion. I will go through every one and talk briefly about the structure of case report. There is like a guidelines for any research design. For randomized controlled clinical trials, they have specific guideline. There is a guideline for case report, although not all the journal ask you to go with this guideline. The best thing, you go to the website of the journal and you see what are the requirements, what are the author instruction. If you don't find it, then you can go with the guideline. Title should be brief, informative, descriptive of a case report. Some journal ask you to write case report, like saying this is a case report of rare or atypical presentation. Other journals say no, do not mention this. So you have to make sure what they are asking for. Are they asking for this or not? Because you don't want to spend weeks, then they ask you to remove the word case report. Target MISH terms, if you go to PubMed, there is a specific characters called medical subject heading. They classify, they meet twice yearly, and they classify each disease on specific name, just to make sure when you put key terms for a specific disease, you find all the variation. For example, if I publish a paper about road traffic injuries, and you type motor vehicle collisions, you're going to get my research, because they understand these terms mean different things, and they collected in a specific place. If you go to PubMed, there is something called MISH database. You go and type the keywords there, and you try to figure out what are the MISH terms you are looking for. Some of them ask to write a rare case or atypical case. If you want to try writing first case, make sure it's first case. Because sometimes you say first, but if I do literature review, I'm going to find more cases of this. So as I mentioned, some say avoid, some say no. You can write a rare case or case report. Keywords, this is important. Usually choose 2 to 5. If you succeed at choosing the proper keywords, this would help other researchers when they go and do the Google Scholar search or PubMed through Medline to find your topic. And if the journal is indexed in PubMed, it's more likely that people will find your paper. Abstract brief, we said less than 200 words. Total case report, less than 2,000 or 1,500. Structure or unstructured. Sometimes they ask you for abstract, like in paragraph, mention everything, but in chronological order, introduction and methods, result. Sometimes they said no, write objectives or aim, then you put like 1 or 2 sentences, then write methods, then write. So this is the structure and this is the unstructured. Check the journal instruction. Usually check the journal instruction. Actually, it takes a lot of time to change from journal to journal. So if you get rejected or you want to change the journal, you have to change things in the paper, and usually it takes times, because you change the style, you change the reference sometimes, how you put the reference, you change the grammar or punctuation from American to British or Australian. Key elements in abstract, try to mention these key important things. Sometimes you write a paper and after 3 months or 6 months, when you want to publish it, they ask you for abstract. Then you write the abstract without going back to the paper. Then you figure out there's discrepancy. The things in the abstract a little bit different than the original paper. And usually do not believe any abstract Especially if you are trying to make a decision on this, you have to go and read the methods of the paper, because sometimes they mention something a little bit different than what the paper mentioned. And sometimes even things are the opposite. It shouldn't be like this, but you have to make sure you read the whole paper if you want to depend on that paper. Because sometimes you do not have access to the literature, so you just depend on the abstract. But this is not usually a good tactic. The introduction mentioned briefly things about the topic. Landmark papers, you can mention them in the introduction. Also, case presentation. This is mimicking what you have seen in the hospital. You just mentioned that we have this patient present with this disease and we did this. 2 or 3 paragraphs. Do not be obliged that you have to write everything about the patient, because you have only 2,000 words. You cannot write everything. You have to make it very short. Because in communication, you want to be clear and concise. Finish the story, even if you wait for follow-up. If you write the case and you don't know what happened to the patient, wait for a couple of days or weeks to say that patient didn't survive or went back home or deceased or something. Because it's like story. You're communicating with the clinician or other provider and you want to end it. You don't want to cut it in the middle, especially when the outcome is very important. Discussion, do brief literature review and emphasize on the learning point. Why you are reporting such case. Usually mention this. We are reporting the first case of this in this geographical area. Or we are reporting this because we started seeing these cases in our geographical area. Focus literature. When you come to the discussion, do not just report a case as if it's in solo. No, try to make a correlation between previous cases that have been reported in the literature and try to compare what's different from these previous, because discussion is like group discussion. We talk to each other. It has to be like kind of interactive. You mentioned X says, Y says, we noticed this. So do not make it like just a paragraph and you are mentioning, you are repeating the result. It has to be different than the result. It's interpretation of the result based on the other papers. Compare and contrast, finish with what your case add to the literature. In conclusion, should include evidence-based recommendation. Usually when you recommend something, especially with the case report, you have to base it on evidence, because usually this is a rare things. We do not have a lot of published recommendation about this disease. So try as much as you can support your decision in recommending specific things. Emphasize on the applicability of the practice. This is the main idea. If you want to change practice, if you want to increase awareness, you have to convince people that we did this with this case and the result was, for example, satisfactory or not satisfactory. Example of not very rare or first case. So I mentioned it doesn't have to be the first case. This is one of the case report I'm submitting now. It's a road traffic injuries in the middle of the city, in the highway, between 2 cities, but it was still in the same city. The car didn't leave. And the road wasn't lit very well. There was no light, and a camel came. It was an SUV, hit the camel. The car swerved twice, flipped over twice. The driver was putting seat belt, the baby in the back with the seat belt. The woman, the front passenger, wasn't seat belted. She was ejected and died on scene. So it's, if we report this, somebody would say, yeah, but this is a camel with the car, so what's the point? There is a point here. There is a point that although this is, it shouldn't happening, especially in a city, but it happened, we don't know what's the behavior of the accident. We usually, when we talk about accident, we talk about people who are texting and driving or people who are overspeeding, but we are not talking about uncommon things like animals. And we figure out that camels, accident with camels in the Middle East mainly, sometimes in Australia. In Australia, they have the kangaroo and other animals, but it happens, and it can increase the mortality of road traffic injuries. Then we spoke about the intervention that should have been implemented on the street, probably, or on the animals. Sometimes they put stripe with the light on these animals. Other thing, we saw a couple of cases with elderly people when Dr. Lisa talked about diabetes. I remember I was working with the Ministry of Health in health policy, And some of them, they did a research survey, and they mentioned that diabetes in Saudi Arabia, they said 8%, some of them said 10%. The problem, we are a young population. Diabetes usually happens in middle age and elderly. But when they did the subgroup analysis of that survey, people in Saudi Arabia who are 65 and above, 50% of them diabetic. Can you imagine this? So if you are 50 years old or 40, you're going to be diabetic. It's 50%. And this is previous research. We don't know if we continue on this, maybe it's going to be 60%. So one of the cases I saw in the hospital, I was taking history from the patient, and he was having a chest pain. He was 50 something. Then during the encounter with the patient, he said, this is after that pills, and he started cursing the pills. I was like, which pills? Then I figured out that he was using Viagra. At the same time, he was having angina and taking medication. So due to the interaction, he had a myocardial infarction. And the problem, they take it from the pharmacy over the counter. They do not have prescription. And the pharmacists even do not give instruction that if you are taking medication for the heart, you have to make sure you are not taking them at the same times. So although maybe this is not a very rare, but at least you are increasing awareness and mentioning some recommendation that need to be implemented not on the physician only, but on the pharmacist or on the patient. Graphic and image, this is good. If you mention something, if you put illustration, it makes your paper looks nicer. It's kind of like entertaining. If you entertain the readers, people would read your articles. They probably would cite it. The journal would like it. But usually follow the instruction. Sometimes they don't want more than 3 table or 3 image. Be creative. Feel free to be creative. You can create something. You can draw something or hire a video animator. Like now I'm trying to hire a video animator. I contacted one of them because I figure out when there is an accident, sedan car with a camel, usually because the camel is 2 meter height and the sedan is a little bit lower. The weight of the camel is more than 500 kilograms. So if they hit the camel, usually the camel fell on the passenger and they get killed. But it's SUV or family car, usually the camel will be ejected. So this might indicate the fatality of the accident. And I think the speed has another factor. If you are driving at high speed, more likely the camel will fall in the car. But if you hit a camel on a low speed, it will fall in the front side of the car. So you can add some information, especially the mechanism of the accident. Practical tips to write and publish a case report. Consent the patient. This is the first thing you do. If you see interesting things in the hospital, consent the patient before he goes. Because if you tell me after 2 weeks, I want you to help me in writing case report, if the patient left and we do not have a consent, that's an issue. Put a deadline. If you agree with your consultant to write a case report, let's write this in 2 weeks. Or I will give you my final case report and then you review it in 1 week. Agree on authorship. Sometimes conflict happens, especially between 2 different departments. We are the emergency medicine. We saw interesting case, admitted the patient, then the radiologist, they publish the paper, but we publish at the same times. So try to, if it's different perspective, they are publishing from radiological perspective, that's fine. But if it's the same case, it doesn't look nice when you have a conflict of authorship on a case report. Plan to succeed at the 3rd trial. I'm a researcher, so I usually see clinicians, they are frustrated because they tried once, twice, or 3 times to publish something, but they weren't successful at this. Let me ask you a question. Do you think your first intubation will be successful? I don't think so. Do you think your first physical examination will be presented, or people would say that this is the best physical examination? So in research, it's the same thing. You do the research, you failed first time, you get rejected second time, third time rejected, then you resubmit again. You might succeed after 4th time, but that's fine. It's a learning opportunity. The more you try, especially with the supervisor, the more you learn. Authorship, make sure you do not have a conflict. Single author usually responsible for the load of the work. Sometimes a single author may be the senior, but the senior need to have the load of the work. Being a clinician, or if the patient is admitted under your name, doesn't give you the authorship. You can publish a case report while the treating surgeon or clinician was not involved in the case in the writing or intellectual.
Yes,
process.
1 minute.
Okay. Avoid double publication, ethics and ethical approval. You need to have the informed consent from the patient, okay? If you want to show the picture of the patient, there is another form. In some institution, they ask you for IRB, institutional review board. It's not the usual practice, but some hospital ask for this. And avoid plagiarism. You can check the journal. Sometimes they mention topics that they accept. For example, they said we take case report in trauma or injury, stuff like that. Drawback of case report, we said it's at the bottom of the evidence-based medicine. Due to the high volume, journal usually accept very few number, limited number. And some journals do not accept case report. Avoid making firm judgment because it's one observation. Do not say that this treatment is for this disease. Before claiming rarity, make sure it's rare. Few grammar mistakes is acceptable. Typos are not acceptable. Even if you are non-native speaker, typos usually means that you were in a hurry or you do not have time to review your paper. Example of non-case report, we said the AIDS, the thalidomide, it started with the case report, with the congenital anomaly, the fenfluramine, which is the appetite suppressant with the pulmonary hypertension, and the Zika virus. This is the guideline for the case report. Some journal ask for this. Yeah, so this is just a video. I was showing how when I write, usually try to use a dictionary, especially if English is not your first language, to be very handy for you. Because you need the thesaurus, you need to check for words, you need to check for spelling. If it takes you a long time, you will get bored and you wouldn't go and check the dictionary every now and then. But usually writing is not like speaking. It doesn't come from the first time. Even native speakers, sometimes they write things, and when they read it again, they do not maybe understand it, or it's not very clear. And this is the last video. You can hire somebody to check your writing, check your English, and you can pay them per page as a native speaker. That's all.
Okay, thank you very much. Thanks. We'll take questions at the end of the session. Our next speaker, Dr. Razan Rahimi. She completed a residency from the Kuwait Board of Emergency Medicine. She's currently a staff physician in the emergency department at a hospital in Kuwait City. She's going to talk about one of her interests, which is telemedicine.
No experience of any mad honey, so I can't. If any one of you has ever seen any cases of mad honey? Okay, good, good.
Thank you
Over
very
to you,
much
sir.
to Menetox and EPAT for inviting me. I'm proud to collaborate this assembly. My presentation topic is mud honey. Mud honey poisoning, not also this presentation, my presentation topic, also my scientific life main topics. I will explain some my expert. I like there to no conflict of interest. First, let's see some chronologic old writing and ancient writing about mud honey. In ancient and old writings, we first seen Xenophon. Xenophon has a book called Anabasis. In this book, he mentioned about the mud honey. He told that his soldiers who ate mud honey looked like drunk people. This is first used mud honey word in the past. First we seen mud honey word in this book. Second, we seen Strabo. He is also an historian in ancient time. Strobo also told his book, Pompey's army was destroyed by feeding methane. This war Strobo's mentioned about is near the Trabzon, like Xenophon mentioned about this war, his war. Centuries after these ancient history writers, Mr. Koloman said that he gave medical attention about, explain some case, 14 case, which 3 of them died. This is important for us because this mortality is first described these books, these letters. The distribution rhododendrons and methane-posing cases in Turkey. Grantoxin comes from the rhododendron flowers, and this makes the honey posing in Turkey. Plants belong genus rhododendron have wide distribution area in Black Sea region, which extends from the Marmara region to Caucasia. We see. This area is rhododendron ponticum area. This area is rhododendron luteum area. There are remarkable harmony between the distribution areas of plants genus rhododendron and the areas where posing cases. Worldwide, when methane poisoning cases are analyzed according to countries, it is seen that the most cases of methane poisoning occur in Turkey. Nepal is second country. South Korea comes third. As we see, Turkey is first one, Nepal and South Korea is second and third case we see. Methane poisoning produced in this country can export Europe, Asia, and others countries. Because of this, some poison case can be appears in this area. Out of the Turkey, Nepal, and South Korea, we can see methane poisoning cases. For what we use, people use methane. Methane generally consumed but accidentally in Black Sea region. People don't know how it contains grantoxin or not. Methane can also consumed as alternative therapy for health problems such as digestive system, hypertension, sexual dysfunction, wound healing. Methane also used to diabetic patient for blood sugar regulation. When they use it as an alternative therapy, it can be poison this person. The poison effect of methane originates from toxic compound called grantoxin. Based on the literature, so far we 60 grantoxin types, and their glycosid have been isolated from the various Ecosia plants. Primary toxic compounds are grantoxin 1 and 3. Primary toxic 1 and 3. Physical symptoms from methane poisoning appear after dose-dependent latent period of several minutes, approximately 3 hours. Patients exposed to low-dose grantoxin typically recover within few hours. In more severe cases, symptoms may persist 24 hours or longer may be required medical treatment. Grantoxin are capable of binding the group 2 receptor regional voltage gated sodium channels. Grantoxin only binds the activated conformation of sodium channels. After binding of the receptor, grantoxin prevents inactivation of sodium channel. This activated conformation allows the influx of sodium, and this is stop the membrane activation and neural activity. The main symptoms believed to caused by continued sodium channel activation, cell deposition, and hence stimulation of the vagal nerve system. Depending on this, various cardiac conduction disorders may develop, such as varying degree of heart block, nodal rhythm, complete atrioventricular block, and second degree heart block we can see. The main common symptom in methanoposing cardiac symptom methanoposing patient is sinusal bradycardia. Also, clinical characteristic. What is the main clinical characteristic of methanoposing patients? We can see in emergency department this patient. Main symptom is hypertension, bradycardia, nausea or vomiting, sweating, dizziness, impaired consciousness, fainting, blurred vision, or diplopia we can see. Diagnosis based on patient history and clinical finding. SMSMS system need diagnostic tools not used in Turkey now. Maybe in the future we can use this diagnostic tool. There are similarities in clinical status between methanopoisoning and cholinergic poisoning. It is important to efficiently difference between the two types of poisoning, emergency department, to initiate appropriate and effective therapy. Biochemical data which was obtained in this study do not support the hypothesis that methanopoisoning should regard as cholinergic poisoning. It's different. Only the same is atropine treatment is useful, methanopoisoning and cholinergic poisoning. Clinical characteristic. We seen one patient methanopoisoning related asystole. This is first case and only one case to after the poisoning we seen asystole. After after this after we published this case report, we seen a famous film, Sherlock Holmes, named Sherlock Holmes, mentioned about our case report. One of my colleagues said me that people made films your study. Did you see the Sherlock Holmes film? I said no. They said me that you should you have to watch Sherlock Holmes film. Let's watch this part of film. In this film, they said that as we wrote on my our case report, they said that in this film, Matheny poisoning, very well-known poisonous poison, which can temporarily block heart rate. They said also this film, this fragment. But we can't hear. No. Okay. Ne diyorsun sen? What's the treatment in this poisoning? We only two tools, atropine and IV fluids we use. Standard ACLS protocol if bradycardias appear. Supportive treatment, atropine and IV fluid we use for treatment. There is no specific antidote for gram toxin. Although symptoms and signs can be alarming and sometimes life-threatening, useful supportive care with electrocardiographic monitoring. Normal saline infusion, as I said, we used if complete heart broke and appear, we can use cardiac pacemaker. A lot of research has been done on Matheny poisoning in Karadeniz Technical University Medical Faculty, Department of Emergency Service, Emergency Medicine. The high incidence of, let's look at some of it. One of them, dose-dependent effect of gram toxin in cardiovascular system. Second one is the analgesic effect of Matheny poisoning, and is gram toxin directly responsible Matheny poisoning associated seizure? Does Matheny poisoning require hospital admission? Clinical review of Matheny poisoning with flow over Matheny, and also maybe 5 or 6 more example. The honey, the poison, and the weapon, the topics presentation was we have. Are there any new project about Matheny in this our department? Yes, we have new projects. We are doing some new studies. The most important one is project developed to diagnostic kit for Matheny poisoning. I think the last one, this project, the last project is the best one for Matheny poisoning disease. Thank you very much.
Thank you. Thank you.
front flower is Rhododendron ponticum, the back is Rhododendron luteum. This view is Black Sea Mountains. Thank you.
Thank you. Are there any questions? Yeah.
Because actually, because we are facing with this patient. Actually, we have a patient with same symptoms after injection of honey.
Can you just keep the mic
Yeah.
near your mouth?
My question is how we can differentiate this is hypotensive bradycardia, this from the honey itself, or it is contaminated honey, because you know that a lot of honey is contaminated with other substance, which can cause bradycardia and hypotensive. How we can differentiate between this?
I think you mean old honey don't poison. You mean?
No.
How can we differentiate what?
I mean, many manufacturers, they are producing honey, they are contaminated with other substances, which can cause bradycardia and hypotensive. How we can
Like what other symptoms you mean?
because what I want to say, because what I remember that when I talk about that, what the case was, I'm showing that the honey was definitely contaminated with something. I'm not sure what was that one, but if it was contaminated.
His question is, can there be any other contaminant which can cause the similar kind of?
As we case, we don't have any contamination.
You don't
honey,
think that
honey.
there is
Yes.
any
Yeah.
such?
Or contamination is only ground toxin.
Okay. Okay. I think it's better that you can maybe discuss your problem with him at later. So thank you so much. It was a wonderful talk. Let's give him. So I thought we were kindly done with the presentations, but we have Dr. Hussain, who's from Iraq, and he's going to present on thallium poisoning, his experience.
Yes, our next speaker, Dr. Hannah Bergbauer. She's a nurse midwife and nurse practitioner. Nurse midwife and nurse practitioner who focuses on international health programming. She's a consultant with Integral Global and currently stationed in Bangladesh, focusing on expanding access to care and quality improvement within the Rohingya and host communities, incorporating telehealth platforms into low-resource settings.
I can probably do it without, I think. Oh. So I have to use that. Okay. Everyone for being here. That was a great talk, giving sort of the history of telehealth, and I'm going to talk a little bit more about telehealth, but in a different capacity. The telehealth work that I've been involved in has been in low resource and vulnerable settings, so slightly different from the EMS perspective. So just sort of a broad definition of what is telemedicine. It's technology-enabled health and care management and delivery systems that extend capacity and access. So what does that mean? It just means that basically we're utilizing technology to expand the reach of providers and care access to patients in settings that they wouldn't normally have it. So we saw in the previous presentation, that the telemedicine was used in the field. I'm talking about actually taking it to rural settings or places that maybe are conflict zones or other things like that, where a person in the U.S. or maybe couldn't even go, or providers can't get to. So why telehealth? These options provide sustainable medical expertise to those with the most vulnerability. So the quality of care increases. They have greater access and lower or no cost, because oftentimes when it comes to telehealth, the person on the other end of the camera is doing it for free, or it's a part of a package. So it's low to no cost, which is nice. So 50% of the world's population lacks adequate health care. and that's, you know, we see typically in the global south, but also telehealth is being mobilized throughout the United States in rural areas as well, and in other countries that are considered high income due to lack of access. So I always like these world mappers. I don't know if anyone else uses them, but I think they do a good job of showing distribution, specifically in regards to the health workforce. So this is sort of an example of the distribution of physicians globally. So you can see, right, that higher income countries tend to have more physicians, which means that patients are generally going to have better access. It doesn't always guarantee that, right, because we know that oftentimes in countries like Bangladesh is a high-income country, but for example, in Bangladesh, 70% of the physicians are actually working in urban areas, while 60% of the population in the country lives in the rural areas, right? So it's disproportionate. But this is what, you know, we see the continent of Africa becomes very, very small. Southeast Asia, like India, looks large in Bangladesh, but the distribution isn't even. And then we look at nurses, which also, are now being moved into telehealth platforms to do consulting as well. And you can see that the distribution isn't quite equal. And the same for midwives. So sort of background on how telehealth, that what I've been involved in is working is devices are provided. So the organization that I've worked closely with has been, it's called InTouch, that's the platform. And there's some pictures of the devices throughout the PowerPoint. And then the World Telehealth Initiative. So World Telehealth Initiative is a partner of InTouch. And basically InTouch created this technology. And the World Telehealth Initiative has then linked them up with providers who will see the patients, you know, from the other side of the world, which is pretty cool. Then extensive training on the use is conducted, and then the expertise based on what the service utilization is going to be will then be provided. So I'll talk about more like the utilization of the telehealth in a few slides because there's a lot of different ways. It's not just providing clinical care or consultations. It's now being used in low resource settings in a variety of other ways as well. And then these devices that I've been working with specifically they're trying to use internet as much as possible because it's more cost effective, but they're also using satellites, as was mentioned in the previous presentation. Hello. Okay. So these are a few ways that we are currently utilizing or uptaking the telehealth models. So direct clinical, well, I say direct clinical care, it's a little bit more indirect, right? But for clinical care, scheduled expertise consultations, emergent high acuity cases. So for example, we might have somebody on call that you can ring into or that you can call into with a video capacity as well. Education and training is something that we're utilizing these models for pretty extensively, especially in settings that are unstable where someone who's a trainer can't actually go into. Technical assistance, so I'll tell some stories about some technical trainings that have been done. And then disaster preparedness and management, real-time response, and then a lot of mentoring. So this is actually a picture of students who were utilizing telehealth resources out in a village. You can't, they kind of cut it off, I'm sorry, but there actually was a telehealth device. This is in Tanzania, and they're out doing trainings with a local community, sort of training of trainer models. So it's actually, that device was using satellites. And this is what's called a mother's club. So it's a place where mothers can come and gather in these rural communities in Bangladesh. And they've got telehealth devices that actually allow someone to provide them a consultation for different things that they might be experiencing. So they might have a day where there's a dermatologist that can provide a consultation with one of the devices. This is an example of, you can see one of the devices down at the bottom here. And so not only was the training recorded, but this was really important for these midwives because they actually practice on an island. So it's an island that takes about 45 minutes by boat to get to the mainland from, and there's no emergency transport service. So there's not like an emergency boat or anything like that. Basically, if there's an emergency, that person has to get on what's called a sampan and make their way. So these midwives, there's 6 of them that basically run this labor and delivery ward, and they need to be able to do everything. And that's a challenge for them. So what we were able to do is do extensive trainings and mentorship, and also they have a telehealth device where they can call in to somebody who's on the mainland at any time for backup, which is different than they ever had access to before. And actually there's been a documented decrease, in some more severe morbidities, and then mortality hasn't changed, but that's a result of other factors. And so this is, you can see a nice graph representing fistula clinic and the mentoring sessions, and looking at, they were doing the same amount of surgeries throughout the entire period, but they were able to do more independently after trainings, and less mentoring sessions were then required. And then this was reported on yesterday, using the telephone consultation service at the tertiary care hospitals in Lebanon for the toxicology exposures and the impacts of the reach of, having access to those services to help patients get specialized expert care. And then one of the projects that I've been working on has also been in the Rohingya refugee camp. And so when the Rohingya, I don't know if everyone is aware of that crisis, but basically in 2017 in August, there are about 1 million people who made their way from Myanmar to Cox's Bazar, Bangladesh, as a result of genocide in Myanmar. And so, of course, at that point, there was no infrastructure, there was no healthcare services available to them, and the influx of providers from Dhaka and other cities throughout the country, they weren't specialized providers. So they may have been physicians or other trained healthcare personnel, but they weren't specialized. And so telehealth devices were able to be moved in pretty quickly, and satellites were used so that there could be access to things like a dermatologist, which oftentimes people say, why do they need a dermatologist? Acne is not an emergency. Well, when you have a skin condition that is life-threatening, it is an emergency. And so having the access to the dermatology, for example, was actually pretty important. And then in relation to more of a toxicology or sort of perspective, I don't know if anyone's ever heard of YABA, but YABA is a drug that there's been a big issue with the import of it through the camps, and there's been a lot of overdoses. And so it was actually, when that first started to happen, they looked at it from an epidemiology standpoint and figured out what was going on, and then employed telemedicine actually to consult and help treat some of these patients, because there's only 4 tertiary level hospitals throughout all of the camps serving about 1 million people. And so those providers didn't have access to emergency or response resources, so they were calling into experts actually in the US who could help them through that. And then there's the option of clinical consultation, so specialized expert care. This is the picture doesn't tell you what this patient has, but this guy actually has MDR-TB, and no, he's not wearing a mask. But this patient was waiting for his call to actually talk to a specialist in the US, and he continues to come back and get his treatment. And the device, actually, he can see him, and it's this young lady in the picture. They've hired a telemedicine implementing physician. So she basically just runs the telemedicine device. She does the assessment. She helps move and maneuver everything in collaboration with the provider who is on the screen. And this is just an interesting picture because it's a dermatologist looking at a patient who is following up. So it actually has created continuity of care, whereas like many times before, maybe a provider had flown in from wherever, saw the patient, and then would never be back again. But what this also does is creates the option of seeing that patient again and again, and the patients, they do come back. So this is important in terms of these low resource settings and the provision of healthcare, because the idea is that there's the possibility of preventing about 8.6 million deaths a year, which is a lot, by providing access to specialized care and resources. So the idea also is that with everyone that is interested in telehealth coming together and providing these expertise and consultations, that you can actually transform healthcare that is currently being provided in low resource, low income settings where the options to see providers or receive trainings and other specialized services aren't available. It's really impactful, and it has the ability to offer patients things that they wouldn't normally have. And so, like I said, I'm working with Integral Global, and then in partnership with In Touch Health and World Telehealth Initiative. So thank you. If anyone has questions, I'd be happy to answer.
We can take questions from all the speakers now. Yes, do we have a microphone?
Dr. Hussain, you have 20 minutes. Please stick to the time.
Yeah. Where is my presentation, please? Okay. Yeah. Thank you, Doctor. It's my appreciation to be here. I am Dr. Hussain Hamoudi, the Director of Baghdad Poisoning Control Center. In fact, from 2008 up to 2015, we have many cases presented, about 60 cases presented to our center. Sometimes might ask, this is the most likely presentation. Alopecia is one of the presentation of thallium poisoning in chronic cases. Sometimes skin hyperpigmentation also occur, but it is not usually start like that. Usually thallium starts in acute stage with after entering to the GIT symptoms, presented with GIT symptoms in acute. Then in second day, after 48 hours, usually presented with painful ascending peripheral neuropathy. With the time, with the course, after a few days, the painful ascending peripheral neuropathy changed slightly and slow progressive into motor neuropathy. So the patient after 1 week or 2 weeks might have numbness and paresthesia, and usually end with paralysis. This is the effect on the lower limb, which is the most likely affected by thallium. Of course, the mechanism of thallium is usually attributed to its analog to potassium ion. I mean, it enters and deceives the cellular membrane instead of potassium because of similar charge and similar size. It entered to the ATPase system, and that illustrates why it is usually affect the hair follicle, because ATPase is responsible for energy production, and this is due to lack of this energy production. Usually the hair is fall, and the epilation usually starts at the 10th up to 3 weeks. 10th days after exposure up to 3 weeks. Sometimes when the amount ingested is so large, it might cross the blood-brain barrier, and the most likely affected oculomotor nerve, the third cranial nerve, and the patient presented with the dropping of upper eyelid. Here there is 2 case study. One of them, the most common, a famous case report that is published all over the world. It is about Al Jawiya Sport Club. When they ingest thallium, which is contaminated with the piece of cake usually introduced to them during the celebration day of that club. Those 2 families, in fact, admitted to the emergency departments of Al-Kindi hospitals. Their complaint was GIT symptoms, but it was fruitless. They didn't manage well. In the 4 days, they admitted to another hospital within the medical city complex, to the Baghdad hospitals. At that time, they asked me to see and examine the patients. On examination, this is a good example of acute thallium poisoning. All of the patients looked terrified, exhausted, diaphoretic, and the child was admitted to the intensive care unit. The member was 6 at that time. Bilateral painful ascending peripheral neuropathy on all of them. They have severe burn, describe their burn as if they are walking on a pen or a hot coal. Yeah, of course, the tendon reflexes was normal. Babinski reflexes and other reflexes was normal at that time. Abdominal reflexes, normal. Ptosis in 2 persons. Yeah, pleuritic chest pain in 1 person, and all of the patient, of course. There's ECG normal and other examination is normal. In fact, this is the questionnaire that I have asked at the time. How many days they were suffering? The answer was 4 days. This is the day 4. What type of food they were shared? Yeah, they said to me, and a cake introduced to them. Who had ingested the largest quantity? Because I want to compare the quantity that had ingested with the clinical presentation. The answer was that one have severe painful ascending neuropathy and ptosis. That means he had ingested a large amount of thallium which crossed the blood-brain barrier. So, differential diagnosis at that time was arsenical compounds and thallium. Botulism also. We sent for a stool culture and bacteriological study to exclude the Clostridium botulinum and Guillain-Barré syndrome. In the second day, we arranged for laboratory workshop. 6 samples were withdrawn from these 5 samples, and another 2 negative samples. All of them were positive, as you see. This is the name, Zainab and Muhammad Rasool. He is the big boss of Al Jawiya Sport Club. This is the thallium test were done in my lab. If it is clear, a pink color test usually appear, which indicate the positive results. Of course, we use dithiazide and sodium potassium tartarate cyanide reagent in this test. Okay. After we finished the diagnosis, the absence of a Prussian blue at that time, and unfortunately, we sent them to another Jordanian hospital. And the guideline management were prescribed at that time. A Prussian blue should be given orally. Hemodialysis should be done for them. Potassium infusion, it is controversial. Some of them said that it might exacerbate the neurological symptoms, and some of them mentioned that it might shorten the bedridden of the patients. This is the Prussian blue potassium ferric hexacyanoferrate. This is a case. Another case, please. Yeah. Mustafa Latif, 13 years old male. In fact, presented to the Mansour Pediatric Hospitals. The relevant gave history that he eat hamburger and sweet, and his daughter were died the day after ingestion. Of course, the Ministry of Health and other pediatricians asked for my help at that time. This is the Ministry of Health. This is the examination. All things were normal except sinus tachycardia. The patient looked hallucinated, terrified. Of course, he has painful ascending peripheral neuropathy, but no alopecia. And with dark hyperpigmentation of both hand and face. This is an abnormal, but it rarely happened with thallium. In more than 80 cases, just we have 2 patients presented with such dark hyperpigmentation. Of course, the patient treated with thallium, with the Prussian blue, and also we add, this is laboratory finding. All biochemical tests were normal, except thallium. The patient has hypertensive, which were treated by captopril, in addition to Prussian blue, or IV fluid, or potassium, of course, given IV infusion, but then it replaced by fruit juice in order to replace the thallium. Usually the patient have hypokalemia during the course of illness. On 7 days, another test were done, which was negative, but the patient kept on the same treatment for at least 3 days. This is this patient presented 1 month after exposure. We add on discharge neurobin, multivitamins, and zinc sulfate. After 1 month, the patient completely returned to normal, but he still has painful, some pain in the lower limb. But it usually, according to the literature, it might disappear after 1 year at least, 9 months up to 1 year. Thank you.
Thank you.
If there's any question, please.
Yeah, they're very interesting cases. I just have one question for you.
Yeah.
How did they get, all the cases got
Thallium.
thallium in food? What was
Yeah.
the intention
It is
and how did they get that?
Most likely criminal.
Criminal.
Criminal, yeah. Because during the wartime, and ISIS, some members, some families, some of their family members belong to ISIS, they might to kill other, which belong to policemen or governments.
And is thallium available?
Yeah, it is not available on the markets, but it is used as a rodenticide in the neighboring countries, in Syria and Iran.
Okay.
So it was used by intelligences during the time before war, before 2003, by Saddam regime to assassinate the others.
Okay. Okay, so that's very interesting because I personally have no experience. I would have maybe thought of ascending paralysis, neuropathy, arsenic, which you mentioned, but
Yeah.
the alopecia
Arsenic was negative in our test,
Yes.
in my lab test.
any other questions?
Any other question, please?
If there are none, thank you very much,
Thanks
Professor
a lot.
Hussain, and
Thanks.
I must give him a big round of applause. I must thank all the speakers, Paul, Chuck, Hussain, and Dr. Abdul Qadir for a wonderful session. With that, we conclude today's day, and we meet again tomorrow morning at 7:30. Thank you very much.
Welcome to Istanbul. Please introduce yourself and what do you think about Congress?
It's nice to be here. My name's Hannah. I'm working with Integral Global, and I'm happy to be at the conference. It's going very well. Lots of really important information.
How do you say about Turkey foods or Istanbul?
Well, I like sweets, and
Sweets.
so the Turkish sweets are faring me well.
Okay.
Yeah, I'm enjoying the food. It's wonderful.
Thank you very much.
Yeah.
Welcome again.
Thank you.
Hello, my name is Nabil Ahmed. I'm the director for Integral Global, one of the participants for this conference, and this is my 5th time in Istanbul, and I always like coming to Istanbul. It's a beautiful
love
city.
Istanbul.
Yes, I love Istanbul. I love the food, especially the kebab.
Thanks. We love it too.
Yeah.
Welcome again.
Thank you very much.
Hi, I'm Mazda Shirazi. I'm the medical director of Arizona Poison and Drug Information Center. This is my 2nd time being involved with your physician group, the emergency physician group. Last time I was in Trabzon. And it's actually lovely to be in Istanbul. And I'm partly Turk and partly Persian, so I always like to come back to the region that my heritage is
We are
from.
waiting for you every time. Thank you very much.
Okay.
Okay, Mr. Charles McKay, welcome to Turkey. Can you introduce yourself to us?
Sure. Charles McKay, I'm a medical toxicologist, physician toxicologist in Connecticut, the eastern part of the United States, and immediate past president of the American College of Medical Toxicology. It's our national organization of physician toxicologists.
Thank you very much for welcome to you also again. Did you like the program of the conference? How do you find our preparation? Can you make some comments for us?
Oh, sure. No, it's been very enjoyable thus far. It's always amazing to see how a group of people will come together from different areas to try and provide some information and training across common areas of concern. And certainly EPAT and Menatox here, the board and all of the participants have been doing a great job running really 3 simultaneous tracks today and 2 tracks in the next couple of days. It's always a challenge, but it seems to be going very well.
Thank you very much.
Today we are with Lucy Schiffer-Bain, and first of all, would you like to introduce yourself to us?
Certainly. So I'm Lucy Schiffer-Bain, and I'm from the New Zealand National Poison Centre, and I'm also from the Toxins Poisons Information Database.
Okay, what do you think about this Congress?
It's fantastic, just having the opportunity to be able to participate in a Congress which helps strengthen the capacity in the region is just a wonderful opportunity.
Okay, thank you.
9. Menatox Klinik Toksikoloji Konferansı'nda İstanbul'da Başar hocamızla birlikteyiz. Hocam yurt dışından, Amerika'dan, dünyanın birçok yerinden 70 tane yabancı katılımıyla İngilizce ana dilinde bir konferans düzenliyorsunuz. Ne hissediyorsunuz? Nasıl gidiyor konferans? Katılımcılar katılımdan memnun musunuz? Düşüncelerinizi alalım.
Yani bu Menatox'a eş sahipliği yapmamız gerçekten bizim için çok önemli bir dönüm noktalarından biri. Çünkü toksikoloji ülkemizde şu anda emekleme dönemini geçip yavaş yavaş yürümeye başlayacak bir branş gibi görünüyor. Şu anda yaptığımız bu kongrede aslında ülkemizdeki en büyük uluslararası kongrelerden bir tanesi. Yani 70 tane yabancı konuşmacının sizin de bahsettiğiniz gibi ki bunların birçoğu okyanus ötesinden geliyor. Ve ülkelerinde de dünyada da saygın isimler. Bunları bir araya getirmek, İstanbul'da buluşturmak ve İstanbul'u toksikolojinin bir gündemi olarak oluşturmak bizim için çok önemli adımlar. Gerçekten bu yüzden hem mutluyuz hem gururluyuz. Ama bir taraftan da bu konuda gerçekten bütün asistanlarımızın, bütün uzmanlarımızın daha çok ilgi göstermesini, toksikolojiyi takip etmesini bekliyoruz. Çünkü toksikoloji acil tıbbın ana branşlarından biri olmaya gidiyor. Ana branş derken yani ana altyapılarından biri olacak. Çünkü hastalar zaten toksikoloji hastaları öncelikle acil servislere başvuruyorlar. Onların tanısı ve tedavileri de acil serviste devam ediyor. Bu yüzden acil tıp konusunda toksikoloji giderek ilerleyen süreçte daha önemli bir pozisyona gelecek. Yani toksikoloji acil tıbbın çok önemli bir bölümü olacak. Burada baktığımızda Amerika'dan, Avrupa'dan ve sadece bu coğrafyadan değil, aynı zamanda mesela Uzak Doğu'dan gelen misafirlerimiz var. Bunların da çok ciddi çalışmaları var. Bunlar da gönlünü toksikolojiye vermiş çok önemli bilim adamları. Çok güzel noktalara vurgular yapıyorlar. İnteraktif çok iyi geçiyor. Yani bu konuda duyarlılığı artırmak, farkındalığı artırmak için önemli bir mihenk taşı olacak diye düşünüyorum. Acil tıp açısından da şöyle düşünmemiz lazım. Acil tıp açısından. Yıllardır beklediğimiz adımlar bunlar. Çünkü birçok acil tıpçı aynı zamanda üst ihtisas yapmak istiyor. Üst ihtisasın en önemli maddelerinden biri toksikoloji. Bununla ilgili bazı gelişmeler oldu dönem içinde. Bu daha ileriye taşınacak. Öyle görünüyor.
Çok teşekkür ediyoruz hocam. Ülkemizde böyle bir konferans düzenlediğiniz için.
We do get cases occasionally where we have given antivenom and there is refractory coagulopathy.
For us, for me, I rarely found like the antivenom is not working. I cannot remember like maybe few cases.
And then, though we are sharing the same, and that's the other point, though we are supposedly sharing the same species and the same use of the antivenom, but we give way more doses than how much.
Maybe you have other new species which are not covered.
That is
So
what is.
Depend. So I'm sure, if you like in Oman, they know which types of snakes available in each area.
We know.
It's available there.
I don't think you exactly know what exactly is there. Nobody knows exactly what's there.
Well,
I mean, we know historic data,
Universities,
anecdotal data.
I think in universities, this thing they have data.
We have good data on the type of species that we have in the country.
Not published.
It is there. Maybe not published, but it is there.
The WHO don't have it. Even as grey, they call it grey data, which is unpublished, I mean governmental data. It's not there.
It is available.
But, okay.
But there isn't any specialized herpetologist in the area?
There is.
Yeah, so they know.
They would know.
There should be, like in Lebanon also, there is one only few published, but there is a good
Yeah, Ashraf, this is another problem in the MENA region. Data are there but not published, and we do not have access to these data.
No,
but I'm sure if you will look, you will find it.
I will show you the slides. They will show published. They have everything.
Yeah, because they will check from where they will have their data.
Governmentals. They go to the government.
No, I don't think they will have it
So
from.
WHO, let's be clear, WHO, they don't go governmental. WHO, they go to Ministry of Health. And
Yeah,
we
Ministry
have-
of Health is the government.
No. It's different there. So the one who's taking care of this,
Universities.
responsible for this, is Ministry of Agriculture or Ministry of
Environment.
Education
Or education,
or
universities.
environment or universities. It's not-
Universities, snakes.
Yes.
Yeah.
So it is not the Ministry of Health. It's the College of Science in the universities
Yep.
usually, and that's the situation we have there in Oman.
Yeah.
And so WHO are basically reaching the wrong agency to get the information from. And most of the time there is no much collaboration between the two. So even if you are approaching the Ministry of Health and assuming that the Ministry of Health will get you the information, they will only provide what they have, but not what the others have.
Interesting. I didn't know that.
Yeah, so you cannot rely even on the, I mean, WHO sent the guidelines about the management of snake envenomation. We don't use it at all because it
Because that's
does not
African.
reflect.
Yeah.
It does not.
Yes, that's African. Well, at least I talk from experience in North Africa. We don't know what's going on.
See, in today's
No.
date and time, if we say that I'm talking from experience, which is unpublished, nobody
Doesn't-
would believe.
Yeah.
Doesn't stand anywhere.
Yeah.
So I think the first step, forget the collaboration, go back to your own hospitals or your institutes. If you have a poison center, start making a local snake bite registry. What you can do at MENA Talks is make it similar. you know.
Yeah, so that's what it should be, and then you have that collective.
If you say that Minotox has made a snake bite registry, then you will have to go through the whole ministry setup and get permissions to
We're not going to do it in that formal way. We're just trying to.
What I'm trying to say is that you start doing it individual levels, start collecting the similar kind of data,
exactly,
and
but
then
that's
share
the
it
collaboration we're
at
talking
this.
about. Yeah, that's the collaboration we're talking about. Is to have it in different area, whatever, whichever way it's going to be, and just try to start to collect.
And it won't be a bad idea if you are making a workshop on envenomation to invite your herpetologist who has actually seen the snake, because they would have a reasonably good idea what are they dealing with.
I think so the herpetologists that you have in Oman, Badriya.
Yes.
So do you use them a lot? Do you?
When we have difficult cases, like we don't know exactly what's going on, and we have the snake, we do contact them to identify the snake.
So keep those snakes preserved if you can. Make a museum, keep those snakes preserved, whatever you can get, because that will help you.
So
Is that right what I'm saying?
Yes.
Because if you keep those snakes preserved, at least later on it can be used to teach, show the clinician, what you see on the picture sometimes, and what you see real snake may be a little different.
Yeah.
Do any center or any one of you have already a file to collect the data?
Yeah, I do.
Do you have?
I do. I'm using the.
Do you have? We have Badriya?
Data
A file to collect the data.
Like a database for snake envenomation.
Yeah,
So
a file to collect the data. maybe we can take all the files, compare them, and make a common file, and send them to everybody, so that everybody has the same kind of data.
Same kind,
Yeah, so that's what we will.
And then we can start.
Yeah. So I think that's what we should start with, is to unify
Yes.
the form to collect this data.
The sheet of the
The
data
sheet,
to
that's
collect.
correct.
So I think somebody has to collect all the sheets and make it.
And then look at them. And we can do it in a year, we can do it on a regular basis. We can create it.
Whenever you meet at Minotox.
Actually, I found a nice article recently published about all the terrestrial medicines in the Middle East and toxicon. So it combines all the different areas in the Middle East, and it's an excellent article that I found through ResearchGate. I told him, can you share, because he cited my article. So, and they talk about different, like Oman, like in Jordan, like all the different areas.
But this is not based on.
Right.
The article was written by actually people from the UK and Jordan, by Zuhair Amir, Hamad Abu Bakr, and David Warren. And it was published in Toxic in Health.
When was it published?
It was just published actually.
Is
2020 now, and I asked him to share the article.
And do they have a list of parameters to collect? Or
everything.
No?
I mean, they have literally
I mean, that
a lot of all the
was
countries.
Yes.
All with pictures with antivenom from where they're getting it, the complications even. In certain cases.
So that's a theoretical.
Theoretical.
Yeah, I got
Very
it.
interesting.
David Warren, I met with him in Australia. I don't know if anybody knows David Warren, please. You know him,
David Warren.
David Warren. You know him.
Who's written this article?
David Warren.
David Warren.
The person from Middle East,
Jordan one.
Is he a physician? Is he a herpetologist?
The biology department and the Department of Biological Sciences. So I would think he's a.
So he's not a doctor, most
herpetologist.
likely.
So that's what that's the point I'm trying to make.
Yeah.
No, but I think Bruno was right on the spot. this is a theoretical.
It's a theoretical
view.
Yeah.
It's not based on
data.
But it's
There's
based
no
on
data.
the published articles and data from other places. In
There
other
is
countries.
no
For
much.
example, I published about Lebanon all what we know about our snakes.
Yeah.
And then he used
Lebanon
from
you have.
Lebanon, and he used similarly from different
I'll
places.
tell you example. I'm
and
not
then-
trying to there is no data. There is no data. I'm telling you. Lebanon you have, and I know you have, and I've read your article. Saudi Arabia they have. Oman they have they have some. The rest is nothing. I mean, so that's the
See,
issue.
the point which I'm trying to make is, you are a clinician, I'm a clinician. If a person comes to me with a snake bite which is resembling viper bite, I'd say this is the viper bite. And that's it.
It's correct.
Right? I haven't seen this snake. What viper? You know, why I'm trying to make this issue is because we believed for donkey's years that we have only 4 toxic snakes. But now we have found that there are more.
Interesting.
You know, there are at least 4 more toxic snakes and we have no antivenom for them.
That's probably tally with what's.
That's what she was trying to say, that we end up with patients who have persistent coagulopathy. We will still label it as viper. So when we publish it, it will get published as viper, and somebody who quotes it will quote it as viper. But what kind of viper? That is where the herpetologist would come in and tell you, you know, what kind of snakes are prevalent in that particular area.
I understand.
And then you go from there. What do you think?
Yes.
I'm right, because if I write neurotoxic and I write that it is cobra,
look,
it'll get recorded in the medical sheet as cobra. It will be cited as cobra.
But
It'll just go as cobra everywhere.
Yeah, but
maybe it will be like cobra is causing coagulopathy.
Yes, but you need both. But you need
that's
both.
what I'm trying to tell you. This is the problem.
No, but you need
With
both.
the physicians,
You need both.
You need both.
You need the
That
clinicians and you need somebody.
You need both, but you need someone who will identify what snakes are.
Yes.
We had Ian Simpson who worked with us on this project, and Bob Norris from Stanford. So they went all over the country. They didn't only meet the physicians. They went to the villages. They met these snake charmers, these snake catchers. You know, looked at what snakes were. And then they came out that there are more, which you don't know.
So I think the next step now is, I think what we do, we will start with this data sheet with Ria and the guys. We start with this data sheet. And we send it and people start to collect. And whenever you have the opportunity to ask a herpetologist, get him to identify or take a picture.
You can take a picture also if you have a dead snake and you
Not
can't
smashed.
store it.
Not smashed snake.
No, even
Even
see
if
for
it's
them,
smashed, they
even if
can-
it is smashed,
Listen, listen, listen.
even if the head is smashed,
No, no,
they can
they-
identify
they
by
probably,
the
yeah.
scales. So if you have a good picture, they can sometimes, but obviously if you have a snake in front, then it's better.
But we have to start from one point.
At one point.
If we don't start,
You
I
just
think,
keep discussing.
We'll be at the same point next year. So we have to start.
One of my
I think the easiest is to start by sheet.
and
So maybe you, Ashraf.
I will start it and I will send it to everybody to
everyone.
edit it. I have it, so I'm just going to send it to you.
Yeah, but maybe first all the people can send you their own sheet.
Okay. Okay.
You
But
have
Ria,
one
do you want to
in
send me
Lebanon?
yours?
You have one sheet to collect
The,
that?
the sheet. Saudi and
We don't have across all Lebanon.
But you have one used.
I have one with a person in our center.
Okay, can you send it to Ashar?
Can you send it to me?
Yeah, it's, I already, I have the article that it is.
Make an announcement.
Send it to him. So
Do you mind?
all will send you their own sheet.
Yes.
And then you can make a common sheet by taking all the parameters.
Variants, yes.
And then
Send
you
it
send
to
it to everybody. We criticize, we give our opinion, and
Yes.
we send it back to you. And then you
We
make the
start-
final version and you send it to everybody.
Yeah.
So that
collect data.
yes.
So the ones that, I know it's limited because one center, but this is was done in collaboration with herpetologists, which is the best one in Lebanon, and he knows about all our like spiders or snakes or lizards or so.
No, probably it's good, but he has to say it's applicable everywhere.
Correct.
That's the important thing, what you just said, applicable everywhere. Now, if you write that you want to do some fancy coagulation parameter as a data collection, may not work. So you need to know what is available where and what can easily be done across the board. So that is again important.
Yeah.
Let's say somebody says thromboelastography for every patient who comes with coagulopathy. May not be available.
No. It's true. Just not,
Okay, so it was a good introduction.
That's a very good introduction, actually.
So now we can maybe start different lectures, make them more interactive.
So we'll make it, so how 20 minutes?
Yeah, take your time.
So welcome everybody, just for the snake information. This is the second year we do this and hopefully we'll carry on doing it. Every year it's an important issue that's not only in the Middle East but worldwide, as everybody probably aware. That there are more than 3,000 species of snakes, 250 are of medical importance, and WHO classified them of category 1 and category 2 based on whether they are high or low venomous snakes and the encounter with human and the effect that they cause on human category 1, category 2. And as just we tried to discuss earlier, the Middle East in somewhere between, every country have between 4 and 9 medically important snake species. So we are not as bad as Southeast Asia or Sub-Saharan Africa or South America, but nonetheless, we have our own share of bad snakes. So in terms of the types of venomous snakes, I'm going to concentrate today on the lapid and vibridii because this is what we have mainly here. So the elapids, as you know, the cobras, the mambas, the coral snakes, they're typically neurotoxics, but not exclusively neurotoxics, short front-fang snakes. The vibridii, they have two, the true vipers and the pit vipers, shallow, long, hollow, long, hinged fangs that inject and withdraw. They are commonly necrotizing, hemotoxic, and anticoagulant. However, you do have anticoagulant, necrotizing, and hemotoxic, but you do have the neurotoxic ones, example, the Mojave rattlesnakes. Sorry. So, in terms of just a bit of definitions, the venoms is a mixture of toxic proteins and peptides, and the toxin is a pure toxic substance with natural origin. Snake's venoms is a product of protein synthesis, and it's a mixture of enzymes and toxins. And there are about 20 types of toxin known, and there are so many unknown yet of toxic enzymes. Some of them are very specific. They go and target specific areas in the body, and they don't touch others, while others have effect on different areas. And it's so the snakes. So the function of this venom is three things: acquire the prey, digest the prey, and defense against enemies. So this is extremely important because in no way in the evolution of the snake that the venom being produced to cause consumptive coagulopathy. That does not serve the snake purpose in any way, shape, or form, because what you need, the snake need if you need to kill, to eat. So the effect of that hemotoxic effect of the snake bites, compared to on a small prey like a bird, it's completely different from a bite on a human. The effect on a small prey is sudden thrombotic effect that will kill the prey instantly, while in human it gives you consumptive coagulopathy, which will carry on for days or hours and days. So the effect is different. So that's that we need to understand. The other things which is important, like some classifications, we say elapids are neurotoxic and vibridiaes are hemorrhagics, which is a completely wrong definition, because some elapids have both local local toxins and hemotoxics, and vice versa. Some of the vibridiaes have neurotoxins. So the notion that elapids are neurotoxin and vibridiaes are hemotoxic, hemorrhagic is a completely inaccurate classification. So neurotoxins mainly are elapids, but as we said, they are in the vipers, like the Sri Lankan Russell vipers and some European adders, the multiplayer snakes. They have neurotoxins, and it's very unique. It is very important to understand what sort of neurotoxins that you have in your region, because the management is different. Because of the mechanism of action is different. So if you look at, so we have two types, either presynaptic neurotoxin or postsynaptic neurotoxin. So the presynaptic neurotoxin, which is mainly phospholipase A2, and the postsynaptic, which is mainly polypeptides. So talks about the presynaptic neurotoxin. What they do, they come attached to the presynaptic membrane, enter into the cell, damage the synapses, release the acetylcholine, causing a surge of acetylcholine, depleted, followed by paralysis. That process is irreversible. As soon as it starts and the damage happens, it is, as much as you give antivenom, it's not going to work. And you just need to wait for the axons to start to repair, which just takes days, weeks, or whatever. In reverse, the postsynaptic, they block the receptors on the postsynaptic membrane, so they stop the acetylcholine from working. So displacing the acetylcholine from that receptors will give you a recovery. So giving antivenom, anticholinesterase, which some people try, will help, is a form of a treatment. So that's an extremely important distinction that one has to make when looking at the neurotoxins. So presynaptic neurotoxin usually take more than an hour to develop by the toxin to reach the motor in the plate and start to work. And as we said, this is the damage cannot reverse. If damage starts, you can't reverse it. And good example, your crates, your tiger snakes, and taipans. The postsynaptic neurotoxins, which you're mostly talking about the cobras, they are polypeptides, bangarotoxin and cobra toxins. And as we said, they attach to the postsynaptic membrane and they block the receptors. You displace them, you get some recovery. Now it's been, I don't know from experience of the panel here, but it's been postulated that the paralysis you get with the presynaptics tend to be worse and more severe, and probably that has something to do with the way that they damage the synapses completely. However, there's published data now with the cobras that there are life-threatening paralysis has been documented with the postsynaptics neurotoxins. There are other two types of neurotoxins, dendrotoxins and fasciculins, and a good example for those is the mamba, the black mamba, the African black mamba, where they work synergetically. So the dendrotoxins will do the presynaptic effect, they will go into the cells, they damage the synapses, they release acetylcholine. And the fasciculins will block the anticholinesterase, so the surge of the acetylcholine will continue, and that will give you the paralysis. It augments the paralytic effect. There is the Taiwan, the Chinese branded crate, has a unique neurotoxin. Anybody knows what is it? It has both the pre and post-synaptic neurotoxins. And this is a unique thing for the Taiwan branded crates, or Chinese branded crates. Time of onset of paralysis, as we said, it may take more than an hour. It usually starts with tingling, numbness sensation, then the cranial aid first to start to get affected. Bit of ptosis followed by ophthalmoplegia. 6 nerves usually start to affect first, and it progresses from there on. And then it starts to lose your reflexes, and you start to have respiratory depression, and death. And this is the best example how so it started with your ptosis, your ophthalmoplegia left the 6th nerve palsy, faceless or expressless faces, and then fixed dilated. So that's pretty much about neurotoxins. Then you have the myotoxins. And the myotoxins, you have the two types. So that you have the local and you have the systemic. Systemic is associated with potential, it's devastating and lethal. And the locals, it works on different effects. Before that, we ought to say not only skeletal muscles get affected by myotoxins. Although smooth muscles very rarely get affected, you have the cardiotoxins. There have been documented cases of severe cardiotoxicity and cardiomyopathy following snakes and venomation. Though it's not clear whether that's a direct effect or indirect effect of being sick and etc. Having said that, so there you have the local myotoxin and the systemic myotoxins. The local myotoxins, the most important, the snake venom metalloproteinases, which we're going to talk about later, which have both direct and indirect effect. So it causes damage to the muscles by this myotoxicity, plus the edema and the ischemia surrounding it, and the hemorrhagic effect on capillary leak. It will give you the indirect myotoxic effect. Local myotoxin cause damage to the basement membrane. The systemic myotoxins, they don't do that, and there is some differences, and we'll show you it later how that's important. And then you go to the systemic myotoxin, and there are two types here. The ones which are pure myotoxins, they go systematically, but they don't affect anything else apart from the muscles. And the phospholipase A, which affect both. The presynaptic neurotoxin also have an effect of the muscles. Now, it's been postulated that the pure myotoxin is more associated with more severe rhabdomyolysis and muscle damage effect because the presynaptic, the mixed, they have the diluted, the acceptors of the enzyme, the enzymes are different, so and they don't cause damages on other organs or other tissues, so you get a diluted effect on the muscles. Not sure how true is that. So chemical types of myotoxins, we said there's some cardiotoxins, the phospholipase A, and non-neurotoxin myotoxins. Not going to dwell too much on that. And this is an interesting slide. Tiger, I think. Yeah, a tiger snake, phospholipase A2, injected into a rat's skeletal muscles. After 3 hours, the damage, 24-hour transverse section, and 24-hour longitudinal section. Yeah, so we discussed this, that some of the myotoxins, they don't specifically attach to certain acceptors, and attached to many acceptors, but the damage only on skeletal muscles, acceptors or receptors, and you end up with a systemic muscle effect, but that not necessarily a severe one. The ones who are attached specifically to certain acceptors on skeletal muscles, they tend to cause more systemic effect because of the concentration phenomena. With systemic effect, the basic membrane remain intact, so regeneration is muscles can occur. However, you get a regeneration only of slow twitching muscles, and this is an effect of, see, the long-lasting effect of the systemic myotoxic of snake bite. And when we talk about myotoxins, we talk about rhabdomyolysis, which can be severe, very, very severe, and end up with renal failure, hyperkalemia, etc. And the long-lasting effect of muscle wasting if the inflammation was severe with systemic effect. Urolipids, many Australians, licked crates, sea snakes. Do you see Ashish in India?
Sea snakes? No, we don't.
No, so your crates, do they cause myotoxicity?
No, we haven't seen any myotoxicity with crates.
No. The vibridii, some Americans, rattlesnakes, or American colleagues, myotoxic effect is a lot.
You see it, yeah. You actually can see myokemia with lots of the, even the non-Mojave rattlesnakes.
They do?
Yeah, and you see muscle breakdown. CK goes up all the time.
Yeah. Talking about the hundreds of thousands of snakes.
What was that?
The CKs.
CK goes actually in the tens of thousands, not
Uh-huh.
hundreds of thousands.
Okay.
It's not as
and the
severe.
long-lasting, is there the systemic long-lasting disabilities effect of muscle wasting?
Very few chronic effect that we see. There's some local effects in terms of if it's your fingers, toes, you see some waste is there, you can see some.
But that's
local
most of
damage.
the probably a necrotic effect.
Yeah, it's not, and very rare you see like neuropathy here and there because post-acute inflammation.
Yeah, that's correct. Okay, interesting. So the coagulopathy, and this is the interesting subject. And as I was saying earlier, the snakes in their evolution, they did not intend, the evolution did not bring them to the point that they wanted to cause coagulopathy in their prey. It does not serve them any purpose. The effect of the same venom on the small prey is completely different on a human. They wanted to paralyze the prey and get it eaten. They're not interested to let it go for bleeding for a day or two. So your consumptive coagulopathy, thrombotic, anticoagulant, antiplatelet, and direct hemorrhagic effect. And you can find a single venom, single toxin which has two different effects and it's augmented its action. We'll talk about it in a minute. Most species have hemorrhagic effects, hemorrhagic toxins. So, for example, the metalloproteinase prothrombin activator of the Acil species has also a hemorrhagic effect. So the concept started the concept of coagulopathy, that activate the prothrombin activators, that the coagulopathy, the consumption. Meanwhile, the hemorrhagic cause the damage to the blood vessel wall, give you a shear stress effect, and that will augment the bleeding. So you get worse bleeding. And in a study, they compared the efficacy or the potency of the prothrombin activators of the Australian elapid and the Acil, found that the potency of the prothrombin activators in the Acil is much more potent than the Australian. However, the bleeding is worse with the Acil than with the Australian elapid, and they put that down to the effect of the augmenting effect of the both the consumptive coagulopathy and the hemorrhagic effect. It used to be called BIC, which is wrong descriptions, And it's basically that you activate the coagulation cascade to the point that you consume all of your coagulation factors. And you have 3 types of activators, the prothrombin activators, the factor 10 and 5, and thrombin-like enzymes. And you end up into that circle until you consume all of your factors. And it's give you somehow clinical, biochemical picture similar to the IC, but it's not the IC, because as you know, the IC is associated with multi-organ failure and it's associated with much worse prognoses. So we've discussed that earlier. Don't want to go through it. Now, anybody has any experience using point of care INR for snake envenomation? I don't know. It's just interesting to mention it here. It should not be done in snake envenomation because of the fact, and this is proven. There's a couple of studies on this. Because of the fact is the laboratory tests on INR test the clot formation. So you get the blood, you get the plasma, you add to the tissue factors, and then measure the time to form a clot, and that's what you need. But when you use the point of care, it will give you. They will add the tissue factor, and then they will add a substrate, electro substrate, something substrate. And then they see the cleavage, the thrombin cleavage of that substrate, and they measure that. And that's the wrong way of measuring INR in this situation, because thrombin is always there. But you don't want the thrombin, you want the clot. So it gives you a wrong reading, and it tells you it's normal, while it's not normal. So point of care of INR is pointless. Sorry to mention that. Well, I thought it was a bit of an interesting point. Although you might be bitten by snakes as hemorrhagic or hemostasis effects, not all of them can give you the clinically significant bleed. Some of them get unseen. And this activity of the bleedings might cross over with the necrotic effect, the cytotoxic effect. You get bitten here, there's some necrosis, you have direct effect on the blood vessels and start the oozing. And as soon as the systemic effect of coagulopathy or the antithrombotic or the antiplatelet aggregation, you start this get worse and worse. In terms of necrotoxicity, not well understood. But it probably is related to phospholipase A2 and the metalloproteinases, which has several reaching effects, so we're going to discuss briefly in a minute. And also the secondary effect. It used to be thought that the necrosis or the local effect is not of a significantly clinical importance, but that was, again, a misconception. It has a major devastating effect on the life of the person who's getting bitten by venoms, which has a local necrotic effect, not only from an immediate clinical point of view, where you have fluid shift and you have hypotension and shock, infection, which can be devastating. You end up with severe morbidity and mortality. And for these areas where the most snake envenomation happen, these people are manual laborer, and any form of disability is a devastating effect on them on their family. So, and as you know, there are several snake species who are linked with local injuries, and that span the whole 4 species that we have. So the hemorrhagine metalloproteinases, SDM, there are 4 classes, and the effect is they have a wide range of effects, some of them locals and some of them not local, and it is in a way, main effect is to immobilize the prey and digest the prey. And another interesting fact is that the The vipers and culprits feed on what they call type 3 prey, which is big and heavy bodied. So they need an enzyme which can digest the prey. So they have a large, they have prominent SVMPs in their venom. The elapids, they usually tend to feed on elongated low volume surface to ratio. And for that, they don't need to a potent SVM to digest the prey, so it's not a prominent toxin. And we talked about the effect of the CMV. They damage the basic membrane, cause local hemorrhage, shock and secondary effect, ischemic change, and direct and indirect injury. I think finally the renal toxicity, again, there are some renal toxins, and it's been proven that there are some renal toxic enzymes. However, from anecdotal evidence and from some literature data, the most prevalent is a secondary effect because of the shock, the infection, etc. And the pathology is varied between acute tubular necrosis to bilateral cortical necrosis in severe envenomation. I don't know if we have a Turkish, no we don't, so just for interest for the people here, they have in Turkey, they have mainly the vipers. I think they have 11 vipers types, and they have the one cobras more than there's a cobra. In terms of the vipers, the procoagulants and hemorrhagens, that's the main toxins, and their neurotoxic is postsynaptic neurotoxic. Just the last couple of slides, just what to tell. This was not intended for you guys, it was intended for general physician or AR physician, but just want to tell them not every bite is a wet bite, not every bite is going to give you inflammation. There's some studies suggest up to 80% of soft-scale viper envenomations are dry bite. And there's a lot of various reasons why can that happen, so not every bite has to be given antivenom. And unfortunately, for our colleagues from the West, the cultures in the Middle East and here is, when a patient comes, you want to do something, and you show the family that you're doing something. And this is huge impact on the decision making for the doctors. So when somebody comes with snake, to come to the family and give it to teach them, oh, this is a dry bite, it's nothing, we'll wait and see. You are unlikely you're going to get somewhere with that. And if anything happened later on, it's not like you've evidence-based your decision. You made a mistake. And that has an influence on decision making. And I was with Badria just recently in the emergency, Society of Emergency Society, the Emiratis one?
Emirates Society of Emergency Medicine.
Yeah, we did a track on toxicology and we talked about envenomation. And after that, 3 people came to me, 3 doctors who works in the peripheries of the main cities, and they told me that they had same experiences, copycat. Envenomation, dry, no symptoms, whatsoever. And all 3 of them, they gave an antivenom. All 3 of them. And then I asked them, all 3 of them, and then I asked them, I mean, I just tried to elaborate, and they all say the same. It's a family pressure or something down that line. So it's a way to go. I think we've discussed this. I don't need to dwell about this too much. Anaphylaxis, that's a very important aspect that can happen with any snake inflammation, and the management is following your SELS, and it is a feature of systemic inflammation and its indication of antivenoms, a topic which Dr. Ashish will talk to us about it. Thank you very much.
sure you don't have any question. I'm sure you.
Just going to kind of some of the slides I'll rapidly skip through. Touch our life in Southeast Asia, every possible way. The worship as God in India, and yesterday was Mahashivratri, where you worship actually snakes, right? Source of living for many, food for many, wine, and then lots of movies. Right now, currently, the #2 ranked serial in India is on a snake, right? And then there is fashion, jewels, and tattoos, and pets. And this is me.
Someone is holding it.
Much younger.
Much younger.
Yesterday.
And the deadliest animal in the world is human. So, this is a person who was a priest in a local temple. Probably had developed immunity because he was maybe bitten again and again and again. But why did the cobra die?
Nobody knows.
Nobody knows. These slides you've already seen, so I'll not show them again to you. Know about what are the 4. These are the major snakes in Southeast Asia: king cobras, vipers, common krait. This is what I was talking about. This is a hump-nosed viper, which we see. This is Pangarus sindanus, which is mostly common in Pakistan, but in some parts of Rajasthan you see these snakes. And we don't have venom against them. Now this is what you were talking about, dry bite.
Yes.
Do we ever document a dry bite? I have not seen a dry bite till date. What do you mean by dry bite? Is that you have a person who's actually witnessed bitten by a venomous snake and does not develop any.
Yeah.
Since I work in a tertiary care hospital, most of the time people reach me when they have something. So what you were talking about was that people who are practicing in the periphery,
that's correct. Yeah.
they would be seeing most dry bites. And this is a wonderful article. I don't know if you have seen this. No envenomation, no local silent symptom. That's dry bite.
We see this in Europe.
You see it
we
in Europe
because I think people go to the emergency as soon as they're
yes.
So we see.
So this is a review article where they have reviewed the complete literature and say that there could be a natural immunity, there could be absence of venom in the gland at the time, it could be a diseased venom gland. The fangs may be broken, or there could be a mechanical failure. And then one of them was, one which is not here, is that maybe the snake misjudged the distance between the victim and has probably already injected it somewhere, and the second time when he bites, it's a dry bite. So what are the problems? Identification, first aid, definitive management, and the supportive treatment. I don't know what happens with you guys. In India, this is the problem. At the time of monsoons, you have these kinds of growth all over. Their burrows get flooded and they come out in big numbers. And they enter your home in search of food. They are not interested in biting you because they can't eat you. You get accidentally bitten because you are in their way. Right? So this is, we see majority of our, I'm going to present that in the EAPCCT meeting, majority of our snake bites are within 3 months. And that's it. It starts at the onset of monsoon, with the end of monsoon, it's over. And we don't see any snake bite in between. Occasionally...
In the tertiary center, but in the periphery they still see.
I have not any idea because most of the time they are referred to me from the periphery. So if they don't see it there, they won't send it to me. Very occasionally we get some viperine bites or cobra bites in the winter time from the handlers, not general public. General public is monsoon.
So that's interesting because we in Arizona also have monsoon.
Yeah.
Actually call them monsoon. And we don't see a correlation with that. As a matter of fact, our season starts around mid-March and goes to about October.
Wow.
And the peak of activity, snakebite activity, is peak when we see people going outside performing, which is not too hot. And usually people don't go out during the monsoons and right after the monsoons because of humidity. But when it's nice and warm but not too hot,
then they get it. Okay. Now the first principle is identify your susceptible population. For us, it is males, rural more than urban, workers in the field. Most of the times, in one study from Bavaskar, most of the times the people who are harvesting time, that's where you get bitten. You either get bitten on your left hand, and he showed at one particular meeting that he got in an hour's time 3 women who were harvesting, and all of them were bitten on the left. Because what happens is when you grab the wheat or rice and you want to cut it, so you end up grabbing the snake or touching the snake, and that's why your left hand, with the right hand you are kind of, so you need to identify. For me in Chandigarh, it is this: construction site workers. Most of the times, because they have they are staying in small makeshift rooms and no doors, no nothing, they're sleeping on the floor, and in the monsoon time, the snakes also want to come out and be on a dry land, and that's the dry area, the floor where they are sleeping. So that is where they get, or workers in the forest. We don't have any big forest nearby. Sometimes we get from the forest in Himachal victims, and that is occasional victims during the other times.
so that's interesting because I just reviewed about 1,000 envenomations, recent envenomation. In the U.S., it was sexy. What I call trash bias gets replicated all the time, and it was we had this derogatory 7T, testosterone, intoxicated, tequila, nonsense, really. That because it was sexy, everybody reproduced it.
Yeah.
I looked at our data, and our data shows that these are people who are doing landscaping, golfers, gardeners, hikers. So ours is also, to a large extent, people who are doing what I call industrial activity or work activity, and then leisure activity. I actually presented that about 3 years ago it was in Dubai. It was the International Society of Occupational Health. Had that conference we presented. But in the U.S., the same trash gets recycled and regurgitated all the time.
But we have a lot of our army in the area, which is dealing with, and it's if you know the Maoist area, the right-wing area in the eastern part of India, lots of forests there, and the terrorists are hiding there. The police and army is behind them. So all three get exposed. So all three
the terrorist comes to your hospital?
We treat
I'm
it.
a terrorist.
Well, we see, I don't know who you are, right? If you are here with me as a patient, I have to treat you. You might be a terrorist, I don't care, right?
They don't have a bandana, say I'm a terrorist.
Now this is again which is very important. I think when you're making a sheet, you should know this, that you need to include comorbidities. Most of the time the armies, the policemen, they are active people, they do not have so much comorbidities. Construction site workers, who will work at a construction site? A person who is healthy. A person who's got diabetes, hypertension, coronary artery disease is not going to go and work there. So, but if you have comorbidities, that this is again important, the part between what we looked at, our data, that if you get bitten on the foot or on the hand versus you get bitten on the ear or on the scalp, you're likely to have more severe inflammation, right? So this is what we realize, that near the face, you're likely to have more severe inflammation. Then you have individual sensitivity, the species, and then the secondary infection. What kills most of the patients with viperine bite is not the bite itself. It is renal failure and it's the secondary infection. Principle number 2, snake identification is difficult. You try to identify snake whenever it is possible. They run away, they bite at night, so people, they get killed, crushed, so sometimes, but if you have a snake which is brought to your ED, preserve it. Preserve it and send it to a herpetologist or maybe a picture to them.
Have you had somebody brought you a live snake?
Yeah, we've got. I'll give you an example. There was this guy who came in, had classical symptoms of envenomation, and said, "Did you find a snake?" "No, I didn't." Like, okay, want to? He says, "Just some itchiness here." He took off his vest, and there was the snake there, live snake in my ED. It was a small snake, crate, and it was chaos. Everyone just ran here and there.
It's great, the worst thing.
Yeah. So clinical toxidromes sometimes do overlap, and venom assays we don't have. I don't have a venom assay. I don't know whether you have a venom detection
Australia, I don't know if in America they have.
In
Australia, I think they only
Australia they have venom detection kits.
Yeah.
Right? I'll tell you why we can't use venom detection kits, or very limited use for us in our. This is general symptoms remain the same. Viperine bites, you may have cardiovascular effects in the form of arrhythmias sometimes. Bleeding, clotting disorders have been already talked about. This is the picture which was again shown. I had a picture of a real patient, a video of him, but the thing is my laptop crashed, so I can't put that, so I picked up. Now this is sometimes one of the manifestations of viperine bites, and it doesn't progress beyond that, right? So if you have a kind of Russell viper's bite, having neuroparalysis,
Yes, it does happen.
but it does not, it just goes to ptosis, and it does not have very severe respiratory paralysis as compared to the crate and the cobras, which cause very severe respiratory paralysis. This we have already seen. This happens with Russell's viper with us quite a lot. This is what we published. I don't know if any one of you ever read this paper or not. We published it in endocrinology, that in the chronic phase following a Russell's viper bite, there is something like a Sheehan syndrome which these people develop. It's initially a hemorrhage, and then they go on to develop these kinds of manifestations. So we did a study over 3 years' time, collected all kinds of viperine bites, followed them up, and found that there is a definitive evidence of a pituitary dysfunction. So if you don't have the venom detection kit, if you don't have anything else, how do you identify? What we use is this: paralysis, severe local envenomation is, or necrosis is, cobras do cause tissue necrosis, and severe local envenomation with descending paralysis. This is what I see every day. Every day. You know, very interesting thing. I walk into the ED one day, and there's this my resident talking to a family, saying that we can't do anything for this guy. He's brain dead, right? And I start talking to him. I said, "What's happening?" So this guy slept at night. In the middle of the night, he wakes up with severe abdominal pain. vomit. And the wife says, maybe you've eaten something which was not gelling with your GI tract. So go back to sleep, gives him something and goes back to sleep, never wakes up in the morning. So this patient had dilated fixed pupils, no doll's eye, cold calorie negative. And they were sending him home, that this guy's brain dead. So hold on, give him anti-snake venom, put him on a ventilator, and 96 hours later, he walked out of the emergency. So a person who was declared brain dead was not brain dead. He was just having severe ocular paralysis. And that's why you were not getting anything which was, his brain was intact. Nothing wrong with his brain. But if he was not given ventilation, he would have died. And it would be hypoxic kind of death. We had one death in hospital in a crate bite victim. We ran out of the ventilators, so we were giving them manual ventilation. The person who was doing that fell asleep for 2 hours. And that lady went on to develop severe hypoxic damage of the brain. She was put on ventilator and things like that. She never recovered and she died of complications of ventilation rather than the snake bite itself. But she had suffered, we had an MRI done, she had a definitive evidence of hypoxic brain damage.
So, Ashish, are they bringing you the patients then within a period of time?
I'll come to that.
That they're not hypoxic?
No. Rhabdomyolysis, I'll talk about that also. Renal failure, rhabdomyolysis, could be sneeze snakes, could be Russell's viper, shock, bleeding, coagulopathy, renal failure, and severe swelling. Local swelling is viperide, and then some amount of neurotoxicity may be there, as I said earlier. This is very important. First aid, what are the guidelines? Hardly any guidelines. This is a review article published in Tropical Medicine. It says definitive evidence is this: splint, rest and avoid movements. That's it. Just splint the limb. What is a natural reaction if you have somebody running after you? You run. What is the natural reaction if somebody bites you? You want to get away from that place, and if you know it is a snake, you want to run as far away as possible. When you start running, that's when the damage starts happening. So you have to splint, rest and avoid movement. Now this is pressure immobilization is written here, but you have to be very careful. You don't want to very tightly tie a tourniquet.
Because just for your colleague, in America, that's no.
What?
The pressure embolization.
Yeah.
It's a no.
No, we still say, but no tourniquets.
There's a position statement.
No tourniquets.
On pressure
Because
embolization.
tourniquets can cause.
No, even pressure embolization. This is the Australian one. In America, they have a position statement.
Yeah, we don't do it.
Because of the local necrosis.
Yeah, I'll talk about that in my...
Yeah.
So then there are these two new things: topical nitric oxide inhibitor and trypsin injection locally. But there's, as far as possible, don't do anything in the field because you don't know what you'll end up with, right? Why I was telling you it is important to involve the herpetologist and know this is the data which has come from India, from the snake park in Chennai. Now they milk these snakes and they find out how much is the maximum amount of venom which is there, after a week or after a month, whenever they milk them. So you find that Indian cobra, it is 60, common crate is 20, Russell's viper is 63, and saw scale viper is less. So maximum around 60 milligrams is with cobra and viper. Why is that important? It's important because when you want to devise your anti-venom properties, you need to know what exactly you want to give and how much maximum. Although the fatal dose is just 12 milligrams and 15 milligrams. But you want to neutralize what the snake can inject maximally. And that's where your herpetologist will tell you. And then you can decide, based on the calculation, that how much of venom would 10 ml of or 1 ml of your anti-snake venom neutralize. So that's how you make the calculation regarding the doses. So Indian snake anti-snake venom against cobra and against Russell's viper, 1 ml will neutralize 0.6 milligrams. So if 1 ml neutralizes 0.6 milligrams and you have 60 milligram as the maximum dose, so you need to give nearly 100 ml. That one vial is 10 ml and you give 10 vials. That's the way calculation was done, right? But you need, this is known. This is known, but what the snake has injected, until unless you have the venom assays and the venom levels, you'll never know. So if you have a venom assay, and if you know that how much is the circulating venom present, you can titrate your anti-snake venom dose. If you don't know that, then you need to make calculations based on what can maximally be injected. So that's how our treatment protocols have been devised.
How do you calculate the fatal dose in human? How do the lethal dose in human?
There is the 50?
This.
How they will
Well, it's extrapolation.
It's the extrapolation.
Extrapolation from.
They have not done the venom analysis. This is just the extra. What is known is this, and what is also known is when you make your anti-snake venom, how much of 1 ml of anti-snake venom will neutralize. Now you have this much, but you may not inject that much per person. But when you are giving anti-snake venom, you need to cover. Again, this is a normal, natural kind of a snake which has been reared in a snake park. Now, if this snake hasn't had a meal, if it is dry weather, then the venom would be far more concentrated. Right? So you get that. So the
venom content is actually both the content and the amount is different in the wild type versus the capture.
Yeah,
I've known that for a long time.
Yeah,
and I agree with you in a sense that if you don't have anything else, this is. But if you have clinical trials, you actually it's based on severity and what really happens in humans that you can determine the dose of the antivenom. Or how many vials you need. This is in lack of having clinical trials. And I think we keep doing this to ourselves. We need clinical trials.
The problem with this kind of a trial is that if I don't know what is the venom concentration, how can I lower the anti-snake venom? Then it becomes a trial and error. I give one person 10 vials, 100 ml, and I give another person, 5 vials or 50 ml, and then see what happens.
Well, we do it in clinical trials based on severity. That's why we come up with trauma,
most of the
like ICU, we come with either snake bite severity scores or other clinical scores that will guide you. And then it's based on the practical activity rather than potential.
Okay, I slightly differ from you on this. We have cases who come to us early have just doses. We give them anti-snake venom, and within 2 hours or 3 hours, they go down to the, in spite of giving them 100 ml of antivenom, they're going down. And they go down to develop severe paralysis. Right? So,
but what's the harm, sorry, the question, but what's the harm of having that graded severity approach if you are
that's what I'm saying. So, if I have a graded severity approach, and if I say that if a person presents to me with ptosis only, I'll give him 5 vials. And if he has full-fledged paralysis, I'll give him 10 vials. I'm delaying institution of maximum amount of antivenom by a couple of hours.
But you're reducing the risks of side effects, you keep your antivenom storage.
You are weighing the risk and benefit.
You are weighing the risk and benefit.
And that's what you do also in clinical trials.
Yes.
Clinical trials are designed, and then you look at it and see whether your patients are moderate, severe, okay, mild, and you don't make the recommendations based on a mild. Right?
I'll show you the data again a little bit later. So, principle 5, whenever you get a patient in the emergency, reassure, use IV injection, look for respiratory risk. ABC is the airway kills first, right? So ABC remains always. You have persistent vomiting, you can give chlorpromazine. If you have syncope, shock, angioedema, you can give adrenaline. Give adrenaline. Clinical assessment, again, is something very important. How fast the swelling is progressing. The swelling starts within 15 minutes, but it may take up to 2 hours, right? This is very many times the patients are bleeding in their mouth. You don't even see that. You don't even ask them, until unless they bled enough and they're spitting it out. You won't even look at that. This is something which I haven't encountered too much. Regional lymph nodes. Although it is mentioned, but I don't.
I've seen it with the European ones, European other lymph nodes.
We see that all the time with the American crowdlet. As a matter of fact, some of the worst bites I've seen in terms of local effects is women who have gone under mastectomy and lymph removal. They actually have much faster development of a local effect than a person with the intact lymph node.
I haven't seen too much of sea snakes, so I don't know how much trismus and generalized muscle weakness, because we stay way away from the sea. This is what I was talking to you. Whole blood clotting time has its problem. But in a clinical setup, this is probably, we've done trials, my colleague has done trials on thromboelastography and measuring INR versus the whole blood clotting time. So if you talked about the point of care, we don't use point of care, use lab INR. And lab INR, if you can get done, is more sensitive. But as you said, that if a person comes to you early, may not have developed consumptive coagulopathy, may still be in the phase where the coagulation is going on and they, all the factors have not been consumed till now. So your whole blood clotting time may be normal in the initial phase of a viperine bite. That is what you need to repeat. You need to repeat it. So that's very, very important. Always examine urine for both hematuria and myoglobinuria, because viperine bites can also cause IV hemolysis, right? So that's antivenin, we all know this. This is what happens. 1 ml of antivenom. These are studies which have been done over a period of time, and 1 ml neutralizes 0.6 milligram of cobra and 0.6 milligrams of Russell's. So if it is 60 milligram maximum, you give 100 ml. These are the indications for giving this. This is very important, dose of antivenom. Now there are lots of issues with how do you dose antivenom. This National Snakebite Protocol was developed around 15 years ago with the help of Ian Simpson, who's a herpetologist, who talked to people all over India, looked at how much was the snake venom which could maximally be injected, and what were they doing. So what they said that if you want to neutralize 60 milligrams, you have to give at least 100 ml stat. Now you have to, what you said that the snakes which are inbred and the wild type may be different. So you reassess after 2 hours if the paralysis persists or increases. Well, there are only 2 snakes which can cause paralysis. That is cobra and crate. And if you look at the amount, 20 milligrams, right? So you need a much lower dose for crate bite. But you don't know. You want to cover cobra. Although we don't see local envenomation. So your point that you want to rationalize giving antivenom, could do a trial on this by trying to neutralize only 20 milligrams and not 60 milligrams, which would again be different dosage.
In your center, what's the average number of vials?
I won't finish? Okay. This is what I was telling you. This is what it is. This 2001, 900 ml.
The average.
900 ml.
Wow.
That is huge. 90 vials. Right? 2005 came down to 500 ml. Then they did a trial, the same group. They gave 150 ml in 28 patients and 600 ml in 27 patients. Now we've come down to 200 ml. Because that's the guideline. It says that you give 100 ml up front, right? And then you give 100 ml again in 2 hours if the paralysis is.
But what's your endpoint? What are you comparing?
Comparing?
Yeah. Besides the patient walking out.
Mortality.
You gave 900, they walked
out. Mortality and the duration of hospitalization. I haven't presented here, but I can, share with you what was the total duration of hospitalization, which was much higher in all this, and it has come down here.
Did the time of the presentation affected the outcome?
No.
Or the amount that you are giving?
No, because we are following this standard protocol everywhere. But the recent guidelines which have come from the Ministry of Health, not for the neuroparalytic snake, but for the viperine bites, they have decreased the follow-up dose to 6 vials. From 100 ml, they've decreased to 60 ml based on whatever a little bit of clinical trials which have been.
And these are FAB2, right?
Yeah.
FAB2.
Yeah. So this is the total cost. Okay, I'll not talk about this. This is important. Ventilation works in neuroparalysis. Now, when I was given this talk, Ziad gave me a question. How do you deal with snake bite if you don't have an anti-snake venom? Now, you talked about the crates causing the presynaptic destruction of the nerve terminal. There have been studies which have been conducted in Sri Lanka, and they've shown that the nerve terminals take anywhere between 72 to 96 hours to regenerate. So you don't have an anti-snake venom, don't do anything. Ventilate them. They'll come back, right? With the anti-snake venom, the average duration of ventilation in a crate bite is around 36 hours. So if you want the nerve to regrow, you might have to ventilate them for double or slightly more than that. And then they'll be associated complications with ventilators, right? Long-term ventilation. But if you have nothing to offer, just ventilate. And why ventilation works in a crate bite victim? Because their lungs are clear. They are not ARDS patients. They do not have dirty lungs. They do not have anything which is flooding their alveoli. It's just that the muscles are not working. And the ventilator is doing that muscular. They don't require very high FiO2. They don't require very high rates or pressures. What they require is something which can work as their muscles. This is the mortality. It was 3.5%. It was 11%, and this is the last study, 2.73%. This is what you were asking. What was the mortality?
Yeah.
You know, in different studies when you were using different kind of ventilators. So it was 3.5%. There in this group where they were using high dose of antivenom, the mortality was more. So we have kind of come back. Okay. Yeah. Look for complication. Look for antivenom reactions. This is something which has again come from Sri Lanka. We don't see too much of it, but it has come from Sri Lanka that people who have been, we followed up our snake bite patients. I haven't seen anyone coming back with these issues till date to me. We have a very big rheumatology center and we initiated this. Any new patient who comes with any of these arthritis or mononeuritis or any kind of a problem, then were you ever bitten by a snake? Did you receive anti-snake venom? Till date, we haven't kind of found this. But somebody's come out with this, that this can happen. So there is a possibility that there can be a long-term. Look for hypotension, look for oliguria, look for local infection, look for compartment syndrome, and then some other unusual complications. So if you see a snake, don't panic. Do not disturb it. If the snake is moving towards you, stamp the ground. This was for the president. This can be, for the general public. Yeah. And avoid stepping, protect yourself. That's it. Thank you.
Thank you very much, Ashish.
To give you our perspective and how we have kind of gone from very high to reasonable anti-snake venom. We'll probably try to reduce it further.
We are trying to do a randomized control trial two doses for the snake antivenom because the guidelines in Iran, they give us for severe envenomation quite a huge range between 50 to 100 ml of the snake antivenom. And so they are keeping it up to the physician to decide.
And each vial has what, 10?
10
ml.
each vial
10
has 10 ml.
10 ml, and how much protein in each one?
I think 40.
What's the question?
Protein
How
in
much
each
protein
vial
in
of
each vial of,
anti-snake.
Saudi snake antivenom?
Paul, do you want to make your presentation before or after the break?
I'll do it now, if that's okay. Okay. Unless you want to take a break, I want to answer. Thank you very much for inviting me to give this presentation. I think I don't really need to give a presentation because it's already been given by the previous speakers, but I'll highlight my perspective as well and try to focus in on anti-venom. But much of the key teaching points have already been presented this morning with two really excellent talks. So I'll just start off with this slide about the cost of antivenom. So in the U.S., which is my experience with treating snake bites, most people who are bit by snakes don't die. So that's not the endpoint that we deal with in the U.S. In fact, the number of fatalities from snake bites each year is just really a handful. I think they've made estimates of maybe 10 or fewer people from around the U.S. die from snake bites each year. But we still use a lot of antivenom, and the first speaker is real interesting in terms of, well, when someone comes in, is it a dry bite or not? The family wants us to do something, give antivenom, and that's often, you know, the quandary we face when someone gets bit by a snake, or even if they come in with other medical complaints, is the family wants us to do something. But one of the factors with snake antivenom has to be factored in is also the cost. And not only is the basis of the cost very expensive, but then the hospital makes a lot of profit on antivenom. And so while most antivenom cases, they don't spend $143,000 US dollars, the typical amount of antivenom cost may be $10,000 or $20,000 or $30,000 routinely, which is extraordinarily expensive. You know, we associate that sort of cost with open heart surgery or some major operative procedures, and the cost of antivenom is almost that much. So, given the cost of the antivenom, that's part of how I factor in whether I'm going to give antivenom or not. So I've had the opportunity over the last 7 years to be part of the North American Snakebite Registry group, and we're a group of toxicologists from around the United States that have been putting in our snakebite cases into this registry. We have about 1,000 cases or so at this point, and we're continuing to enroll cases, and hopefully we'll learn more about snakebite with this large accumulation of data, particularly in terms of treatment. I think our approach, as you'll see, is kind of one size fits all in terms of how we dose our antivenom, but there's certainly subgroups which would be, I think, very interesting. People with coexisting morbidities, diabetics and other folks, and children versus adults, and whether there is a strategy to differentiate how much antivenom to give. So a lot of this is not known. And through the collection of this data, hopefully we'll learn more in the future. I think what I did in terms of my research to prepare for this is that in Turkey, the most common venomous snake is the black viper. We don't see black vipers in the U.S., but we see, as you'll see, mainly the crotalids. So this has already been discussed previously. These are very interesting and very pretty sorts of snakes. But other than the coral snake, which we see in the southeast in the U.S., these other snakes are the exotic snakes, which occasionally people have as pets, so we occasionally get a call about one of these other sorts of snakes, but these are not native. These are the old world vipers, which have already been discussed, which belong in the old world, not in the U.S. except as exotic snakes, and we see the crotalidae snakes. And particularly the rattlesnakes and the copperheads, the cottonmouths are less common, depending on the geography of where you're positioned. So in Arizona, for instance, it's predominantly rattlesnakes and their subspecies. Where I practice in Texas, we have a predominance of copperheads, but we also have some rattlesnakes as well. And the venom effects are different between these two types of snakes. The rattlesnake envenomations tend to be more severe than the copperheads. The copperheads tend not to have as much of the hematologic effects, and even the direct tissue toxicity tends to be less with the copperheads. But still, when patients come to the hospital, they get bit by the snake, they bring in the snake, they want something to be done. Do you use antivenom or not? And in fact, many of the copperhead bites that we see, even if they have the local effects, we may choose not to give antivenom, particularly with the copperheads, just because the course is relatively benign. So, thinking about when to use antivenom, in the U.S., I'm not sure how good this data is, but approximately we say 20% of the snake bites are dry bites. So my sense of a dry bite is there's really no direct inoculation of the venom per se. There may be some minor physical injury from the bite, but no envenomation. But of those who become envenomated, many of these cases, or some of them, may be mild cases just with some local effects, really without extension, without any systemic effects. And those cases also may not require this very, very expensive antivenom. So these are some of the species we see in the U.S. And in terms of identifying snakes, it's nice to get an identification. We often don't have an identification, and we just treat them as if it's some sort of rattlesnake or a copperhead snake. We've already heard a lot about venom and various proteins and the clinical effects. With the U.S. snakes, most of the clinical effects are the effects causing local tissue toxicity, and For some reason, those slides are not appearing. And then some hematologic effects. And the hematologic effects are of interest because you can measure these hematologic effects. You know, we do not measure antivenom or venom levels or any sort of you know, additional information that might be helpful in assessing the severity of the stake, such as a venom load. We don't have that sort of technology. So, but we do look at, obviously, the hematological factors, the platelets and the coags. So in terms of the management of the snake, as was already discussed, you know, we do the initial evaluation. If the patient's been envenomated, we do hospitalize the patient even if they don't need antivenom, just to provide some time to observe the patient to see if there's any progression. If we feel it's a dry bite, particularly if it's in the upper extremity, then we'll send them home after a short period of observation. Usually with the lower extremities, and in children, we'll admit them over to the hospital and watch them at least overnight, even if we don't give the antivenom. This has already been discussed in some detail. You know, the complications we've also discussed. Again, death is not a common endpoint at all in the U.S., but certainly the potential for a compartment syndrome or something that looks like a compartment syndrome is probably our most concerning problem in rhabdomyolysis. And here's just some folks that have had, you know, fasciotomies, and traditionally, particularly in some parts of the U.S., you know, before the wide use of antivenom, you know, the primary approach was to be a surgical intervention with the swelling, and patients had very disfiguring surgical procedures, which with antivenom are probably not required. And estimates are maybe 1 out of 100 cases of envenomation, you know, require some sort of surgical intervention, whether it's a dermatomy or occasionally a fasciotomy. But this is very uncommon. Interest, though, in certain parts, as I just alluded to, in Texas and elsewhere, the traditional approach was the fasciotomy. And that's why where the patient gets admitted in the hospital, it really does make a difference. If there's a toxicologist, if they're admitted to a toxicology service, we tend to, you know, primarily use the antivenom. But in other hospitals without toxicologists, you know, they see swelling, they say it's a surgical problem, they may admit the patient to a general surgeon, and they may end up with an unnecessary fasciotomy. So
in the U.S., it's a trauma code.
Trauma, yeah. So, you know, in terms of antivenom, again, unlike my Indian colleague who's really saving lives with antivenom, you know, these patients, almost all of them are going to live regardless, but, you know, when do we use the antivenom? So, you know, if there's progression of the swelling, again, limited swelling, we may not use the antivenom. And then hematological effects we use. And some of these rattlesnakes, a minority of them do have some neurotoxic effects, and any neurotoxicity would be treated with antivenom as well. Oops, wrong way. Okay, so different types of antivenom. So up until about 2000, the only antivenom that was available in the U.S. Was the old Wyeth antivenom made by horses. It was the whole IgG, and there were lots of side effects. It was very immunogenic, and many patients, in fact, the majority of patients, you know, you gave them the antivenom, and they developed, you know, significant, even severe reactions, anaphylaxis, at the same time that you gave them antivenom. That's why a little bit of caution about, you know, just moving and giving antivenom to everyone just because of all those side effects. And there were patients that in one arm you'd be giving them the infusion of the antivenom, and the other arm you'd be giving them the infusion of the epinephrine to treat the anaphylaxis. So fortunately those days are behind us. And in the U.S., as you'll see in the next few slides, you know, the main antivenom we had up until last year was the FAB antivenom, known by the trade name of Propab. And then the newer antivenom, which really just came out, is the FAB2 antivenom, which we'll discuss. So this was the old Wyeth that came from horses, lots of hypersensitivity reactions, including anaphylaxis. And, you know, traditionally, when we approach the care of patients, if something causes anaphylaxis, that's the last thing we use. If they have an allergy to an antibiotic that causes anaphylaxis, we never ever use it. But in the case of treating snake bites, you know, this was the quandary. Not only the acute hypersensitivity reactions, but also the delayed hypersensitivity reactions. And most, if not all, of the patients practically would develop the serum sickness from the horse serum. which we see occasionally, but not very often now with the newer types of antivenom. So Crofab came out in 2001, came from sheep. It was made by immunizing the sheep with certain venoms, the rattlesnake and also the cottonmouth. And it's just a very small amount of the FC fragment, so much less immunogenic than the IgG antivenom. It was is useful in stopping the progression of the swelling. At least that's one of the endpoints, and also to reverse the hematologic toxicity. There are a small subset of patients that develop systemic toxicity from snakebite, including hypotension, for instance. But those are really the minority of cases. Most patients have the swelling, which can be quite dramatic, and then a subset of those patients will have the hematologic effects.
Based on the clinical trials, it was John Sullivan who created it at the University of Arizona, and all the antivenom go back to actually our poison center. But even then, it was the clinical trials was on 48 patients, and it was on mild and moderate.
Right.
Yeah. Never treated anybody with severe in that clinical trial.
And whether it prevents tissue loss or not, I mean, if someone presents already with necrosis, it's not going to suddenly reverse the necrosis and prevent that sort of tissue loss. Hopefully, it will prevent worsening tissue injury, but it doesn't reverse severe tissue injury by any means. So in terms of dosing, I wish we could do this stoichiometrically. I wish we knew, the total amount of venom that was introduced, and that we would calculate this based on the venom load, but we don't do that. So the way this antivenom was approved was to use a starting dose, and generally, we say 4 to 6 vials. With the old Wyeth antivenom from years ago, it was a larger number of vials, 10, 20 vials at a time, but this is a smaller number of vials. Whether you give 4 or 6, kind of depending on the severity of the bite. If it's more severe, I usually give 6. If it's less severe, but I want to use an antivenom, I give 4. And then you reassess the patient, and that's the critical thing that you need to do after the initial administration. You come back after an hour or two, and you see what the swelling has progressed or not, and you measure the coags and the platelet count to see if there's been any reversibility. And we often see platelet counts that are very, very low, of 5 or 10. So if you give the antivenom and there is a good response, the platelet count will bounce right back up. The same thing with with some of the coag factors. Those can be totally depleted, dramatically so. Although the patients tend not to bleed a lot. They just, you would expect them to be bleeding if the patient was on chemotherapy and had some sort of cancer and had those sorts of numbers. You'd be worried about head bleeds and other sorts of really devastating hemorrhages. But you don't see that much with snakebite. At least that's my experience. Then in terms of continuing to give the antivenom, particularly with the Crofab, as you'll see in the next couple of slides, there was this feature where the patient seemed to sometimes get worse again, or there was a delay, and because of this, the initial standard approach was to give them these extra doses, even as they recovered, just to prevent the late onset of other sorts of symptoms or the delayed toxicity, as you'll see. Whether that's required or not is still very debatable, and there's no standard of care. There's a recommendation under the package insert, but there's no standard of care. And I think in the last number of years, a lot of people have been deviating now from the traditional approach, which was used after the release of Crofab initially, which was to give this maintenance antivenom to patients. And again, one of the factors in terms of the decision making is the cost of it, if nothing else. Do you spend another $10,000 or $20,000 when the patient may not need any of this at all? So the problem with the Crofab was the pharmacokinetics and the fact that the half-life was relatively short. And so the effects of the venom, in some cases, were outlasting the effects of the antivenom. And because of that, you would sometimes see this late onset hemotoxicity, which was certainly of interest in terms of how long do you observe the patient for after the treatment. And then the other problem is the recurrence. And so, patients seem to recover, you'd send them home, and then 2 days later, you check their blood counts again, and their platelet count would be back to 10,000, and you'd say, well, they seem like they've had a late venom effect. Do they need to come in for retreatment? And these were the decisions that need to be made. So, particularly with the rattlesnakes, less so with the copperheads, the approach is to follow them up after discharge from the hospital to test their coax and their platelet count again, and to follow them closely. And if they had an isolated coagulopathy, we wouldn't necessarily treat them. Again, many of these patients, most of them never bleed anyway, so you're treating numbers. But if they have two-compartment coagulopathy, or thrombocytopenia, for instance, or platelet counts that are real low, then we may treat them. Whether there's data to support that approach, there is none. But this was kind of a gestalt that those who treated these snake bites felt like, well, do we leave these patients to go home with platelet counts of 10,000? It's dangerous. What happens if they fall and hit their head? We probably should retreat, but again, based on anecdotal information. And these are some other risk factors for bleeding as well. So moving on to the newest antivenom in the U.S. is the FAB2, which those of you from India and elsewhere have much more experience with. This was under clinical trials and a long delay to the release for many, many years. Some of the clinical trials were done literally 6-8 years ago, but it wasn't released until late in 2018. And the potential advantage of this antivenom is that it has much slower clearance. It hangs around for a lot longer period of time. So these were a couple of the studies done during the clinical trials. It's only been released, like I said, in October 2018, so there's really practically nothing published yet since it's been released. But there are a number of folks studying this, and there should be a lot more papers coming out in the next few years about the use of the antivib and also comparing the antivib with the Profab to see whether there's truly a difference or not. So this was from one of the early clinical trials, just really a couple handfuls of patients comparing the two groups. But the group that got the FAB2 seemed to have more detectable antivenom when it was studied further out than the group that just received the Profab. So at least on paper in these small series, there seems to be an advantage. And we'll see what happens in the future. Now, in terms of the use of particularly the FAB2, that was approved for the treatment of rattlesnake bite and actually not copperheads, which are less venomous, as I described, but we have a lot of copperhead bites in the U.S. And so whether it will be used off-label, like a lot of things are used off-label for the treatment of copperheads, will still be to be determined. The typical starting dose for the antivib is thought to be about 10 vials. And Mazda, you have a lot of experience now with the antivib. You usually use 10.
We have used it. It looks like for mild to moderate 10 vials, and then anything more than that, you actually need to repeat it.
Yeah, okay. So again, all this will be coming out. So I just want to close with this one little case, and I continued to learn about toxicology with my travels. So this was a patient who was bit on the toe, but it turns out he did not have much in the way of local tissue effects because it was a crate bite, and as was described very eloquently, had severe effects in terms of the neurotoxic effects. Ended up on ventilators. The patient on the right was really interesting because when it was presented to us on rounds, they said, well, we have no idea whether he's bit by a snake or not, but he presents like a crate bite. He's unconscious. He's a young guy. He's healthy, so we're going to treat him as such. And because of that, they have really good success in treating this patient.
Are they giving him antivenom?
Yeah. Yes. Yeah.
This is what as I said, that in that particular time period, any young person who comes with this kind of a symptom, I might end up over-treating a couple of them, but I would treat them.
Yeah. And this is the antivenom that's used.
Yeah.
So So thank you very much. Any questions? Yes.
Yeah. So what's your experience with the delayed coagulopathy from the rattlesnake? I know there's also some evidence whether if they presented like delayed 2 days later and the role of loading antivirals at that point. So do you see a lot who do not present initially with coagulopathy and then like 2 days later have a delayed coagulopathy?
Well, there are some, and you know, the initial dosing of the antivenom with the Propam may mask the coagulopathy, and once it wears off, then it presents itself. And I think that's the issue. They come in, you know, those patients, they come in really early. They have swelling. You check their blood count; it's normal. You give them the Crofab, and then 3 days later, you have to send them home, and then you check your platelet count. Now it's very low, or the PT is very high. And the question is, well, why wasn't it like that at the outset? It's probably because they were treated so quickly.
50% of the patients that present to us are coagulopathic, defibrinated or platelets that are below 150, I guess, by consensus, we decided that that's thrombocytopenia in the snake bite. Of those, 75% will go to develop recurrent coagulopathy in our care. Now, Paul is correct. Majority of the Arizona population in the city are within an hour of presenting to a hospital. Now, our understanding, because our center takes care of most of the rural Arizona, we see the same thing even when they present later. This is 50% are coagulopathic and 50% are not. And you can't predict which ones are going to become.
Yeah,
and the longest we've seen has been 82 days. 82 days of platelets under.
And does not have to do with the reabsorption from tissue?
There are lots of theories about why that happens, that whether there's a depot or not, or maybe that individual is, you know, when we're talking about now smaller individuals. We follow them up to 21 days, and then we call them every 6 months up to a year out, just to look for local damage on the, you know, because we get lots of local damage and they need grafting when it's on the tissue of the fingers and toes.
How often did you experience anaphylactoid reaction? I mean, in Atlanta we had mostly copperheads, so we didn't much recommend it. But how do you often really see it? I mean, we talk about that.
Well, with the Propam, I've yet to see a case of true anaphylaxis, but it's been reported. But that has to be compared to the prior experience where anaphylaxis was happening about a third of the time. I mean, with the old horse serum, and that's why, you know, we're very cautious about the potential of developing adverse effects. But the number of adverse effects with the FAB is much lower.
The total reactions is actually there are good publications on it from Phoenix, Tucson, and it's less than 0.05%. All reactions, not anaphylaxis, but all allergic reactions with Crofab. With the now, if you're talking about anaphylactoids, we see that all the time, and that's rate. You know, if you start giving the antivenom really fast, especially in children, we see lots of anaphylactoid. We just slow it down.
Okay, perfect. Thank you very much. So now the real break.
Break.
And do insurance cover venom?
Most insurance are, if you don't have it, goes on Medicaid.
But they have to pay some percentage, right?
No. Treat snake bites. Within the season that we have, we see about 50 snake bites at the bedside, and then we treat another 70 in the hospitals that are under our care. So the most common types of coagulopathy that we see with snake bites are defibrillation and thrombocytopenia. Now, thrombocytopenia has been explained in many ways that is it due to demarginalization? Is it due to clumping? But that's something that we see that immediately is reversible, almost. So platelets are almost gone, individual comes in, and again, we do not run into the problems of people presenting late. Now, do we have late presenters in terms of snake bites? Yes, but those are volitional. One individual, for example, did not come in for 2 weeks because he didn't feel he's sick enough. And again, our snakes do not kill you, right? Our snakes are rarely kill you. And you can look at the rate. We did a study with Frank Walter and myself, and we published the rate of snake bite deaths in the US, even when you include the elapids that we have, it's almost rare. It's a rarity. Okay? And again, access to ICU care, access to ventilation, almost, if you have that type of care, nobody dies from it. But thrombocytopenia we see early on. It's reversible both with Crofab and now with Anavib. So both with antivenom that is Fab1 and antivenom that's Fab2. Remember, lots of people talk about antivenom snake bites, but they don't treat them on a regular basis. Antivenom Fab1 came to be why? Why did we come up with the Fab1? There's only 2 Fab1. There's a European and there is an American Fab1 anti-snake. The whole idea was they have better penetration into tissue because we were worried about tissue toxicity. And I don't know, Bruno, do you guys have a Fab1 in France? No. We have a Fab2. Fab2 is actually a better antivenom in terms of lasting and being effective. But what we see is a different problem with it. Now we're talking about coagulopathy. Platelet reversal we see almost the same with the antivenom that's a Fab1 and antivenom Fab2. So people come in, you measure their platelets, it says 30, 60, undetectable. You give them antivenom, back to normal, right? Now, are they as effective, meaning functional? Most of the functional studies that are done, whether you're talking about epinephrine activation, collagen activation and stuff, they do not show any difference. There are shear activation studies that show that maybe in a snake bite, depending on the venom, that the activations are not one and the same, meaning platelets are not functional as they were before seeing the venom. Now, the other thing that we see is defibrination. So fibrin is totally gone. It is interesting that with antivenom that was a Fab1, we would give it, and it would take almost tens of hours before we could see a detection on the levels of fibrinogen. Okay? So what happens? Fibrinogen, if it's destroyed, right, then it takes time to regenerate it. You don't all of a sudden come up with fibrinogen. I would tell you, our early studies and looking at the Fab2, we see a different pattern. And I don't have an explanation yet for it. We give Fab2, and what do we see? Return to normal. Why? I don't have an explanation for it. Is it that somehow the venom actually is, enveloping fibrinogen and other factors, and they're not seen based on the assays that we're doing, and now we give the antivenom and you can see it? I don't know. I don't know if those studies have been done. But I know that you guys have been using Fab2 longer than we have. And are you seeing anything with fibrinogen and other factors? Do you measure them?
Yeah, we do measure them.
And what do you see with the Fab2?
Yeah, a few hours.
Return to normal?
Going up.
They start going up. But do they return to normal?
Yeah. Yeah, fibrinogen. Yeah.
So Fibrinogen going, you get somebody that comes into the hospital, fibrinogen undetectable. You give them antivenom, and now they're normal. Is that what you're seeing?
But not within not within few hours. I mean, within few hours you start to see it going up. 6-8 hours you have some.
Because our protocol basically we don't measure after 2 hours. We measurement is mainly after 6 hours, 6,
Okay.
12, 18 hours.
So we do it an hour before and an hour after infusion. So, Bruno, what's your experience in France with the fibrinogen? So one thing that we're seeing now with this new Anavip, which is a Fab2, fibrinogen, we used to see it go down, and we get Fab1, it would not affect it. Maybe 6, 7, 8, 10 hours later, it would start going up.
Let me ask you first. Did you see any difference for the local reaction between the Fab1 and Fab2?
What do you mean?
Local reaction.
Local? No.
Because
we're not seeing any.
We know that when you give antivenom, Fab2, right, it doesn't go well to the tissue.
Mm-hmm.
So the tissue reaction is cause it is it's called inflammation, right?
Mm-hmm.
And fibrinogen is the acute phase reactant.
Correct.
Yeah, and we see that when the patient have really bad local reaction, it's gonna increase fibrinogen. That is the factor that counterbalance the venom. You know, the one who has severe reaction, those patients have high level of fibrinogen. You know, really early on.
So we see that with, for example, when we were talking about antibiotics, okay? People who come in and they have high levels of fibrinogen,
yeah.
And I'm talking about 600 to 800, we look at them and they have an infection already, something going on. And majority of them, they've done something. They manipulated the wound, or they were out of care, and you know they were not sanitary, and they do have some sort of infection. We looked at 2,000 snake bites and showed that nobody needs antibiotics unless they've done some manipulation of their wound. Now,
at what time did you diagnose infection?
At what time we diagnosed infection?
Yes.
Well, the whole thing was in the EDs, a diagnosis of infection. Oh, I better do prophylaxis.
I know, because you know usually
we do not do.
You know, venom can cause local reaction, right? It's inflammation is not infection in the first few hours, like up to like 6 to 12 hours. It's not possible. Infection can happen within like 6 to 12 hours. So if you diagnose infection in 6 or 12 hours, it would be not that infection. It should be inflammation from venom, I think.
Well, yeah, that's what the toxicologists consider, right? But the regular emergency physician, even in the United States of America, right?
Yeah.
One thing that they did is like, let's give them antivenom and let's give them antibiotics immediately, okay? And we used to see, actually, with that practice, we used to see more reactions because the risk of having a reaction to the antibiotic is much higher than even to the antivenom. So we used to see lots of it, and that was a common practice. And still goes on, although our recommendation after we published this is that you do not need to do any prophylactic treatment. The venom itself, at least the venom of North American corrodolite, is bacteriostatic, okay? Even if you don't consider anything else. So, but when we're talking about acute phase reactant, right?
Yeah.
So the patient would come in and they had a high levels of fibrinogen. We would say, okay, this is probably an infection. Now what we're seeing is low levels, okay? And we're seeing a rise, immediate rise. So I can understand when you're saying the inflammatory response to the antivenom, but that wouldn't be within an hour.
Yeah, that's true. Because
that, you know,
I mean,
when you get things within an hour,
I mean, the half-life of I mean, for the liver to produce fibrinogen is between 3 to 9 hours.
Correct.
The median time is 6 hours. But we don't know if inflammation can increase the rate of fibrinogen production.
Sure. Now there are, when we're talking about, anticoagulation and measurement of anticoagulation, there's even suggestions of, for example, and that's why I was asking Ashish about hypoxemia, how many percentage, what percentage, because there is a talk to actually allow patients to rebreathe their own air, increasing their carboxyhemoglobin. Carboxyhemoglobin actually pushes fibrinogen up, and it decreases its degradation. But really, does that have an effect on coagulopathy and bleeding? Now, as it is, our rate of bleeding, even with severe thrombocytopenia and defibrillation, is rare. The only times I've seen it, it's been on somebody who got envenomated multiple times. So, and that's one of the things that I wish Ashish was here. I disagree with Ashish because I've seen people who were bit twice with the same snake, 3 times with the same snake. And their presentation is not the same presentation as one bite, okay, of a snake. These guys are usually severely thrombocytopenic, severely defibrinated, and they bleed. As a matter of fact, I think it was the first venom week that I took David Waddell and Julian White to a hospital in Tucson and showed them a severe GI bleed from a snake envenomation, rattlesnake envenomation, which is usually not seen. And this was an individual from New York, came to visit her family member, went to pick up a trash can, and most of you have seen trash cans. They're these big buckets that you pick up in Arizona. She went to pick it up, and she was wearing flip-flops. Snake got her foot. She took one foot back. She got the other foot and put the other one down again. So 3 times she was envenomated. Severe coagulopathy, bleeding, GI bleeding, or GI bleeding. We couldn't stop it. Another one we saw was a case of a single bite of a pet, Chlorus cerebrus, one of our worst rattlesnakes, and the gentleman was actually a son of a hematologist. And he ended up getting severe coagulopathy. He has epistaxis. His nose was bleeding. He was transferred to the floor, out of the ICU and out of our care. And by the time we got to his bedside again, they were giving him blood products, and his hemoglobin was 4. And when we turned his back, from the back of his, all the way down, he was bruised.
No antivenom.
What?
No antivenom.
They weren't giving him antivenom.
Just blood products.
Just blood products. He was under care of the internist, unfortunately, at that time. And then we put him back. And as you guys know, or are aware, our system now, we have internists that take care of the inpatient. They're called hospitalists. And if they're not attuned with the state or the hospital or the region that patients, for example, snake bites come in, they do the same things that they do with anybody else that bleeds, which means give them platelets, give them fresh frozen blood, give them blood. Which is like the worst thing to do is like, let's give them something else to break down.
To the fire, yeah.
So we do see severe coagulopathy. Defibrillation is the worst one that we see. As you saw with Paul's presentation, that there is a point that we become concerned. When do you treat them? Okay? When do you treat somebody that comes back to you with platelets that are under 150? And I'm going to give you a range. And also with fibrinogen that's under 150. So they come in, platelets 100, fibrinogen 100, right? Are you going to treat? Most of us say no. Risk of bleeding is low. Now, they come back with fibrinogen under 50, platelets under 50. Would you treat? Why? The risk of bleeding is really low. But I'm not saying I wouldn't do it, but I think most even toxicologists, we lose the control. It's, okay, now this is too high of a risk for me. Not that that's actually for a patient, and we would retreat.
Wouldn't you argue that you have an evidence, you have an evidence of systemic inflammation from step one? You would treat that. I know because you know your demographics, you know what you're dealing with, so you have some sort of reassurance. But in a general toxicologist, when you have that evidence of systemic inflammation.
So I would suggest that maybe we should go back to total clotting time, 20 minutes and 30 minutes in these individuals. Because really, our empirical data is dictating that these people are they're not at risk. There are our recommendation for anybody that goes home after snake bite, rattlesnake bite in Arizona, is that no provocative action. You do not go to dentist to pull teeth. You do not go for any cosmetic or elective surgery. You do not go under any high-risk activity, which are contact sports, okay? Jumping out of a plane, and the reason is we get lots of young people, and Arizona is known for their activities, right? We have people who go out of the hospital and says, okay, can I go and do a skydiving now? You know, of course we tell them no, because they are at higher risk. But in our general population, these people don't bleed. Those studies have been done. Fibrinogen low, platelet low. The only study that I've seen was actually a torsional peg that was done. And it showed that platelets under 60, okay, it didn't matter how much fibrinogen. Platelets almost played the role of what you would call a spoke in a wheel. If you didn't have that, fibrinogen didn't matter how high it was. If your platelets were low enough, that clot was not stable. So really, maybe we should be looking at just platelets being under 60. My suggestion is going back to total clotting time, or looking at the limited in 20 minutes or 30 minutes clotting time for these people, at least in the United States. I opened the forum to my colleagues who've been using FAB2 more often, and for a longer time, and hearing your suggestions also.
Yeah, we use 20-minute whole blood clotting test as a bedside test.
Thailand?
We use the 20 whole blood.
In Thailand?
Yeah, in Thailand. Yeah.
So you do it initially for determining treatment, but not for disposition.
For disposition as well.
So when you send them home, you also make sure that they're...
Yeah.
Same as minimal.
Yeah.
So you do also that?
Yeah. No, in minimal.
Oh, in minimal.
In minimal, they have the same protocols as Thailand.
Minimal,
okay. We don't. We do the clotting test is on the patient arrival, and the reason is because the coagulation profile can...
You're doing the INR you're talking about?
No, the bedside.
The bedside, okay. You do it only in the...
At the time of presentation.
We actually have a study already. It's a prospective study to compare 20-minute whole blood clotting test with the PT, TTT, and fibrinogen. We use the fibrinogen level less than 100 as a gold standard, and then we compare 20 whole blood clotting test with the fibrinogen level. The sensitivity is about 93-95%. Oh, I'm sorry, 85% sensitivity, but specificity is about 95.
95%.
95. And the sensitivity is the highest one for the 20 whole blood clotting test, nothing else. And same thing with PT INR, but you need to use the INR cut off as above 1.2, not 1.5, to reach the highest sensitivity at 85%.
And when you go to send them home, usually for us is about close to 36 hours that we send them home.
Usually in Thailand, for green pit viper bite, we take the blood at time when they visit, about 2 or 3 hours, and then another 2 or 3 hours later, if it's normal, we send them home, and we have them follow up at outpatient, but go back to ED, not at the outpatient clinic.
And the rate of...
Under toxicologist, observation. Yeah.
And what's the rate of reoccurrence?
Yeah. We follow them for 3 days, okay? But we have them follow up once a day until 72 hours. And we did a retrospective study back 8 years if we have any revisit between the time 6 or 7 hours to 24 hours, because we send them back home at that time. So we are concerned about their safety. So there's only 3 patients came back in 320 cases.
320 and 20 patients, you said, or 3 patients?
3 patients came back.
Out of?
Out of 320.
320. So that is...
And 3 of them had no any coagulopathy to come back. They only have swelling, pain, and fever. Okay. Nobody died. I already published that in Quintox. It just last month in Quintox. Look it up.
Okay.
Yeah.
Thank you very much, guys, for the sake of time.
Yeah.
Thank you.
I'm going to sit down, but I will tell you, 50% right off the back are coagulopathic, 75% of them are recurring. So our rate is much higher.
Yeah.
Interesting. Interesting. And me.
Okay, so
Sorry, Dr.
no worries. Okay, so I'll be talking briefly in 10 minutes about first aid concepts and controversies. I have no conflict of interest. Just as an intro slide which has been presented, snake bites occur frequently with a global estimate of 421,000 up to 1,842,000 cases of snake envenomation and up to 94,000 deaths. Yearly, the prevalence is high in the tropical regions of the South, the Southeast Asia, Latin America, and Sub-Saharan Africa. And they are most common in the rural areas where you do not have access to professional health care. So rapid antivenom therapy and appropriate first aid measures are of utmost importance to decrease the mortality and the morbidity. Many different practices have been described in literature regarding the use of first aid techniques, and they are being practiced in some areas with no really solid evidence to back up their use. I'll be talking briefly about each. Tourniquet. They are used as a first aid, mostly in developing and rural places. And the problem, unfortunately, is that they can be very harmful. The lack of local oxygen supply will rapidly damage the tissue and result in tissue death and amputation. And once you release the tourniquet, it's even worse because you will have an abrupt systemic absorption of the venom and severe systemic envenoming can occur. Bahat et al. Found a significant increased incidence of local swelling with the tourniquet use. Another study by Franca et al. Described a significant increase in the severity of the local envenomation in those who use tourniquet, and Wang et al. Showed a significantly increased risk of skin grafting even in those who use the tourniquet. There's an inconclusive evidence regarding the duration of hospital stay. Some showed no significant difference, while others showed actually an increased an increased duration of stay. Even there's also an inconclusive evidence regarding the amount of antivenom, whether you use the tourniquet or you did not use a tourniquet. So the guidelines briefly do not support the use of tourniquet. According to the WHO, arterial tourniquets are contraindicated, and their effectiveness and relies really on the occlusion of a peripheral pulses, causing pain, ischemia, nerve injury, and gangrenous limbs. The deleterious effect can occur, and they are usually seen within 20 minutes and up to 2 hours after its use. And the Wilderness Medical Society does not recommend tourniquet for envenomation by pit vipers in North America. So, no tourniquets. What about cutting the bite site? This is also some of the practice that's done in some areas. It's an oldest form of treatment, and the theory is that you promote local bleeding, and eventually what really happens is that you will have severing of the tissues, including the arteries. You will have, even the wound chewing can increase the risk of a secondary infection, and persistent bleeding can occur as a consequence of the venom-induced uncoagulable blood. So it's really a terrible way to just consider as a first aid measure. Regarding venom extractors, this also has been described as a first aid approach for snake bite management.
There's different actually venom extractors. There's some of the forms are called the Blackstones, and they are long advocated as a first aid. The premise is that they will absorb the venom once you put it at the bite site. Due to the porous nature of the Blackstone, there's no evidence to support this. There's other even venom extractors which can range even from a negative pressure extractors to so different complex forms, and they are even online. If you just Google them, you can find them online, and they are being advocated. They actually give a false sense of security and cause local tissue destruction. And the current guidelines from the Wilderness Medical Society and the American Heart Association do not support the use of any venom extractors or mechanical suction for pit viper envenomation. What about freezing, burning, and shocking? The use of extreme cold as a first aid is another option that has been used, and it actually results in local tissue damage without any benefit. These shocks neither reduce toxicity in rats that were injected with sublethal doses of the Bothrops atrox venom, nor reduce the lethality in the mice. And in one case, actually, it resulted in coma and incontinence. The United States FDA has banned the use of these devices, and which were previously actually sold to the public for the treatment of the snake bite and the spider bite venom. So there's really no role for any electric shock or any freezing cryotherapy. What about lymphatic flow inhibitors and trypsin injection? This has been described that the lymphatic flow inhibitors release nitric oxide, and which will inhibit the intrinsic lymphatic pump and delay toxicity. Another form is the use of trypsin, which is a proteolytic enzyme that will degrade the protein toxin. And the injection of trypsin at this site has been efficacious in the treatment of eastern coral snake envenomation in an experimental study. But up till now, since there's no really solid evidence for that, they are not recommended, neither the use of trypsin or the lymphatic flow inhibitors such as the GTNO. Further studies are needed to really show its benefit. Now, what about pressure immobilization? There's lots really of controversy regarding the pressure immobilization. The use of pressure band immobilization is controversial in North America. It's due to the perception that they worsen localized tissue damage, and it's discouraged in the American crotalids. The logic is that it's better if you let the venom diffuse to reduce the local tissue damage rather than apply pressure immobilization. And most pit vipers are unlikely to usually cause lethal systemic effect. So that's why they are really not recommended in the American crotalids. However, also a joint statement has been issued in 2011 by ACMT, by AECT, and AAPCC and other associations. And briefly, it mentions that the available evidence failed to establish any efficacy of pressure immobilization in humans. But it does indicate the possibility of serious adverse events from its use, actually. And the use of pressure immobilization for the treatment of North American crotolid envenomation is not recommended. So this is a statement from multiple societies in 2011. However, if you look, some authors actually supported its use in the potentially potent neurotoxic or coagulotoxic in the non-Australian snakes that are limited to the these snakes, the Echis, the Dysphalidis, and the other ones, and the Naja and the Microrulis. However, further research is required as there is insufficient evidence to support or discourage its use. If you look at the American Heart Association first aid, you will find a little bit different, that they actually state the use of pressure immobilization for venomous snake bites could be considered by applying a pressure immobilization bandage with a pressure between 40 to 70, not too tight and not too loose in the upper extremity, and between 55 to 70 in the lower extremity, around the entire length, and you splint and transport the patient. It's just a reasonable way that it will slow the spread of the venom. But the effectiveness really has been demonstrated for non-neurotoxic American snakes. So you can see.
Let me make a comment on that. That was based on a study that Sean Bush did when he was in California on a pig.
True,
and it was actually a misunderstanding of the results of that study, that American
Heart Association established this recommendations, and we have informed them multiple times. But as you don't want to go take care of your heart when you have you don't go to a proctologist for your heart, you shouldn't be going to a cardiologist for your envenomation.
Correct. But again, I mean, different associations, those really discourage its use, just the American Heart Association. And in Australia, where there are neurotoxic elephant snakes, the recommendations is pressure immobilization bandage to be around broad and or to be applied over the side to cover the whole limb, and the patient should be immobilized, and then the bandage should remain until the patient are transferred to the hospital and received an antivenom. So you do not remove the bandage until the antivenom has been given, so if the patient is envenomated, then the bandage can be removed after antivenom. So they do the testing and then give antivenom, and then they release it. So you can see different guidelines, and I think it's the only most controversial, the pressure immobilization, regarding all the first aid techniques that have been described. What about traditional herbal medicine? It's also described, if you see it in some of the articles. The ingestion of plant extracts and local application of the herbal medications have been really mentioned, but it lacked any robust evidence for that. And many of them even are toxic, such as the strychnine containing monkey fruit, and it can result in secondary infection. And one of the study by Madeke et al., the use of traditional medicine was not found to be to decrease any of the envenomation risk compared to receiving no aid. In another study in Brazil, it showed that extracts of the plant jatropha, which is a common plant there, it really reduced the local effects from snake bites, but if used as an adjunct to the antivenom. And also another plant or herb was found to reduce the lethality in a mouse model in Indian cobra, the naja naja. This was the Euphorbia hirta. But again, these are experimental studies, and there's no robust evidence for their use. As a position statement, the WHO guidelines have found that there is actually more harm with the use of traditional therapies, and their use is discouraged, and the recommended first aid is really to reassure, immobilize the patient, and move them to a place where they can receive appropriate medical care as soon as possible. So as a conclusion, the tourniquets cause limb ischemia and amputation. Electric shock is dangerous and is not recommended. Suction devices have no efficacy in experimental studies and cannot be recommended. Pharmacological treatment with a topical nitric oxide or trypsin injection delayed toxicity in experimental studies, but as of now, there's no solid evidence to recommend their use. The pressure immobilization bandage, compression bands, and rings have shown in experimental studies to delay systemic venom absorption, but it should be individualized to certain regions, species, depending how timely there is a definitive treatment, and to your local guidelines. Antivenom is the definitive treatment for venomous snake bites and should be administered as soon as possible. Splint rest and avoidance of the movement should reduce the movement of the involved extremity and should be really the practice for first aid. That's it. Thank you.
Any question? Any comments?
No, that was a great review of it. But these, these what we call first aid. In the U.S., another company came up with a new extractor. Another one came up with a pressure bandage that now has a hole in the middle of it. And lots of them are driven by financial, by financial nonsense.
But the other thing that's important, and I've been to Australia, I don't know if this is applicable in some of the countries where most of the patient will be in hospital within an hour or two. Well, in Australia, you're talking about 9, 10, 12 hours. That might have an influence as well. Next speaker.
Australian colleague here.
Yes, please.
Okay, thank you. I'm going to talk about the antivenom storage project in Thailand. I'm the conflict of interest, and just give you about general idea where Thailand is here, and this is Turkey, and this in the Middle East, and we have about 69 million people in the country, and for toxicology coverage for the all 69 million people. We only have about 20 toxicologists in the whole country. And we have 2% control. All of the 2% control is in the middle of the country. This is the whole country. This is Laos, Vietnam, Cambodia, Malaysia, and Myanmar are here. And we have 7 significant toxic snakes, venomous snake. Up here, there are vipers. This is Russell viper. This is Calosilasma rhodostoma. It's a pitch viper. This is a pitch viper as well. This one is found in Bangkok a lot, about 90% where I work. And this is cobra, king cobra, and crates. So from 2010 to 2018, about 6,000 cases reported to one of the poison control center, with the mortality rate about 1%. But we have about 5,000 to 6,000 snakebite cases per year.
Where poison center?
No, for the whole country per year, annual bite rate. But only 6,000 were reported to the poison, one of the poison control. We have 2 poison control, okay? Between 2010 and 2018, and that is about 1% death rate. And in Thailand, we come together and we have a society called Thai Society of Clinical Toxicology. We do the guiding and collaborating national organization for better serving poison and overdose patients. And also we oversee the medical toxicology scholarship training, and also we do guidelines, book, and also we host conferences.
How many toxicologists did you say you had?
About
20.
20. In 2000, we come together and in 2010, and then we established one project. This is based on what's going on in the country. We know that the market of antidotes is small. Often their patents have expired. Demand is unpredictable, and sometimes profit margins are very low. And pharmaceutical industry has limited incentive to develop, and it's not their interest to produce and improve the antidote and antivenom. Moreover, the antidotes are expensive, and sometimes they have a short shelf life, which discourage individual hospitals from keeping large stocks. So WHO recommends establishing a central bank of antidote as an effective and efficient way to ensuring prompt access to these drugs. In 2002, the National Health Security Office in Thailand set up a special system to improve the system to high-cost medicine. And medicine was selected and procured centrally. Okay, that is the I think the key word that I'm going to talk about. And manage all the supply chain, and was outsourced by the government pharmaceutical organization, which called GPO, to the private sector. By this method, we can save about $1 million a year.
1 million or 100 million?
I'm sorry, 100 million.
Oh,
100 million US dollar a year. And also, even we have the new innovative, the way that we can reduce cost of medical care by having the central procurement of the medicine, but we still have some challenges for the antidote and antivenom. So we want to improve the way that we have access to the antidote, and the antidote we have a problem with accessing it, but for the antivenom we have another problem. The problem is that because it has a wastage a lot, because each hospital want to stock their own antivenom, and sometimes they stock too many, and then it's just go expired, and then they just discard those medicine. And sometimes we have shortage of antivenom because this hospital have too many. Another hospital cannot buy enough, you know, something like that. That is a
So
problem.
the antivenom is produced where?
Antivenom is produced by the Thai Red Cross in Bangkok, and it's non-profitable organization, and it is WHO collaborative center for
And
snake
the
bite.
cost of it to a hospital?
One vial is about $30 US.
$30 US.
30 to 40 US dollar. Not expensive at all. It's cheap.
That's cheap.
Yeah, and because it is FAB Prime 2, and we only give one time, 5 vial one time, at most 2 or 3 times, you know. Yeah, it's not expensive, yes, because we produce it ourselves. And some of the antidote in this stockpile, we also ask the Thai Red Cross to produce for the country as well. So we have like antidote for cyanide for sheep, methylene blue ray sheep as well, because we can produce in our country by the Thai Red Cross and the government. And the program made intensive use. Our program also use the extensive use of information and communication technology, and not only to support the procurement and supply chain, we also use the consultation by the Poison Center to help healthcare provider in the remote area to manage the patient, and also to prescribe antidote and also antivenom. So this is the National Antidote Stockpile Project established in 2011 with all of these organizations: National Health Security Office, GPO, Thai Society of Clinical Toxicology, that is 2 Poison Center, Thai Red Cross. These guys, they help us to produce antidote, and this one is to produce antivenom. This is the first set of antidote in 2012. You can see that no antivenom at that time, but a later year we included antivenom. We have 7 kinds of venomous snakes, but you can see we have monovalent, which is one antivenom for one species of snake. We also have polyvalent as well. In Thailand, we have 2 groups of venomous snake. One is neurotoxic, like cobra, king cobra, crate. Another one is for hemotoxic, is viper. Okay, so we have polyvalent for viper and one polyvalent for neurotoxic. So it's really easy in Thailand. When somebody come in with paralysis, we give polyvalent for the paralysis. And if they have like after bite and they have breathing, we give the polyvalent for the hemotoxic snake.
And that one is made in the US?
No. It's something wrong. It should be something else, not USA. Yeah.
So all of them are produced within
the same,
same
institute.
Thai Red Cross.
Yeah. We have 7 types of snake, but we have low incidence rate of king cobra bite because they are in like jungle. Usually people don't get bitten really very easily. So we did not stock it. We did not keep it in this project. We asked them to use the polyvalent instead. Okay, because
why they have the monovalent like multiple?
Because monovalent is in a long time ago. We just produced the polyvalent, and the number that the manufacturer produced the antivenom more for the monovalent and less for polyvalent.
But I don't know. And most of the time, these patients they'll come without
No, in Thailand we know.
We know which snake has been.
We have a diagram to identify which one is which snake. Yeah, and many times they bring.
And the patient they will bring the snake with them.
Yeah, many times. They snake. Okay. Yeah, and in Bangkok we only for the viper. In Bangkok we only have green pit viper, so it's easy for us to identify. And also for neurotoxic snake, you know, king cobra usually in jungle only, not in the city. If somebody has paralysis after bite, it should be cobra. We know. Yeah, we have epidemiology study about that too. And this is all the antivenom. Some of these are exported to USA as well. I see some of these at the zoo Atlanta 8 years ago, 10 years ago. Yeah.
We have the In Phoenix Zoo, we have also.
Oh yeah.
Because the exotic.
Yeah, because
yeah,
of the
exotic.
Yeah.
I also have a publication about exotic snake by Quintox into back 2010 probably. Yeah, you can look it up. I write about it. And this drug accessibility, we use the IT technology. We use the Geographic Information System, the GIS, and we stock it based on the risk and the agency of the antidote and the antivenom. You know, for example, for the antidote for cyanide, it has to be at all of the level of the hospital because it's needed in 1 hour, something like that. But something really expensive, something not really emergency, like antitoxin for the botulism. Because it is very expensive, we only have it in Bangkok, and then we can fly it to whatever happens. This is based on the urgency, like cyanide antidote. You can see all of the provinces in Thailand. The mercapol, fewer, and then botulinum antitoxin only in Bangkok.
Do you locally produce it? The botulinum?
No.
Very important.
Botulinum is from Germany.
Germany.
And it is heptavalent. I'm sorry, trivalent. Trivalent. We only have we only procure about 10 vials a year because we don't have that much, maybe. Yeah. And this is the web online that any hospital in Thailand can access, and they can know exactly. It's in real time. You can pinpoint the antidote, antivenom in real time, and you know the stock in real time.
Yeah, we have a similar thing called antivenom index.
Yeah,
all poison centers have access to it, so that they know where.
Yeah.
Exotic.
And you can put
Only exotic?
No, we have both. Everybody else has non-exotics, right? It's the exotics that you have to procure because you need it, and they're not available. So, based on the zoos, based on the various research institutes, like in Tucson, we have an agreement with Phoenix Zoo because we have our own exotics and our own snakes. So we have an agreement with them to keep certain number of vials of exotic snake antivenom.
Yeah, it's everywhere in the US like this. In Atlanta, the same thing. I did the exotic thing by drill at the zoo Atlanta. They also have a whole refrigerator for antivenom from outside the country. Yeah, any kind of toxic animal they have, and if the antivenom is available, they have all of those antivenom in the fridge. Okay. I'm going to finish soon. So after we put everything, we want to know like what kind of antivenom, what is the antidote, what is the distance that we can go, number, address, hospital, and then we can know exactly where we should go for. And relevant changes after we have this project is adjusting the sub-national stocking and distribution of antivenom to match the local prevalence of snakebite cases, resulted in more efficient stock management and also reduce the cost. So how much we reduce it? You can see here it's about $2 million US, and in 2012 from $2.2 million down to $1.2 million in 2013 to 2016. It's about 50% cost reduction. And this is because we for example, when antivenom is like 6 months, it's going to expire, and then they relocate that antivenom to another place that has high turnover rate of the antivenom, something like that. And this is is already published and also on the lesson from the field on the WHO website. You can look it up. And for the summary of the main lesson learned, the strong and sustained policy support and full funding from the national budget ensure adequate supply of essential antidote and also antivenom. And a web-based centralized procurement and distribution ensure these essential medicine were available, minimize cost, reduce waste, and save lives. Thank you.
Thank you very much. So at that time, we'll progress to the next session on the debate on pre-medications. Dr. Mohammed Al-Muhammad.
Yeah. Good afternoon. So as I totally agree with Dr. Ashraf, our community different than USA. So I remember in the emergency department once there is a family of 5 people. They came to the emergency because they found there is a snake in one of the rooms. They are seeking to be examined and to be screened because they get scared and maybe they had a venomous from this snake. But yeah, people, they are always seeking to have an intervention. You have to do something for us, otherwise you are not a good doctor, or will go and complain. Even if they have a problem after 10 years, they will say, oh, that's because they missed that snake. So I will start my talk about debate actually. So it is a debate regarding the pre-medication. So just to convince you, this is my aim actually, my main objective to convince you with what I will do is to give the pre-medication before the antivenom. To convince people, they are very expert in this field. It's one of the difficult things, but again, I will try my best to convince you. So for things like this is a controversial, we depend on many things, not only the evidence base or the study, we depend on the experience, we depend on what we are feeling. So especially we are talking of working in emergency department, there is a lot of factors, not only studies or papers written before 10 years, before done in different ways. So I will not try to repeat the things what you mentioned, but imagine that when you have a patient, he developed an anaphylaxis after you give him antivenom. This is a very nightmare for us as an emergency physician. I remember one case, he developed angioedema, and I thought, I tell myself, if the time go back, I will give him everything to avoid this bad situation. So there is a lot of antivenom reaction, which is sometimes gets severe, to get him worse, which will be difficult. So you need to work more and more. So instead of just you give him antivenom, after that you shift it to start to intubate this patient, start him and medication is a lot of medication to save his life. There is an antivenom reaction, which is you described it just briefly. There is an IgE-mediated anaphylactic, and there is non-IgE-mediated anaphylactic explained, and there is also virogenic and the serum sickness, which is late. So this anti-serum, it is not 100% safe. It carry a lot of risk. So this is just an estimation that's it's reached to up 50%. The adverse reaction and severe systemic anaphylaxis, which is the most important things when the patient become hypotensive, cyanosis, altered level of consciousness, develop in up to 40% of these cases. There is variation in the percentage of the reaction. It's all the literature reviews depend on the production of the antivenom. Antivenom, it's not produced everywhere the similar. As one of you he mentioned it before, in the old one, now they have different technique of producing. Each country they develop it in their own way. So that carry different percentage of anaphylaxis, of complications. But depend mainly on these things. What's medication we use? Adrenaline and antihistamine and corticosteroid. So this medication we use to give it in emergency medicine. And actually this is a nice medication. So most of the time patient coming sick, you give it, you become happy. So if I give it to this patient as a pre-medication, what's the harm of that? So let us see what's the evidence behind it, or is there any good literature supporting that? So I will be biased a little. So this one study is low dose subcutaneous adrenaline to prevent acute adverse reaction to antivenom serum in people bitten by snake, which is a randomized placebo-controlled trial. They found that a reduction from 43% to 11% if you give low dose subcutaneous adrenaline as a pre-medication. And there is no adverse reaction to the adrenaline were observed in this study. With limitation of these studies, but again, there show big changes in reduction from 43 to 11% from that side effects. So
where was this study and what was the type of antivenom? Do you know?
This is what I'm trying to avoid.
Okay.
I think
that's cheating argument.
No, I mean
that's a cheating argument.
No, that's what I mentioned. Yeah, that's why it's different. So you can't generalize everywhere because the antivenom not similar in everywhere. But this is one study showed it's in the BMJ journal. This is another study in the Medical Journal of Australia. Parallel infusion of hydrocortisone, chlorpheniramine plus injection to prevent adverse reaction to antivenom for snake bites. This they found approximately 80% in the first two group to 52 in the pre-medicated group. So they compare, they make it people they give him placebo, and the other group they give him hydrocortisone and chlorpheniramine, and they found there's a reduction in the first group up to 52% in the reaction. Another studies which is apparent marked reduction in early antivenom reaction compared to historical control. This one, what he did, he collect all the historical from, he collect from 220 to 2006, and he start to give the people pre-medication and he compared with the previous one. Yeah, and he found there is a big adverse reaction from 47 to 2%. There is a lot of things regarding the study. One, the antivenom, it was different before and now it's different. Also here in this study he used previously there was a fast drip. Now in this study they started to make it a slow drip, the anti-serum. So this could be another factor, but we should consider these things as a factor also to reduce this adverse reaction. So just make it, just as an emergency physician or as toxicologist, you want to give this anti-serum. It's better to anticipate than to react. So if you face one case in real life, patient he develops severe anaphylaxis, he will say, listen, I will give every patient pre-medication. I don't care for what all this is because this could reduce. Yeah, well, I know. Maybe this patient, he will develop, even you gave him, but at least you are anticipating this one by our preventing, especially if you are not sure about the purity of your antivenom, you are not sure about this, how they produce it and how there is this side reactions. So this is just, I tried my best to convince you. I'm sure you are convinced.
Thank you, Mr. Mohammed. We'll do the other part discussion.
Mohammed, he will try now, he convinced you.
No, we'll finish and then we give them 2 minutes or 2 minutes to discuss.
Okay, now I would like to talk about the mechanism of this pre-medication. For me, I will not give any pre-medications. They are using 3 medications, steroids, antihistamines, and catecholamines. So just to understand why I will not use these medications, I have to understand what is the mechanism of action of anaphylaxis and how these drugs can help us to treat adverse reactions. Then some evidence from the literature. So basically, antivenom is an effective medication to treat snake bites, but the problem is in the safety. A lot of adverse reactions has been there in the literature for a long time. Yes, it has been improved, but still, like in some studies, in some studies, adverse reactions reached up to 50%, and in some other studies, adverse reaction has been at around 10%. So there is a varieties in adverse reaction, and this is most likely secondary to the quality of the antivenom. So instead of trying to treat these adverse reaction, why not to put our efforts to improve the quality of production and to see why there's variations between the different manufacturers. So these are types of hypersensitivity reactions. Most of the reactions that we see with secondary to antivenom are antibody mediated. We have type 1, which is IgE mediated reactions, type 2, and type 2 is non-IgE mediated. and type 3 is the serum sickness or the delayed one. So basically we have to understand the mechanism of each one of these hypersensitivity reactions and how we can treat them. So the first one is IgE mediated. Basically IgE mediated anaphylactic reactions are early. So and the main cause for these reactions is the presence of IgE against any component of antivenom. Antivenom, there's proteins and antigens. So if injected in someone and he's having IgE against any component of the antivenom, then they will develop this type of reaction. So this is an example of how these reactions will develop. This is the mast cell, and inside the mast cell we have a lot of inflammatory mediators, including histamines, leukotrienes, and prostaglandins, and other inflammatory mediators like TNF alpha, interleukin, 4, 5, 6, and the others. So basically, once there is interaction between the IgE and the proteins, this will cause degranulation of the mast cell and will release inflammatory mediators, and this is the cause of these adverse reactions. So for example, what will happen if histamine is released? You will start to have, because we have histamine receptors distributed everywhere, so they can cause bronchoconstriction, they can cause itching and skin rash, urticaria, increase acid secretion in the stomach. Also, they can act in blood vessels, cause vasodilatation and inflammation of sinuses. So, to summarize, IgE-mediated anaphylaxis are early, caused by basophil degranulation and release of histamine. So these are clinical manifestations. So the other types of hypersensitivity reactions are related to complement activation, and they will have the same clinical manifestations. Like they will have increased vascular permeability, vasodilatation, skin rash, urticaria, and pain. So the last one, which is the late reaction or the serum sickness, this usually occur within like 5 days to 2 weeks after antivenom administration, and basically the patient, they will present with skin rash, sometimes renal involvement in form of glomerulonephritis and lymphadenopathy. So these are the medication that has been used for treatment of the adverse reactions. The first one, histamines, steroids, and catecholamines. So if we go for histamines, they will act on antihistamines, they will act on H1 receptors. So basically they will they will prevent adverse reactions secondary to histamine. They will not prevent release of histamine. Histamine is released already. So even if you will give a pre-medication, they will not prevent release of histamine. So only they will counteract the actions of histamine. So theoretically speaking, they are not useful in treatment of these adverse reactions. So what about the literature about histamines and steroids and preventing adverse reactions? This study, what was the result of this study? Yes, they found that pre-treatment with low dose adrenaline was safe and reduced the risk of acute severe reactions to snake antivenom. But for others, adrenaline significantly reduced severe reactions to antivenom by 43 in 1 hour, 43% at 1 hour, and by 38% up to 48 hours. So steroid and antihistamine, they did not. So there's no evidence from this study that antihistamine and steroid can prevent adverse reactions. Yes, there's evidence about only adrenaline. So again, another study, in this study again, they concluded that yes, there's evidence about adrenaline, but the other antihistamine and steroids, there's no evidence that they can prevent adverse reactions. Again, this is another study done in Australia. They found that hypersensitivity reactions occurred in 11 out of 40 patients receiving any form of pre-medications. like so 28%, and 2 of the 11 given adrenaline for pre-medication versus 20 of 86 not receiving pre-medication. So they concluded in this study hyperstate reactions were not common, but most were not severe, and pre-medication was not associated with any reduction in these adverse reactions. Even, for example, steroids, we know that in steroids, they will need time to act. Like they cannot, yes, they have a lot of beneficial effects, but their effect will take time. They cannot like, they have effects like within a short time, like 1 hour or minutes. They need time to suppress immunity, decrease antibody production, etc. So steroids, there was no evidence about their beneficial effects to prevent these adverse reactions. Antihistamine also, it has been found no beneficial effects in preventing adverse reactions secondary to antivenom. Adrenaline only has some evidence. So in conclusion, so there's lack of evidence about the efficacy of hydrocortisone, lack of any evidence about the efficacy of antihistamine, some evidence about efficacy of adrenaline in reducing adverse reactions. But again, most of these studies, yes, they mentioned that some beneficial effect from adrenaline, but none of these studies has been talking about the side effects. Adrenaline is a medication, and also it has a lot of adverse effects, including cardiovascular and CNS manifestation. So none of these studies has been talking about the adverse effect of adrenaline. Even why I will give a medication without clear evidence, and also it has some adverse effects. Also, adrenaline can be used as like a treatment. Once these patients they will develop the adverse reactions, yes, it successfully can be used as a treatment, not as a prophylaxis. So we need further clinical studies needed to confirm the efficacy of these medications. In conclusion, we have to concentrate on the quality of antivenom, not on like to prevent interact to the adverse effects. If the quality has been improved, most of these adverse reaction will be improved. In some countries, like it reaches up to 50%, which is very high, and in some countries 10%. And for us in Saudi Arabia, it's less than 5% that we have an adverse reaction. So we have to concentrate on improving the quality of antivenom. Until this improvement will take place, so we have just to be prepared. If any patient is having any adverse reaction, management of acute as well as delayed reaction may occur. So just be prepared. Like, okay, use steroids, adrenaline, everything should be prepared in the health department. If the patient is having any of these adverse effects, then it can be used as a treatment. But for prophylaxis, I will not use these medications.
So can we have maybe he has a response? 1 minute, 1 minute.
Okay, so as he mentioned, he put all the studies that supported. The first one, they said low dose in epinephrine, it's reduced the adverse reaction. And there is a study also that I mentioned that said there is no reaction from the epinephrine when they use it. Agree with the antivenom, the quality, yes, but again, we don't know. We don't have that. You can't say 100%, and there is variety between the adverse reaction between this antivenom. So for me, working in emergency, instead of I observe the patients, keep myself busy and prepare the nurses, I will give pre-medication and I have fun.
Have you tried to do your own study for those to really randomize those with pre-medication, those without pre-medication? If you really have experience with that?
No, actually,
you just pre-medicate everyone.
Yeah, my experience only one case when I faced it when he developed a severe anaphylaxis. This is my personal. After that, I said I will give pre-medication whatever they recommend because I was in very bad situation with the patient. He developed angioedema and he has hypotensive from the medication. The family, they said, what did you give him? I gave him, this is the treatment you're seeking for.
Again, like in these studies, one study, the adverse reaction was 50%. Like for this patient, I prefer not to give the antivenom. If you give antivenom, you will have 50% of your patients, they will have severe adverse reaction. I don't know what is the mortality rate from the snake inflammation, but it will not reach 50%. So it's a very high adverse reaction, most likely secondary to the quality of these antivenoms. We have to concentrate on how we can improve the quality of antivenom production. Plus, again, steroids, their effect will be delayed. They will not have immediate actions. Histamines, again, they will not prevent, antihistamines, they will not prevent release of histamine. So even if you use them, they are not useful. Only they can counteract the mechanism of already released histamine. Adrenaline, yes, there's some.
So you agree with me? You will give adrenaline as a agreement?
No.
So he agreed. He said.
There's evidence, but still, adverse actions of adrenaline have serious adverse actions, including cardiovascular, CNS manifestation. Adrenaline is useful as a treatment. Why I will not use it as a treatment? Like if someone is having hypertension, why I can use it as a treatment choice, not like as a pre-medication. This is
we'll have let's say 2 divisions, three divisions, because
okay.
Make it quick, please.
I think we should weigh between risk and benefit. And same thing in Thailand, we only have 3% of anaphylactoid reaction. Whatever, like anaphylactoid, anaphylaxis reaction, we only have 3%. Yes, if your country have like 80% of reaction, I would think it would be benefit from pre-medication. But for 3%, even the reduction rate, like 30%, you will, reduce from 3% to 1%. But you have to think about the risk of giving the pre-medication as well.
Can I ask you a question?
Yeah.
You have an experience with anaphylaxis reaction.
So
the adrenaline, in what form you give it in that scenario?
I did not give pre-medication at all.
No.
Yeah.
You have somebody who developed anaphylaxis reaction in front of you. This is a practical dilemma. So how would you give that adrenaline?
I am.
And that might be a problem for people who have.
I know. I'm going to talk about it. We discussed about this too. So we only use we call it insulin. The insulin syringe, which is very small.
But that's a problem. You are giving it subcutaneously,
yes.
And you're probably not treating it.
No.
Because the absorption is very, very slow.
Yeah.
And this is a dilemma, and I've had that question before. I don't know what's.
We only have really low range.
Yeah, we treat. If you can give it IV, you gotta give it IV.
If
you can't give it
that's
IV,
what I did.
then IM. But you need actually a good sized needle, and you need to have it needs to be 1.5 inches to go into muscle.
And then you're gonna get a hematoma.
Let me give you a scenario. I think what we forget, and in toxicology especially, because we're acute care, we forget the psychosomatic. I would tell you, I'm sitting here, I'm very atopic, okay? I haven't been given antivenom, but I would suggest you come. I tend to scratch. I say, come rub my arm right now, and you see how it's bumped and how red it is. It's a reaction for which, probably if I was in the ED, everybody would have given me they would have given me antihistamines, epinephrine, and such. And we forget these things. Lots of times patients who come in, and that, I was just looking at a study that was done by our colleague Jeff Ispitz. They're looking at anaphylactoid reaction. Anaphylactoid reaction is also, lots of it has to do with the psychosomatic response of the patient. And I would suggest the effect of the antihistamines is more psychological.
Yeah.
Okay? If you give them benzodiazepine, they probably would not become as atopic. As again, come here, rub my arm, and you'll see that, oh my God, Shirazi over here needs epinephrine. No, Shirazi's over here is atopic and just sits, even his clothing causes him to have lumps and bumps. And those are the type of things that we forget. Also, psychological response. One of the main things, I've gone and talked to toxicologists who they claim that snake bite, envenomations, doesn't have any psychological response. Now, most of us know that, and nobody has done clinical trials, that you don't need a snake bite and then being rushed to the hospital in order to develop night terrors or psychosomatic response. I have a tox clinic, and I see these type of things to it. But most toxicologists, you ask them, say, acutely, no, they don't exist. You know, and they say it like they know it, you know, and it's easy to come up with, again, what I say, nonsense. And not everything, you gotta realize that not everything can be reproduced by clinical trials. Just because you had 50 people in each arm, okay, it doesn't mean that everybody in that arm is gonna develop, you know, any type of anaphylactic reaction so that you would treat or not treat. So,
I had just, till the time you have anti-snake venom which comes from, which has a foreign protein, you have the risk of a reaction, right? Now, he's made a very valid point. Find out what is your proportion. Even if it is 50%, you know, you are giving pre-medication to 50% people, and it is a medication. It can have potential consequences.
I've seen MIs actually.
That's very, very important.
So who is using pre-medication? Just to know.
I don't.
Who's using?
I don't. We stopped the infusion and
for pre-medication, I might give somebody a benzo just to chill them out. Because I know that person is going to have not an allergic reaction, but they're going to go haywire. But I've seen MIs actually from, you know, severe bee envenomation, and they gave the individual adrenaline, 89-year-old, and of course the troponin bumped.
But you have to be careful in tropical country, because if you give benzo, many patients got bitten by cobra.
Yeah.
They have, you know, neurotoxicity, and you don't know if this is from
I would
venom
suggest,
or this is from
I would
benzo.
suggest,
We're talking about 1 milligram or 2
we're
milligrams.
talking about looking at your patient and treating.
I know.
The fact that it's most of the medicine, you know, the reason it's also art is that you know which patient of yours is going to freak out, okay? And I had a guy that jumped out of a plane, his parachute didn't open, a military guy, landed, broke both legs, tib, fib, and his femur. And he's sitting there, I'm saying, asking him, do you need any pain medication? No, sir. Okay? And then I have a guy that his finger, you know, has a nail, is, oh my God, get the surgeon in here.
It's very individualistic. That's what
That's totally
at the end of the day.
So welcome, Bruno, and now we diverge to Europe.
We'll talk about a French experience with Botrops lanceolatus. So you will tell me why France has a position in the snake envenomation symposium. Because of course in Europe there is really not an issue with snake bites. In France we have only vipers, and we have two kinds of venomous vipers, Viper virus and Viper aspis, and we have a very efficient antidote, which is FAB2, and we just give one vial and generally everything is okay. But maybe you don't know that France has also some islands in South America. And we have Guyana, with probably the second largest Amazonian area in the world after Brazil. And we have also a small island called Martinique, you see on the map. And so this is a French overseas department in West Indies. And what is very interesting in Martinique is that we have a snake there called Botrops lanceolatus, which is a specificity of this island. It is a member of the Crotalidae family. It is considered to be the only snake involved in this Caribbean island, and it is venomous. And you find this snake only in this island. So this is the only venomous snake in this island, and you don't find it anywhere else. And it is estimated to have about 20 to 30 reported bites per year. Also, probably it is underestimated. So the toxicity is related to the botrops family. So you have what we call botropic syndrome, with the rapid onset of lesions at the right side with hemorrhage, pain, edema, leading to dermomyonecrosis and local infections with possible severe sequela, and also systemic symptoms with circulation impairments and hemorrhage syndrome and acute renal failure, as you know. That is the botropic syndrome. Botropic syndrome, of course, I will not focus on that, I will go rapidly, is related to various enzymes contained in the venom that may act at different levels, inducing vasoconstriction, activating platelets, activating plasma coagulation, and even fibrinolysis. Botrops lanceolatus is quite different. It belongs to the botropic family, but it has a quite different outcome. The major enzymes in its venom is hemorrhagic snake venom, zinc-dependent metalloproteinase called hemorrhagins, and these, in this species, is responsible for vascular damage with endothelium injuries. So it inhibits the coagulation, it activates platelets, and it results mainly in prothrombic activity. So with botrops lanceolatus, you will have the local signs, symptoms like with all botrops, but from a systemic aspect, you will have thrombotic complications in 30% of the patients, with brain, cardiac, and pulmonary thrombosis. So no hemorrhage, only thrombosis. And this will lead to organ failure, mainly neurorespiratory failure, death in about 15% of the patients if not treated, and sequela in 20%. So the difference, it belongs to the botrop family, but it doesn't give hemorrhage, but just thrombosis, extensive thrombosis due to endothelium activation. Hopefully, we have antivenom, which is botrofab antivenom, so which is just a specific antivenom dedicated to this snake, produced by Pasteur Mérieux. It is obtained from hyperimmunized horses. It contains FAB2 fragments mainly. As explained with other antivenom, its regimen is adapted to the inflammation severity. It was synthesized and first administered in 1993, and it is effective to prevent the consequences of severe bites if rapidly infused, and of course its effectiveness is function of the rapidity you administer it. And till 2000, we have a certain experience with this antivenom. It was published, this experience was published in Toxicon in 2006. About 110 patients received this antivenom therapy within 6 hours and no thrombotic complication occurred. So it is quite efficient. Unfortunately, since 2000, complications reappear. So this is, I think, interesting for MENA region because we will see the reasons. And we performed a study on the 10 years between 2000 and 2010. So this study included about 100 patients envenomated with botrops lanceolatus and treated with botrofab. So you see that, of course, we have the local usual complications, but strokes reappear. Where it was 0, some stroke reappear, and even one death occur. 9 patients developed ischemic strokes, including 6 who received the botrofab within the 6 first hours. So suggesting some resistance to this botrofab that appeared since 2000. Of course, not all neurological lesions were clinically symptomatic. And you see that MRI performed in these patients showed various thromboses in various areas, but what was characteristic that almost all the patients have infarcts in the territory of the posterior inferior cerebellar artery. So, like, this was very specific with this bite, this alveolation. You see here that they have a bilateral infarction in their cerebellar artery, and the branch, the posterior and inferior branch, called pica. So all these patients had a pica infarction, which is not usually in common patients. There were also other CNS injuries. Here you see injuries in the caudate and bioccipital infarcts. Here bilateral junctional infarcts. And in all these lesions you have diffuse thrombotic microangiopathy. This is the case of the patients who died with infarct in the cerebral cortex and obstruction of the small arteries. We, of course, studied the clinical parameters of these patients, and we saw that all these patients presented biological signs of coagulopathy and elevated troponin in comparison to those who did not experience these complications, and these appear to be key indicators to suspect brain thrombosis. And thrombocytopenia was, in the multivariate analysis, suggestive of this neurological accident with the pica complication. So, to summarize a little bit, so during the first 10 years of the 21st century, we observed an elevation in the incidence of stroke despite the treatment of the patient with an efficient antivenom with an incidence of about 9%, a mechanism of ischemia induced by coagulopathy, with a documented case of endothelial injury with microangiopathy, and in almost all the patients junctional thrombosis in the brain, reaching mainly the pica artery. And this is, of course, very specific to our botrops. So we questioned about the decrease of efficiency of our antivenom, which is specific and proved to be efficient 10 years before. So maybe the same case that we observed. So we hypothesized different possibilities. The one which is probably the most exact is modification of the venom composition, because the first antivenom was produced based on 25 snakes caught in Martinique, and they were adult snakes. And probably the new, younger snakes developed new epitopes, and those are not covered by the botrofab antivenom. So it was requested to produce a new antivenom, and about 130 snakes were caught in Martinique, mainly now young snakes, and their venom was collected, and a new botrofab 2 was produced by the Pasteur Mérieux, because this is a public health issue in France, in Martinique. So a new antivenom was produced in 2011, and since that date we made an observational prospective study, and this is the preliminary results of 7 years of observations. We treated 160 patients with grade 3 and 4 envenomation with this new antivenom. So the delay was relatively short because the island is small. And of course, we observed local complications in the majority of the patients, edema, pain, bleeding, but lower rate of troponin elevation and no thrombotic complications of fatality in none of these patients. So we were able to produce a new antivenom based on changing in the epitopes, and it seems now to be efficient again. So
Bruno,
we appear to be optimistic.
Younger snakes had the epitope?
Sorry?
Younger snakes have the
Yes,
epitope?
yes. This is the hypothesis, but it is not still not proved.
Okay.
So we have a collaboration with the team of Guterres. I don't know if you know him. He's a scientist that make experimental studies on snakes, and he's currently studying these antigens from different species, and especially that to answer this
So originally they were all adult snakes? That
yes, originally the first antivenom was produced from adult snakes.
Okay.
Then there was a failure 10 years later, and we produced a new antivenom, and now it's efficient. So we can be optimistic for the future. Unfortunately, no, because last year the pharmaceutical company decided to stop manufacturing this new antivenom. So now we have also some problems, and now we are testing different Brazilian, Panamanian, and South American antidotes that are directed against Botrophab families to see if they act on this specific Botrophab lanceolatus and to choose the most efficient one, because probably in 2 or 3 years when the storages will be finished, there will be no effective antidote to this Botrophab.
Who produces it? What pharmaceutical?
Pasteur Mérieux,
Okay.
which is a French
Is it
company.
Is it a private?
Yes, it's a private. Yes.
Okay. It's Institut Pasteur, it used to be a public.
It is. Institut Pasteur is private too.
Ah, private.
Yes, yes. And Pasteur Mérieux is probably connected to Institut Pasteur, but it's not Institut Pasteur. So I thought that this experience could be interesting for you because here we have some certainties about the epidemiology, because we know exactly the snake, because if you have an envenomation in Martinique, you are sure that this is only this snake, because there is no other venomous snake, and this snake only exists in Martinique, nowhere else, and it is different from all other Botrops snake family because of its mechanism. Botrop venom usually activate coagulation and results in hemorrhage, while here it mainly destroys the endothelium and results in thrombosis.
Now we see the same thing in terms of juvenile rattlesnakes are much more coagulopathic and without getting any signs or symptoms of local toxicity. So, but in our case, using higher amount of antivenom actually reverses that. And it was interesting, and we presented this. We had 5 patients that we found actually hypercoagulable state. We found DVTs in them, which we had never seen before. So it's interesting that you have this problem, but this probably exists in other snakes, but not as prominent, because the epitopes are not.
What is here very curious is always the same localization of thrombosis in the patient that were treated, so that maybe the antivenom is not totally inefficient, but it allows to control the coagulation, but not in this very small area of the cerebellum.
Because that's
where
a
it is not
different
controlled.
question.
And how many vials do you give?
So the number of vials is adapted to the severity of the clinical features, and all these patients who develop this have the maximum recommended dosage.
Which was?
But I don't remember, but I can send you the exact dosage. but it's the maximum one, but we don't test higher dosage. But normally it's adapted to, as it was shown, to the LD50 in mice, extended to humans, the same adaptation, with cases where the venom concentration was measured. Also, of course, in all these cases, no venom was measured, but it is adapted, and especially we have 10-year period of more than 100 cases treated with this antivenom with complete efficiency. So there was something new.
So about the juvenile snake with the more systemic effect, there's a study already published in Clintox as well. It's from Brazil. And I was the reviewer for this study, and they capture the juvenile compared with the adult, and they compare the systemic effect and local reaction. It's true. There's evidence already published.
Thank you very much.
We know it's true. I see it all the time.
Yeah, but we need to prove it.
Thank you. So I know it's not time, but if you spare us a few minutes, just a difficult case that. Sorry, can
we'll
just,
start?
Yeah,
We'll talk after.
We
have
our,
our,
yeah,
we have our
Because
own
we are just running late, so it's.
reaction.
I thought just to share this. I discussed this earlier with Dr. Ashish Kalla, and maybe I get, some feedbacks from you guys. So this is a case as a 16-year-old boy who I received the call through phone consultation on Saturday around mid of the day. And basically they think that this is a case of snake envenomation who has been receiving antivenom, but there is no improvement. And in the initial presentation, you can see that that's his foot. Usually we see, like in most of the cases that we see like quite good marks of the fangs. And you see significant swelling in most of the cases. But in this case, it looks like only bruises. There is no fangs, only like a bruise, and there was no swelling. And so the patient presented to that hospital 2 days prior to the call. The patient having significant severe coagulopathy. His INR was more than 10, his BT was more than 120, and his fibrinogen was undetectable. The rest of his examination was unremarkable, and the rest of his lab investigations, including CBC, liver function test, and renal function test, was normal. Okay, and he is not known to have any medical problem previously. So, according to the protocol that we are using, and it's not really clear, but we have this protocol from the Ministry of Health, and it's been published by an infectious disease team in the country. So, and then they categorize the envenomation into no envenomation, mild to moderate, and severe envenomation based on the local manifestation as well as the lab investigation. So if you have a patient who is having severe coagulopathy, defined as a BT more than 50 seconds, INR more than 3, or platelets less than 50, or fibrinogen in less than 0.75 gram per deciliter, then that's considered as severe envenomation. And in that case, patient should get the maximum dose of the snake antivenom. The snake antivenom that we are using is the Saudi polyvalent, because we don't produce our own. And the maximum dose is 10 vials, which is 100 milligram. So 10 ml in each vial. So by the time, yeah.
The cost to the patient and the cost to you?
Yes.
No cost there is no cost to the patient.
There's like non-profit. It's distributed for free for all the hospitals in the kingdom and even to GCC countries. Like I think it's free. Yes, you are getting it.
No, we are getting it, but with the minimal fees. So it's not. And the patient is free
I've
of
been
charge.
to the antivenom institute in the Haras. I've been there.
So eventually, by the time they called me, he was already 48 hours, and so he received around 70 vials, because according to the protocol, they should repeat the coagulation profile every 6 hours. If it is the same, then they repeat the same dose that they started with. So, and then they called, and the reason they called basically because on Saturday, so he presented on Thursday in the evening time, around 9 p.m., And then on Saturday, patient started to develop a sublingual hematoma, but there is no active bleeding, and so they were worried. They already gave him FFP and cryoprecipitates, and his repeated coagulation was almost the same. So we said, and that's when we thought this could be refractory coagulopathy. And so I don't know what is your thoughts about refractory coagulopathy, because this was my first case of that scenario. So I looked into the literature. I didn't find much, except some is from the Indian literature, where they say they, instead of giving boluses of the antivenom, they give infusion. So we decided to give him infusion over 6 hours. So the same dose that he received, 100 ml of the antivenom, we give it over 6 hours, and we continue giving the FFP and the cryoprecipitate. The repeated coagulation after 6 hours and after stopping the infusion was getting better. So we decided to continue with the same scenario. Unfortunately, the repeated coagulation after another 6 hours was still, again, severely deranged with an INR more than 10 and BT more than 120 with undetectable fibrinogen, though he showed a little bit of improvement in his parameters the 6 hours before that. So at that point, we decided to shift the patient to the, I will not go with this, but we decided to shift the patient to the tertiary care hospital where I work, and then I saw the patient in the ICU. The patient was fully awake and conscious, but he had a significant swelling in the low part here on the chin and in his face. And there is a hematoma underneath the tongue, but there is no active bleeding when he arrived to the hospital. And so we did the coagulation again, we repeated the coagulation, and then at that time I contacted Dr. Ashish Palla, and he said, you might cause more harm by giving the antivenom. Let's stop the antivenom and treat the coagulopathy with the blood products and see. So we continued giving him the blood products, but his condition started to deteriorate. The swelling was getting worse, and he started to have bleeding from the gums. In fact, he was like, I think he was swallowing his blood into the lungs, and he was...
So before you go forward, why did you not continue with antivenom and blood products?
Okay,
because
so...
that's what we usually
that's what
recommend.
we usually do, yes. So...
If you have a severe coagulopathy,
yes.
And again, the only time, when Ashish wasn't here, the only time I saw was the internist was giving blood products without antivenom, and the patient was getting worse.
Yeah, so we are talking about, so that what the envenomation happened on Thursday, and we are talking about already Tuesday by the time. So it's almost like 5 days from the time of the exposure. So that's when, according to their experience, basically there is no harm after, there is no effect of the antivenom after 48 hours from the exposure.
Why I say that?
Yeah.
I showed you the data, 900 ml ASV down to 150 to 200. When you give anti-snake venom, you will only take out what is circulating in the blood.
Yeah.
Once you've given your maximum dose, whatever you continue giving is not going to take anything out of the tissue if it is already bound. If it has caused harm,
if it's already bound, but that's making an assumption
No,
that
see-
there is not equilibrium between the, and it's not coming out and going
And also
back
the
in.
site of action of the venom is in blood, not in tissue in this case.
So carry on, doctor, and then we'll have a discussion.
Yeah, so let's see what happens.
Yeah, see what
So
happens.
you stop the antivenom, you're
So
giving
I
blood
stopped
product,
antivenom,
Ashish is involved.
Is he incubated now?
No, so yes.
Yes. Why didn't you consider that? I saw it was like a very huge zone here, where there was the
No, that's the heel.
That's
That
the
was
heel.
the heel.
That's the heel.
Okay.
That's
But
what the
didn't you not consider to operate this area?
to get the blood. No,
Yeah.
when
No,
I'm
to get the
So that
the venom.
picture.
So
If
the
a depot-
idea is, if there is a venom depot,
Depot, that's what he's
that
talking about.
you can. The fact is, I'm not a believer in venom depot, but we last 3 weeks, our venom
Yes.
last 3 weeks.
And there is
We know
there is
because
big
of the climate.
evidence, there is big data. You can still give antivenoms even up to 7 days, 10 days.
But with the bleeding, how they're gonna
So-
do a myotomy? Or
So
something?
no, but it's not. He basically that picture. He did not develop any significant swelling. By the way, it was only ecchymosis at the same day. By the second day, the ecchymosis almost disappeared.
And did
It's
we do
not
any
like
studies on this
Did he
individual?
really have a snake bite?
Or did he have other
So,
issues?
Was it something else?
So at this point, we started to question whether he actually had a snake envenomation or not. So we go back to the history. In fact, we involved the environmental health, and they went to the area and did screen. They did not find anything unusual. He was playing in a coastal. He lives in a coastal area near to the beach, and then he. That's what they say. Right? So they basically, he was playing bare feet, and then he went back home. On the way back home, it was already dark. He felt that he stepped on something soft, and then he felt the pain. And then he heard the sound of the sound with something like, but he did not see anything. So we were not sure whether this was snake envenomation or not. But because we were not sure whether the antivenom was helping the patient or not, we decided to stop the antivenom, continue with the FFP and cryoprecipitate, and do CT chest and head, because he was becoming a little bit drowsy and he was complaining of chest pain. And the CT did not show any intracranial hemorrhage or bleeding. He had a significant myositis over this area only, not any other part. His foot was completely fine, and he had an evidence of pulmonary hemorrhage bilaterally. Maybe he swallowed the blood because of the active. So we decided electively to do tracheostomy for him to reserve his airway just in case. Then we involved the hematologist at that point, and then the hematologist said we have to do exchange transfusion. And that's another thing that came up in the management. In such a patient with refractory coagulopathy, should we consider exchange transfusion in an early stage rather than waiting for him until that stage? He received 2 sessions of exchange transfusion. He received multiple FFPs and cryoprecipitate, and eventually in the subsequent 48 hours, his coagulation profile improved. He became better, and then we discharged him home without any sequelae.
Did you send any sample of the blood for venom detection anywhere in the world?
Anywhere in the world, I reserved a sample, but I don't have anywhere in the world.
See, there are only 2 possibilities when you have a refractory coagulopathy. One, you are dealing with, and your ASV is not working. One, you are dealing with a venom or a snake, which you're not covering with your ASV.
Yeah, most likely.
So what's the point giving liters of ASV to a patient when you're not covering it? I don't know.
So,
I was very kind
exactly.
of...
So now it's when, according to the snakes that we have, there are certain type of species that there was a question, there was a paper published in 2004 by a hepatologist, and he basically questioned the efficacy of this the Saudi polyvalent antivenom against one kind of species, which is Echis omanensis, and it can cause delayed coagulopathy and maybe refractory coagulopathy.
Do you have a sea snake?
We have sea snakes. We thought about the sea snakes, but the sea snakes.
Reaction, no microbinuria.
So I looked into even the anatomy of the sea snakes. The type of the teeth appearance is totally different, and you have to have a local side because they have to have a long contact with the patient before they do the envenomation part. So which was not there in this patient.
And the CK would be.
He was not. He was not on the shore, by the way. He was in between the houses. So
we have hump nose pit vipers, which are not covered by ASV. And we reported cases, we had multiple cases, one of them we reported was a severe intraperitoneal hematoma. And he stopped bleeding because there was a compression effect.
it couldn't grow anymore.
Yeah.
So there was a compression effect and it stopped bleeding on its own.
He survived.
We didn't touch that hematoma and he survived.
You have a picture?
And there was then a spontaneous resolution. But we didn't give any more anti-snake venom to them.
And no other studies was done on this kid to find out whether he had any type of a pre-existing condition?
Yes, yes.
You mean they
That was the second
protein C, protein S deficiency, factor V Leiden.
They did, all were negative. He's been followed up by the hematologist. All his labs.
So which test did they do? When you say all of them?
I have to double check, but it's the complements.
GCB, usually the routine in the region, either the GCBD,
C3 and C and
yeah, the factors, the Leidens,
Factor
V Leidens, and there's third one they do. There's third one. That's the routine hemolysis.
And they check for hemophilia.
And hemophilia, yes, that's the
standard of care.
They check for factor VIII deficiency.
No, that G6PD.
We have had it so that the patient appears to have a wart, and then we check him, and they had one of the hemophilia.
So the question I think for
and we had to give them factors.
So the question now for
No, because you talked about two hypotheses. I understood the first one, that the species is not covered. Okay. What is the second?
One is the species is not covered. Second is that if you have a circulating venom which you are not taking out, when you were saying, then the exchange transfusion. But you can't offer it upfront if you don't know what this person is having. So, see, your 99% or 99.9% of your snake bites would be the usual snake bites, which would respond to whatever anti-snake venom you give. So you can't offer it upfront. So if it is not working, then you but adult exchange transfusion is a dangerous thing. It's not so simple.
So it's clear from this case, as far as I understood it, correct me if I'm wrong, that you still have a venom active in the body because you're pouring the factors and it's not correcting.
But anti-snake venom is not acting because it's not.
So that's the second part. No, the second. So the first part.
Well, so the first part. It might be that your antivenom actually is not working at all.
It's not working at all. So that's why I said stop it.
So what I'm trying to say is, you have a venom you're not neutralizing. It's still in there because the evidence that you're giving a lot of factors and it's not correcting.
Yes.
So the question for us here is, where do you go from there? Do you sit it out? Clearly, you could not sit it out with this patient.
Yeah, I mean, if you look at the timing, when do you decide that your antivenom is not working?
See, we stopped giving. We stopped giving in 24 hours time whatever maximum antivenom we have given.
I agree.
And after that, no more. If it is not working, then it won't work. So there's no point continue giving antibiotics. You're not
what's the
doing
maximum
anything.
for you? You have decided maximum dose.
300 ml.
Yeah. But the fact of the matter is, for us, there is no maximum. I have given to the gentleman that was bleeding like, and he was the son of a hematologist. I gave him, I think it was the highest number of Crofab ever given in the U.S., which was close to 68 vials that he received. But we were able to control it.
But when you see an improvement,
and he got improvement.
So you're given the first one.
See, you were also giving blood products. So he may have responded to the blood products, not ASV.
This guy came in, we got him under control, went to the medicine service after ICU and us let him go. He reoccurred, which is a common thing. The guy didn't know what to do, gave him blood products, got worse and worse. He dropped his hemoglobin to the level of 4. Then we got him back, gave him again antivenom, okay? And we loaded him, till he stopped bleeding, and then we gave him blood. And he got better.
This patient did not respond at all to the antivenom.
Yeah, but that's the difference. You believe that your antivenom is going to work.
Yeah.
But she did not believe the antivenom.
The antivenom is
I
going to
thought
work.
initially it will work.
Maybe it's a different species not covered.
Yeah, that's what we that's what I
so,
That's a possibility.
so you had a belief with what you're dealing with.
So,
if
the other
there's
thing is,
uncertainty-
you gotta sort of have an idea about your epitopes, right?
Yeah.
And I would tell you that majority of our snakes, now let's say it was, even if you get somebody that comes in with neurologic and we say, hey, this is not one of our rattlesnakes, right? And what I have seen, at least in my practice, that you give them enough antivenom, you cover many of those epitopes. And they do so. Crowfab is not built for cobras. Have I seen a good effect? Yes. And that's why now there's a move about what they call an international antivenom or uniform antivenom. Because lots of these epitopes reoccur. And, you know, who was it that put Brian Fry's study? Brian Fry studied the good part of his study, not his human touch, but the good part of the study is that he has shown that venom and reoccurrence of venom in various species has to do with the strategy that's common. So those epitopes that work in terms of a biological warfare against another species tend to reoccur. Scorpions utilize it, spiders utilize it, snakes utilize it, you know, marine, they utilize it. So sometimes you have to give massive amounts, and it does work. I know what she says, but our experience is totally opposite of that.
I'd not agree with that, I'm sorry.
It's
But
okay.
because, you know, if it is not working, either prove that there is venom in the blood, right? If you can't, then it becomes very difficult. Then the only way which I think is, if you don't have an antidote for a poison, you do an exchange. We do that for malaria. We did it, we've done it for severe complicated malaria, very high parasitemia. The patient is going down, you just take out the blood and give him
fresh blood.
Fresh blood. You don't only take out the parasite, you also take out the cytokines and the inflammatory mediators, which are causing majority of the damage.
But I wonder in her case, maybe if they started early on the bolus and then in the maintenance of fusion, he would have not deteriorated, because when they started again the infusion, he improved for a short time.
So
So
that's
this means that, I don't know.
But how?
So I would tell you
Apparently
what-
not much.
It was-
Because I'm the only one in the US that usually uses an infusion. As a matter of fact, we're presenting at Venom Week. We had over 45 cases of continuous infusion, and we show effect, but it has a significant effect. And what I use it, and I'll be honest with you, is there are many times that even toxicologists want to bolus. They say, no, let's give an infusion over. And what it does is it also mitigates the venom effects of the toxicologist's extra activity.
So we don't, as you know, in general, the antivenom that we are dealing with, we don't give it as bolus. We give it an infusion over 1 hour.
Yeah,
So that's
we always
usually-
give it an infusion
That's-
over 1
But
hour.
we just
Well,
extended
that's what
the
we call a
infusion.
bolus.
So, but we just extended the
Right.
infusion. But the problem is that when we recommended the infusion, the treating physician in the other facility, they added the blood products during that period.
Oh.
And then we tested the coagulation. So we were not sure it's because of the infusion or it's because of the
Do they
blood
give any
products.
antibiotics too?
They give him antibiotics, yes.
They give them
They give him
everything.
antibiotics.
Thank you very, very much.
That's very good.
Can we have, if you don't mind, can we have a picture all of us?
Acil tıp uzmanlarına ve sağlık çalışanlarına yöneltilen şiddet hastalara, hasta yakınlarına, topluma ve tüm insanlığa yöneltilen şiddettir.
Ne olursunuz unutmayın. Size rağmen olmaz.
Ama sizinle iyi olur.
The commonest source of CO poisoning in Turkey?
In Turkey, there is furnaces and heat stoves, most of the common cause. We don't have that much suicidal carbon monoxide poisonings. Big majority of the cases are accidental poisonings because of like I said, furnaces or heat stoves. But we don't have the exact data, so it's anecdotal data.
Any problem with using the hyperbaric oxygen therapy? Is it easy to send the patient there?
Yeah, we have we have several centers in Istanbul, and I'm speaking for Istanbul. So if you had a patient with carbon monoxide poisoning and you think that he or she needed hyperbaric oxygen treatment, you can connect with hyperbaric chamber doctors, and they gladly accept it. But in some outbreaks, we have some delays for treatment because of the patient overload.
Any other question?
Yes. She will talk about caustic injection. Dr. Betül Başaran, she graduated from Hacettepe University Faculty of Medicine and certified as an anesthesiologist from the same faculty, Department of Anesthesiology and Reanimation. Dr. Başaran is an associated professor of anesthesiology and currently working in Konya Training and Research Hospital. She is interested in critical care and toxicology. Yes, please.
Good afternoon, my colleagues. It's my pleasure to be with you as an anesthesiologist. And I come from Konya, the city of Rumi, that's located at the center of Anatolia. Okay, pardon. You see? I declare that I have no conflict of interest about my speech. My topic is corrosive ingestion. As you know, it is rare and potentially devastating event, and there is limited experience, personal experience about it. Uncertainty persists about the best clinical practice. and wide range of cases can be seen from the mild to severe, and the CT scan is accepted as a best methodology for the management of the cases according to worldwide scientific literature. And esophageal stricture, as you may know, is the main common consequence. During the management of these cases, multidisciplinary approach is accepted. And you may see what clinicians must be participate to manage these cases. I am the anesthesiologist, the second one. And the first one always is the emergency care physicians. And, pardon. As you may know, two age groups are most risky group. First one is children aged between the 2 and 6 years. I think about 80% of the cases are children between 2 and 6 years, and 20% of cases are adult. They are aged between the 30 and 40 years. And two main agents responsible for the caustic ingestion strictures, caustic ingestion burns. And the first one is the strong acid. Strong acid may cause coagulative necrosis, esophageal scar formation, and also strong acid can cause prolonged gastric contact. The second one is alkali. And the alkali can cause the cofactive necrosis, but the difference from the acid is the alkalis can cause in all the GI tracts, can affect all the GI tracts. It's the difference from the strong acids. Major determinant of the outcome, as you may guess, is the quantity. Early contact of the poison control center is must. Why must? Systemic effects of the corrosive agents can affect the medical situation of the patients. As you may see, hypocalcemia, hyponatremia, hypokalemia, and acidosis are seen in these patients. And as you may guess, the pathological changes seen in all the gastrointestinal tracts, especially in the esophagus. If we mention about the management strategies, primary aim of this management strategy should be the survival, and secondary aims are to prevent early complications, to prevent late sequelae, also to provide nutritional anatomy and quality of life. Pardon. And I want to mention about the initial approach because I know that especially in the initial approach times you are the emergency physicians include these cases. Identification of the corrosive agent is most important. Time from the ingestion must be questioned, and the evaluation of the context must be asked to patient, whether it is accident or intentional. Co-ingestion of the drugs must be questioned, and additional risk factors related to patients must be asked to the patients or the nearest. We should make some maneuvers according to increase the esophageal passage, but we should not make to attempt neutralize the pH of the caustic ingestion. The effectiveness of nasogastric tubes controversial. Some scientific data try to use it, but some not. Some of them not. Evaluation of gastrointestinal injuries. In case of evaluation, distinguishment is most important. And unluckily, signs of the digestive perforation are rare, and according to it, symptoms are not correlate with the signs. So it shows us signs and symptoms signs plus symptoms do not show the full necrosis. Some of the patients may be admitted to emergency department with a better condition, but in these patients we can also see the full necrosis of the esophagus or the stomach. In these patients, some of the blood-related parameters can be changed. You may see here. And the second blue one is important for the anesthesiologist because during the perioperative period, we must deal with severe acidosis and renal failure with management of fluids. And esophagogastrostomy means state of emergency management, but it should be done between the 3 and 48 hours. Later, it's not important at the later cases. Zargar classification used during the flexible gastroendoscopy. You see here the Zargar classification. Endoscopic grading can predict systemic complications, respiratory failure, emergency mortality, also provide nutritional anatomy, but endoscopic grading have two major drawbacks. One of them is inability to predict accurately depth of necrosis, as I said before. The second one is endoscopic grading is mostly observer dependent. And after the 24 and 48 hours, potential disadvantages of misinterpretation can be seen. I want to mostly talk about the computed tomography. It is new data for me, I think. I know before this speech presentation, I know only the endoscopic grading. But during my search about this speech, I learned about the computed tomography, and I learned about that the World Society of Emergency Surgery support application of CT. It surprises to me too much, I think. There are some conflicted data. Some of them related to endoscopic grading is the best. Some of them related to computed tomography grading is the best. But the Lancet supports both of them. The last data from the Lancet also supports, firstly, the computed tomography if needed. If the computed tomography shows us the full thickness necrosis, then the gastroendoscopy should be done. Management algorithms, nearly scientific data supports management algorithms based on computed tomography, as I said before. In all the cases, the computed tomography should be done. After the computed tomography, the related data should be added to gastroendoscopy related data. But computed tomography also has two disadvantages. One of them is renal failure, and the second one is the allergy to contrast agents, as you may know. I want to mention about little information about the emergency surgery. Emergency surgery, as you may guess, has high mortality rate, has high morbidity rate. Also, the bad factors that affect patients related to surgery are advanced stage tracheobronchial injuries, emergency esophageal resection, extended resections, and severe derangement of laboratory test results, as I mentioned before. If you look at the surgical procedures, we mostly see in the operating theater the esophagogastrectomy. It is accepted as the most common emergency procedure. The second one is the damage control surgery. In the caustic ingestion, patients can be accepted as a major trauma patients. As you may know, major trauma patients should be dealt as a damage control surgery, not only one-sided surgery. The caustic ingestion patients can be accepted as there.
Please take the sentence. Take the presentation finish, please.
Okay. Partial gastric resection is not recommended, and concomitant necrosis of organs can cause extended resections. Non-surgical management, as I mentioned before, from the non-surgical management, early nutritional support is very important, and total parenteral nutrition must be inserted to non-surgical management. Delays sequelae, as you know, hemorrhage, fistula formation, and malignancy are delayed sequelae. In low resource settings, limited access to medical expertise is seen and poor follow-up seen. In low resource settings, primary aim should be prevention of malnutrition and gastrostomy. And future directions are there: optimal management of corrosive ingestion, quality of life after caustic ingestion, and preventive measures. Thank you.
Thank you, Dr. Bambasharan. Do you have any question or contribution?
I guess I have a question and a comment. The question is, did you come across any use of steroids and antibiotics in such cases?
Yes, I have read about the steroids and antibiotics, but they have no place during the routine management of cases.
Okay, then
it should be think case by case. In the routine practical cases, they have no place for the steroids or the antibiotics.
So, and then the comment basically is a majority of these injuries that have been related to caustics will have a very bad outcome despite the measures that you are doing initially. And so preventive measures, probably the standard of care, and increase the awareness about how difficult these cases should be addressed in a very confirmative way.
Yes,
you are right. Thank you. Other question?
Thank you for your presentation. I want to ask you, I met with lots of causative ingestions in my clinic, and most of the time pediatric surgeons are stopping the oral intake and waiting for 24 hours. So what's your emergency surgery rates for caustic congestion
for the pediatric cases? Yes.
In your hospital?
I have 1 year training period in the pediatric surgery department before the anesthesiology training. And the pediatric surgeons mostly deal with cases with waiting, not the operating. They wait, not operate. In the Konya Training and Research Hospital, we did not take any pediatric patients for the emergency resection.
Thank you. Other question? Any other question? Thank you very much.
It's going to talk about the colchicine poisoning. Please welcome Dr. Azura Shiki. I'm not sure, I'm sorry if I pronounced it incorrectly.
Azura Kiki.
Kiki,
yeah.
Okay. Please welcome Dr. Kiki.
Thank you. Thank you, Chairman.
Dr. Kiki is a medical toxicologist working at the Pavia Poison Control Center in Italy.
Thank you for the presentation, and thank you to the organization to invite me to talk about colchicine poisoning. So let's start talking about colchicine. It's a drug derived from the alkaloid component of the plant Colchicum autumnale. Colchicine binds the tubulin dimer and inhibiting the formation and function of microtubules. So, with consequent anti-inflammatory and antimitotic properties commonly used in therapy for the gouty arthritis or familial Mediterranean fever or other rheumatic disease. It's a poisoning with high mortality rate, and it can occur after intentional overdose, therapeutic errors, or ingestion of plant containing colchicine that are often confused with edible plants. The most widespread in Italy is Colchicum autumnale, often collected instead of wild garlic or Allium ursinum. So to my knowledge, different species of colchicum are present on the MENA region with a huge variability, and all plants are poisonous with the high concentration of colchicine in bulb, corn, and seeds. And this is an example, the species of colchicum present in Turkey with difference to autumn and spring. So in order to understand the basis of colchicine poisoning treatment, it is important to point out some toxicokinetic characteristics of colchicine. And the first one, because of the antimitotic action of tubulin, because on the microtubules, because of the presence ubiquitary of the microtubules in cells, of course, colchicine has a really narrow therapeutic index. Is a variable bioavailability between 25 and 50%, a volume of distribution of up to 21 liter per kilo, plasma protein binding between 10 and 50%, is metabolized by liver with biliary secretion and enterohepatic cycle, and with a renal elimination of 20% and elimination half-life variable on renal elimination rate from 10 to 37 hours. So evaluate reliable prognosticator is important to early identify patients at risk of death who should benefit from aggressive treatments. It's therefore important to evaluate the ingested dose because it is known that if patient ingested less than 0.5 milligram per kilo of colchicine, death rate is less than 5%. But if patient ingested more than 0.8 milligram per kilo of colchicine, death rate increased to 90%. Of course, this does not apply with plant ingestion, but only with drugs. So other known prognosticators in colchicine poisoning are prothrombin index less than 20% or white blood cell count more than 80 gram per liter in the first 24 hours, or the onset of cardiogenic shock of ARDS in the first 72 hours. And the exact prognostic value of plasma colchicine concentration is still unknown and I think is not currently available in emergency practice. So drug-drug interaction may cause clinical picture more severe than predicted when, in example, colchicine is co-ingested with the cytochrome inhibitors 3A4 or PGP inhibitors. And clinical picture of colchicine poisoning is characterized by three phases. The first one is called gastroenteric phase, from 2 to 24 hours from ingestion, and is characterized by abdominal pain, vomitus, and diarrhea with consequent volume depletion and peripheral leukocytosis. The phase 2, that is the most dangerous for the patient and is the one in which patient could die because of the onset of cardiovascular shock, respiratory distress, myelosuppression, thrombocytopenia, rhabdomyolysis, and multi-organ failure. If patients survive from this phase, we observe the third phase, that is the recovery phase, with rebound leukocytosis and alopecia. So, based on this information, it is important to identify the key points of the management, especially in the first hour from ED presentation. And I want to start by discussing a case that I consider explicative to this objective. This is the case of a 42-year-old woman for which Pavia Poison Control Center was called from extra-hospital emergency setting. And because the patient had taken 30 minutes before, a dose of 0.85 milligram per kilo of colchicine, so of course a potential lethal dose. So the first indication was perform gastric lavage in the first emergency room available. 1 hour later, the patient arrived in a near emergency hospital, Elitto Hospital of Italy. So the potential severity of the evolution was explained and the importance of the decontamination was underlined, but what happened was that because of the discovery of a pregnancy test positive, the patient was transferred to a bigger hospital with an OB-GYN service, but gastrointestinal decontamination was still not performed. So unfortunately, patient died on day 5 of hospitalization, yes. So sad. But I think it's very important because starting from this, I want to focus your attention on the first hour management of colchicine poisoning, in which is important history evaluation, of course, suspect colchicine poisoning, calculate ingested dose, consider drug-drug interaction, start laboratory test monitoring, but mainly is important to perform gastrointestinal decontamination. And as soon as possible after ingestion and after emergency room admission. Gastrointestinal decontamination should be considered even some hours after ingestion, and even if many hours after ingestion if patients co-ingested opioids or other peristalsis inhibitor. So gastrointestinal decontamination should be based on gastric lavage, oral administration of activated charcoal, multiple dose of charcoal because of the enterohepatic cycle, and whole bowel irrigation. So, I made the photo. So the rest of the treatment is mainly based on the phase of the poisoning, is based on is supportive treatment, so fluids in case of vomitus and diarrhea, vasopressor in case of cardiogenic shock, mechanical ventilation in case of ARDS, hemodialysis that is ineffective because of the large volume of distribution, but should be considered if the patient has acute kidney injury, and of course colonial growth factor or transfusions in case of myelosuppression. So other considerations should be made on exceptional treatment like ECMO. There are reported some cases with favorable outcome, but colchicine poisoning results in multi-organ failure independently from cardiac failure, so actually evidence is still lacking, and the anticorpal fragments anti-colchicine that are still unavailable. So in conclusions, colchicine poisoning is characterized by high mortality rate, should be considered if patients came to emergency room with the gastrointestinal symptom after ingestion of self-collected plants. It's important to evaluate early known prognosticator to early identify patients at risk of death, and gastrointestinal decontamination must not be delayed and should be considered also late decontamination if co-ingestion, as I said, of opioids or other peristalsis inhibitor. Consider drug-drug interaction if you see a clinical picture severe more than prognosticated, and treatment is mainly supportive and needs to be aggressive. Thank you.
Any question? Have you had any experience with the ECMO?
Yes and not. Not in Italy. I have experience in France, but unfortunately was a patient with amphora who died, because actually, as I said, ECMO acts on the cardiac failure, but not on acute kidney injury, rhabdomyolysis, and the multi-organ failure. So unfortunately, no. But was a patient with late arrival at hospital. Actually, it's the most important thing. If patient absorb all colchicine that had taken, the mortality rate is really high.
Okay. Thank you for your presentation.
Thank you.
Chairman of Emergency Department at Hamad Medical Corporation, Qatar. Please welcome.
Thank you very much. Good evening, everybody. I know it's late, and I hope everybody still have some power. So it is basic, so it will not be a lot of information there, but let's see if we can get some benefit from it. So first of all, let me ask anyone from the audience, how many cases of methemoglobin you diagnosed in the last year? So anybody diagnosed methemoglobin in the last 1 year? By raising hand? So nobody. So that means it's rare disease. That's making my life easy. Okay? So I'm talking now about methemoglobinemia. I don't have anything to disclose. We'll talk about what is methemoglobinemia and what is the most common agent that induce methemoglobin in the blood and in formation. and if there is any doubt, how we treat it, how the presentation. We'll go through that in very brief. So let's start with the case. This is a real case, came to us in Qatar. It's a 27-year-old man who has ingested some chemicals for intentional, for suicidal attempt. He brought by ambulance with complaint of dizziness and drowsiness. And the things he ingested was this chemical. It calls indoxacarb. It is non-organophosphate insecticide. It was used there widely for agricultural issues, and he ingested quite a large amount of it for suicidal attempt. So this is the first physical examination of it. He is not tachycardic, blood pressure was fine. Saturation, which was significantly low to 82 to 87% in 100% room air. And he was severely cyanosed, but he was GCS is still okay. So ECG done for him, it was normal. There was no ECG changes, but we found in the lab investigation that his methemoglobin level was 79, which is very, very high. Okay, one of the highest level that diagnosed in our region. Maybe there is one in UK with Dr. Kamor, 91 you got? 90.3. So this is the maximum was diagnosed. Anyway, so this patient is having a very high level of methemoglobin, and he is already symptomatic. He is cyanotic, and he has a dizziness, some headache, tiredness, and he was actually not in the main tertiary hospital. He was in a peripheral hospital, and they started do intubation for him. Then they call a poison center for such case, and we told him, okay, this is a case already you diagnosed, so you start treatment. Okay, so let's have some basics about physiology. This is the hemoglobin, deoxygenated hemoglobin when there is no oxygen. And when there is a binding of oxygen, it binds to it and change it to oxyhemoglobin. With extra oxygen, the bond of oxygen become more tight. Okay, what happens in methemoglobinemia is that there is oxidant that oxidize the iron from ferrous to ferric, and that oxidant form cannot bind the oxygen, it binds the water, and then there will be a formation of functional anemia, where there is enough hemoglobin, enough oxygen, but it's not delivered to the tissue because of this problem. Okay, so the clinical manifestation, as we mentioned, it actually depends on what stage or what is the percentage of methemoglobin. It can come with chocolate cyanosis, chocolate colored. Patient may present it with headache, CNS manifestation, sometimes GI upset, dyspnea. It may reach in a high level to a CNS seizure or coma, or sometimes, if not treated well, it may go to a death. Okay, so it depends, as we mentioned, is to the level. Usually the level below 20, no symptoms, or very mild cyanosis, and up to 20%, you can see the cyanosis clearly, and patient may have mild symptoms of nausea, some dizziness is there. If it reaches to 50, the cyanosis will become more profound, and the symptoms become more headache, more dizziness, nausea, vomiting, dyspnea, and in severe cases up to 70, it has become with CNS manifestation of seizure, coma, and the cyanosis become more severe, more clear, and more than 70 usually is lethal. So it is a significant problem, so that leads to death. So we need to recognize it. And we need to do some investigation. So usually the color of blood, it is chocolate color. This due to the presence of methemoglobin level very high, and it's actually correlate also with the percentage of methemoglobin in the blood. Okay, ABG usually it has a normal partial oxygen pressure, but the saturation is very low because the saturation machine, it is actually reading the wavelengths of the oxygen in the blood. That's caused something called saturation gap, and that helps us also in diagnosing the methemoglobin. Okay, so then you do for either ABG or VBG, whereas usually in new machines have a methemoglobin level, which is the diagnostic. So basically, usually the patient with an exposure to the forming agent of methemoglobin, plus the clinical presentation, that will give you a clear clue what is going on. Methemoglobin causes usually either a congenital, like this cytochrome B deficiency or reductase deficiency, whereas actually the reduction of methemoglobin to the normal hemoglobin, and this is usually the mechanism of action, because in the body there is a usual up to 1% production of methemoglobin on normal basis, and this mechanism will reduce the methemoglobin level in the blood if there is no agent that increase the dose of methemoglobin. Okay, so acquired is a very long list of medications, chemicals, and a lot of things. And you can see dapsone is one of the most common anti-malaria. We treated methemoglobin with amyl nitrate, and amyl nitrate can cause methemoglobinemia also. And there is, which is a well-known nitrate, which we are using for chest pain and other things. It can cause, and anything with nitrogen and nitrate can cause methemoglobinemia, like a fire, smoke inhalation. So not only CO poisoning, but it can also comes with methemoglobinemia. So as we mentioned, the treatment is simple and is gold standard, methylene blue. Methylene blue is antidote of methemoglobinemia. And it can use for other uses also, and we put the methemoglobinemia in the, down in the list. Okay, so the pharmacokinetics, the mechanism, maximum effect is up to 30 minutes. If we use it in small doses, we get our reflex of oxidizing agent to hemoglobin again, but if we are using it in high concentration, we actually producing methemoglobin again. So elimination by bile, feces, and urine. So what is the dosage? And when we use it usually in very high concentration, more than 20, and in the patient is symptomatic. So we give it in a dose 1 to 2 milligram per kg over 5 minutes, slow infusion. Okay, and till the cyanosis resolved, usually within 30 minutes. But this is not the final point we are looking for. It's actually we repeat the level, okay, and we see it's actually dropping down, okay. So caution in G6PD, because methemoglobinemia in G6PD patient can cause hemolysis. So if there is a need, real need, then we need to use it with caution, with very small dose of 1 milligram per kg only. And we keep rechecking methemoglobin and hemolysis pictures, okay? And the side effects, as I mentioned, is according to the dose, how much we are giving. Okay, back to our cases, we give 2 milligram per kg for him, and the cyanosis and the clinical improvement was so fast, within 20 minutes. Patient was intubated in the second day, and he was admitted to a psychiatric hospital because of his suicidal attempt. By this, I conclude my lecture, and happy to receive any question.
Any question? No? Because we are running out of time, so thank you so much.
Thank you.
Next presenter, medical toxicologist and also board certified in emergency medicine. He also obtained postgraduate diploma in medical toxicology from Cardiff University in the United Kingdom. Please welcome Dr. Walid. I'm sorry, Dr. Awad.
Thank you very much. Assalamu alaikum. We're gonna go within the coming 10 minutes fast through this subject, which is the aluminum phosphates. I think they put it, the moderators and the organizer, they put it in this session because they know the severity of this substance. I don't have anything to disclose. We're gonna go in this lecture through the background, the epidemiology, the toxodynamic, the clinical presentation, the diagnostic workup, and the management. First of all, aluminum phosphate is one of the fumigants, which is non-specific pesticides applied to kill and control rodents, insects, weed seeds, and fungi anywhere in the soil, structures, crops, and grains. And it have different chemicals, physicals, and mechanism of toxicity. Aluminum phosphate is the most common one. It have different metals. It's, the most common is the aluminum, but there is zinc, magnesium, and calcium. It is, as we said, used for protect grains held in soils, ships, and during the transportation. Because of its low cost and high effectiveness, freedom from toxic residues, and lack of adverse effect on the seed's viability. That's why they use it widely. In the last 35 years, the cases of aluminum phosphate increase dramatically, and this is mainly because of the advanced transportation and manufacturing of this substance, as well as start to be used as a suicidal substance for suicidal purpose. It is very common in agriculture society, India, Sri Lanka, Iran, Jordan, and Morocco in the region. And that's obviously because it is available in that society, and it is less and rare in Europe and North America. Aluminum phosphates, the first picture, it is the most widely available. It is, as it there in the picture, is a greenish tablet with the garlic order, and each tablet has 3 grams of aluminum phosphates. And it contains also some ammonium carbamates and urea. The zinc phosphides, as in the second picture, look like dark gray powder or crystal. The odor is like rotten fish. Calcium phosphates, as in the third picture, look like reddish brown powder. Aluminum phosphate, actually, when it is mixed with the moisture, ambient moistures, it will give the phosphine gas, which is the main cause of the toxicity, the cytotoxicity, and which is going to lead to the death later. If it is mixed with water, this will lead to rapid release of the phosphine. And this is significant because mainly in the suicidal attempts, they intend to take water on top of these tablets, and this makes the condition faster and make the severity worse. The mechanism of toxicity is it will be through blocking the electron chain transport by inhibiting the cytochrome oxidase and formation of reactive free hydroxyl radicals and reduce the glutathione. This will result into lipid peroxidations, protein denitrations of the cell's membrane, and interfere with the enzymatic function and synthesis of protein. It also causes acute respiratory distress syndrome through direct injury to the alveolar capillary membranes and by producing oxidative injury. It also have effect in inhibit the cholinesterase activities, but this not to the clinical significant level. The toxic dose for the zinc metals, it's around 1 gram, and the death can happen if there is around 4 gram ingestion. For the aluminum phosphates, 500 milligram can be fatal. The smell, the garlic smell, it is very common with aluminum phosphate. So if you smell it in your department, you have to think about aluminum phosphates. The clinical manifestation, it depends on the dose, the route of entry, if it is ingested or inhalated, the time to exposure, how long, especially for the inhalation. And the aluminum phosphate, it have rapid effect than the zinc phosphate. So the zinc phosphate, the symptoms can happen even after 40 minutes. The clinical manifestation, if it is mild, then it will be GI symptoms. It will be around, it will be mainly about the GI symptoms, nausea, vomiting, diarrhea, discomfort of the abdomen, epigastric, and tachycardia as a result. Moderate to severe symptoms, it will involve multiple systems, the GI, and this even can reach to hepatic failure, cardiovascular, hypotension, palpitation, cardiovascular collapse, and dysarrhythmia. CNS, secondary to the hypoxia, there will be dizziness, confusion, convulsion, and coma. Respiratory, tachypneic, and ARDS. Renal failure, metabolic acidosis, airway irritation, especially in inhalation. The diagnostic test, what is in this slide is usually, actually, it measures the complication of this substance into the body, the CBS and the coagulation profile to check for the intravascular hemolysis, methemoglobinemia, and DIC. The chemistry looking for the hypokalemia, hypo and hypermagnesemia, hyper and hypoglycemia, acid-base balance, metabolic acidosis, the main, and there will be also respiratory acidosis and lactic acidosis. Acute kidney injury, we expected in these cases, chest X-ray to check for the ARDS. ECG it is very common to see ECG change in these cases, but it is variable. Tachycardia is the most common and to start with. Then there will be T wave and ST change. Ventricular and atrial tachyarrhythmia is common. Echo to measure the effect on the heart. There will be a dysfunction, dilatation, hypokinesia, and akinesia of the left ventricles. As a toxicologist, we don't recommend to do a specific test for the phosgene to measure the phosphine in the blood or in the urine because it is rapidly oxidized. But for some reasons, medico-legally, you may need to do that. The most specific and sensitive test is the gas chromatograph. Also, silver nitrate test can be done through the gastric contained and exhaled breath. Treatment start with decontamination. Inhalation, for inhalation cases, the best is to remove the patient from the source and supply oxygen as needed. For the continuous exposure, remove the clothes and try to decontaminate with water. Don't forget the eye. For ingested cases, the best to be done within the first 1 or 2 hours. There is a limited evidence about the activated charcoal, but if it happened within the first 1 hour, then no harm to do it. There is experimental talk about oral administration of sodium bicarb to prevent the conversion of aluminum phosphate to phosphine. Also, there is a case report suggested using potassium permanganate as an adjuvant to oxidize the phosphine to non-toxic phosphates. Vegetable oils and liquid paraffin in vitro suggested inhibit the conversion of aluminum phosphate to phosphine, and there is also single case report. Secondary contamination, definitely we are recommending everyone to have his precaution, but you have to keep in your mind that the particular mask will not prevent phosphine from reaching to you. And there is studies from India. It showed that the staff, hospital staff there, although they didn't have using their specific precaution, but there is nothing, no positive effect on them. There is no specific antidote for treatment. The main treatment is conservative and supportive treatment till the toxin leave the body. Shouldn't be delayed to confirm the diagnosis. And according to the symptoms, the treatment, the arrhythmia using antiarrhythmic, shock, try to use to be guided by the CVB and wedge pressure. Use vasoactive sub-agent according to the need, pacemakers and mechanical support according to the need. The ARDS, ventilatory support. Metabolic acidosis, you can use the sodium bicarb, hemodialysis according to the need, and don't forget to correct the electrolytes. Some studied about use of NAC in acetylcysteine. There is experimental in animal, and then human studies show some beneficial. Brodoxime, both the phosphine and aluminum inhibit acetylcholinesterase, as we said earlier, but to a level not significant. Further study needed in this subject. Hyperbaric oxygen, experimental data show that it improves the survival time of rates and poisonous rates, and with no change in the mortality rate. Magnesium sulfates act as a cell membrane stabilizer factor and reduce the incidence of fatal dysarrhythmia. Antioxidant effect and combat with the free radicals, and this is controversial. Hemodialysis to help the effect of the renal failure cases and to clear the acidosis. Insulin and glucose, it is suggested by some investigator because of it, the effect of insulin promote the energy and produce production of carbohydrate and restore the calcium flux, which improve the myocardial contractility. Trimetazidine, this is help in approach the BVCs and bigeminase. This is an in-case report and act as preserve oxidative metabolism, which need further investigation. Intra-aortic balloon pump to help the pressure. ECMO in circulatory failure, not formally evaluated. And thank you.
Thank you for your presentation. Any question? No. I have seen some country recommend using the coconut oil to lavage instead of using like fluid water.
Actually they do it from the local experience, but there is no proven study for that. If it will not help, it will not harm.
I would think so, because oil can cause pneumonitis as well if the patient aspirates. Right. Thank you so much.
Is currently working as emergency medicine consultant in Ankara University Faculty of Medicine, Department of Emergency Medicine. Yes, please.
Good afternoon, everyone. I will thank the organizing committee and scientific committee for the great conference. I will talk about methanol poisoning for the golden hour management in the ED. Methanol, also known as wood alcohol, is a commonly used solvent in various solutions. But in Turkey, we see methanol in imitated labeled alcohol. A commonly used organic solvent contains in perfumes, photocopic fluid, windshield washing fluid, and perfumes also. Methanol is a component of the many industrial solvents and poorly adulterated alcoholic beverages. Methanol poisoning is a common problem worldwide, especially in the lower socioeconomical countries, and methanol may cause outbreaks. Methanol is relatively low toxic, but metabolism is formic acid is a toxic. First, upon ingestion, methanol absorbed in the gastrointestinal tract rapidly, then metabolized in the liver. First, methanol transformed the formaldehyde with enzyme alcohol dehydrogenase is a slower reaction. Then formaldehyde transformed to formic acid with enzyme aldehyde dehydrogenase, and lastly, formic acid oxidized to carbon dioxide and hydrogen, presence of cofactor tetrahydrofolate. Last enzyme, formic acid to the carbon dioxide to the hydrogen, carbon dioxide and water, a very slow reaction. So in methanol toxicity, formic acid accumulates and causes metabolic acidosis. Who is at risk? Children. Accidentally overdoses of any solvents containing perfume, windshield washing fluid. Suicide attempts with methanol is uncommon. Methanol toxicity may be seen in alcoholic persons. Alcoholic persons consume methanol as a substitute for ethanol. And developing countries like ours, imitated, labeled alcohol or homemade alcohol may cause methanol poisoning. In a recently publication from our clinic, an ingestion is very, very high, but in this case report, we report a transdermal methanol intoxication. 58 years old woman presented to emergency medicine with dizziness, diplopia, nausea, vomiting. She uses a methanol-containing solution for knee pain. In Turkey, we say that a ratio yağı in fluid for food heater. We treated this patient with ethanol, sodium bicarbonate, and hemodialysis, and completely resoluted. No sequelae. Initial symptoms of methanol intoxication generally occur after ingestion of 12 and 24 hours later. This latency is due to enzymatic reaction and may be affected with concomitant and ethanol ingestion and volume of methanol ingestion. Methanol blood peak levels 30 to 90 minutes after following ingestions. Initially, methanol toxicity manifests like ethanol toxicity, inebriation, ataxia, disinhibition. Following a latent period, patient may develop headache, nausea, vomiting, epigastric pain. At later stage, drowsiness to augmentation and coma may occur. Seizures may occur due to metabolic derangements and brain injury. Blindness is a very well-known complication of the methanol toxicity. Vision loss is due to formic acid. First, we see flashes of light and blurring, and then scotomata and complex loss of vision may be seen. When we think about methanol toxicity, any patient with any causes altered mental status with acidosis, we think methanol toxicity, ethylene glycol intoxication, cocaine poisoning, inhalant poisoning, complex partial seizures, carbon monoxide poisoning, in keeping in mind these patients. Basic workup includes finger stick glucose, acetaminophen salicylate levels, electrocardiogram, pregnancy test. Electrocardiogram is important for the toxic alcohols. Ethylene glycol causes QT prolongation, and methanol does not. Specific workups are arterial dilute gases, electrolytes, and anion gap, BUN creatinine, serum ethanol level, serum osmolarity, methanol, ethylene glycol, and isopropyl alcohol levels, if available, and pancreatic enzyme. Methanol toxicity can cause hemorrhagic pancreatitis, a very common unreported cases. Serum osmolarity first increase, then decrease, accompanied with increase in anionic gap. Methanol toxicity affects the basal ganglia, primarily putamen. Bilateral putaminal necrosis and varying degree of hemorrhages can be seen in brain CT and brain MRI. This is not specific for the methanol toxicity, can be seen in stroke and Wilson disease. Prompt medical care is key to avoid complication of methanol toxicity. Also, antitherapy and hemodialysis is key. Supportive care, airway, breathing, circulation is essential. Antidotal therapy with either fomepizole or ethanol must be started as soon as possible. And hemodialysis is the definitive treatment of the methanol toxicity. Early consultation may be needed, especially in nephrology, neurology, ophthalmology, toxicology, and sodium bicarbonate. Sodium bicarbonate improves metabolic acidosis. Its effect formic acid to the format, conversion formic acid to the format. This may reverse the visual deficits. Format cannot easily damage the retina and optic nerve, but formic acid damages the optic nerve and retina. Dose of sodium bicarbonate is initially 1 to 2 milliequivalent per kilogram in intravenously bolus. Maintenance dose is 20 to 40 milliequivalent per hour. Antidotes, if available, we prefer fomepizole or ethanol. If unavailable, ethanol. Both of them inhibit the enzyme alcohol dehydrogenase. Fomepizole is superior to ethanol because easy to dose, easy to administer, rare side effects. Its disadvantages of the fomepizole is its high cost. Loading dose is 15 milligram per kilogram intravenously. Maintenance dose is 10 milligram per kilogram every 12 hours for 2 days. Ethanol difficult to dose. Frequent testing and infusion adjustment needing, and ethanol irritates veins. Its more limiting effect is sedative and behavioral effects because ethanol inebriates and aspiration risk rises. Hemodialysis removes both methanol and formic acid. Indications are high onion gap metabolic acidosis, evidence of organ damage, especially visual changes. Cofactor therapy may be outlined. Optimize the non-toxic metabolic pathway for the elimination. Doses is 15 milligram in every 6 hours. Thanks for your attention. Any question?
Thank you, Dr. Young. Any question? Or Eddie? Okay. We have seen recently in our country ethanol poisoning is an important issue. Ethanol is an important issue. Yeah. Any question?
Hi, thank you. Just on one of your slides, you suggested that the visual defects can be corrected by sodium bicarb. I'm not sure how accurate is this. And the second point, as far as I know, although formic acid being implicated in the visual sequelae of methanol poisoning, it's not fully understood because formaldehyde, which is one of the metabolites of methanol, which end up leading to formic acid, when people get poisoned by formaldehyde, which was more common in the 70s and 80s, they did not get visual defects. So the notion that formic acid is the culprit is, as far as I know, it's not
100% accurate, and also that's applied to the sodium bicarb. I don't know what's, if everybody else has any other opinion about
it. Visual deficits is due to formic acid's effect on optic nerve and retina, and sodium bicarbonate transforms the formic acid to the formate. It did not readily diffuse the optic nerve and retina. I can think this maybe reverse the visual symptoms. I don't know the mechanism. I don't know.
Okay, thank you. Any question? We listened to important issue from very valuable speaker. Unfortunately, this section ends here. Thank you for listening. And
thank you, for, everyone. So next one is the break, and then we will come back in 15 minutes, okay?
Unfortunately, Dr. Tharwat El-Zahran is ill, and she have to be in her room. So we have the great pleasure to welcome Dr. Ritrak Ohong. Ritrak is the residency program director in the emergency medicine department of Vajira Hospital in Navaminokhadhiraj, sorry for the pronunciation, university in Bangkok, Thailand. He did his fellowship in the US in the Emory program with Ziad Qadzi, and he's specialist of QT measurement with all the methods and QT interpretation when they are influenced by drugs. And he's responsible for the AACT, ACMT, and EIPCCT work group that is in charge of recommendations to measure QT, and we are waiting for these recommendations soon. So he will present us his lecture dedicated to the diagnosis and management of drug-induced QT prolongation. Thank you, Ritrak.
Thank you so much, Mr. Chairman. With my pleasure to present my lecture today. I'm going to talk about diagnosis and management of drug-induced QT prolongation. I thought I had 30 minutes for this lecture, but I just realized that I only have 20 minutes, so I'm going to be fast. But if feel free to ask me after I finish the talk. I have no conflict of interest. And for the outline, I'm going to talk about the introduction, why QT prolongation is so important, QT measurement, how do we do it, and what is the definition of QT prolongation. And about the QT collection formulas, we have some doctors from Australia. They may say, hey, we don't do formula right now, we do QT nomogram. I'm going to talk about that a little bit as well. And we're going to talk about the risk factors for QT prolongation and torsade de pointes. I'm sorry, Dr. Bruno, I may not pronounce torsade de pointes correctly because it's French. Maybe you can correct me later. And okay. And also, I'm going to talk about the management of QT prolongation and torsade de pointes. And I'm going to start with why we are so afraid of QT prolongation, right? So that is the reason. Sometimes, QT prolongation can deteriorate to the torsade de pointes, which is some kind of polymorphic ventricular tachycardia. But most of the cases, torsade de pointes can stop spontaneously, but sometimes it can degenerate to ventricular tachycardia and VF. And what is the incidence of torsade de pointes? Is estimated to be between 1 to 10% of patients receiving QT prolonging drugs. That is from antiarrhythmic drugs, but it may be much lower for non-cardiovascular drugs, for example, SSRI. But we actually don't know exactly what is the incidence rate of the case from Tosadapur, because most of the sudden death cases occur at home. And from this study, we know that the rate of QT prolonging drug medication use is increasing over time from this US study, and it has a sharp rising of the QT prolonging drug use. So I think this may be very important for us. And also in medical toxicology, we have seen a lot of QT prolongation from drug overdose as well. And if you are wondering how can we know what medication can cause QT prolongation, you can go to the crediblmeds.org. If you are so lazy to write down the crediblmeds.org, you can take the picture of the QR code over there, and you can, go to the website by just, one click, okay? In this website, they will give you the categories of QT prolongation risk as a known risk, possible risk, conditional risk, and also drugs to avoid in congenital long QT syndrome. Okay, next one is about how to measure the QT, okay? I think everybody know what is the QT, right? The QT start from the beginning of the Q wave and the end of the T wave. If you have a very nice and very clean ECG like this, it is easy for you to measure, right? You can measure from the beginning of the Q wave, and you can identify the end of the T wave very clearly. But do you know how many types of T wave morphologies? Let's do a game. Who think there's 7 types of T wave? Raise your hand. 8? Raise your hand. 9? No? Okay, one bet. 10. What about the rest of you? Please help me.
12.
Bruno said 12. Okay.
No.
All right, I'm going to give you the answer. So at least 10 morphologies that we know of. So if we have like something like biphasic T wave, how do you measure it? And what about the notch and bifid T wave? How do you measure the QT? And sometimes, you have like the inverted T with a little bit bumped after the end of, after almost the end of the T wave. So how can you measure it? And I'm going to lead to the next question. How many accepted standard methods to measure the QT interval? 1, 2, 3. Who have no idea? Raise your hand. You have no idea? Okay, I'm going to give you some idea about how many methods. So we have 2 accepted methods, okay? I have a quote like accepted because, nobody say what is the standard right now, but most of the study, they only talk about these 2 methods, the tangent method and threshold method, okay? For the tangent method, you draw the tangent line on the steep slope, okay, on the terminal limb of the T wave, and you draw the isoelectric line. The end of the T wave is the intersection between the tangent line and the isoelectric line, okay? But for the threshold method, this pointer is not working on the LCD. I'm so sorry about that. For the threshold method, you just, take a look at the end of the T wave, and when the T wave ends at the isoelectric line, okay? So what about clinical differences about these 2 different methods? Are there any differences, do you think? So this study looked at the difference between the 2 methods, if they are clinically significant. So they had 2 groups of patients. One is the control group. Another group is those who had congenital long QT syndrome, who confirmed by the genetic test. And you can see the tangent method give the shorter QT interval when compared with the threshold method, and that is between 6 milliseconds to 12 milliseconds, and those of number were significant. And what about the diagnostic performances and validity between the two methods? You can see here, when they use the cutoff value of the QT best set by the QT best set as 480 milliseconds as the cutoff for the QT prolongation, you can see the threshold method provided the better sensitivity, almost double compared with the tangent method, while the specificity they are almost the same, and also with the inter-rater and intra-rater validity they are almost the same. It's really high, above 0.95. So the author concluded that the tangent provided a shorter QT interval compared with the threshold, but both methods have a high validity. And for the diagnostic performances, each method yields different results. So when you want to apply the cutoff value from whatever study you want to your patient, you just make sure you follow their method, okay? If they use tangent method or they use the threshold method, you cannot use interchangeably because it's gonna cause the wrong assumption. And what is the normal QT interval? This is defined by the normal population at the 99th percentile. In men, it's defined as at the 470 milliseconds. In women, 480 milliseconds. And the risk of arrhythmia is going to increase 2 to 3 times if the QTc is higher than 500 milliseconds. But we also have to think about, we know that the QT has dependency with the heart rate. So how can you correct the QT by the heart rate? This is going to be my question again. What formula do you use? Beset? Raise your hand. You don't raise your hand, but you not. Okay, good. At least I know that you are interacting with me. Beset again? Yes? Okay. Who is using Fidelia? No? No? Okay. Rota-Haju formula? Never heard of it, right? Okay. Next one, another formula? No idea. Framingham, Hodges? No? All right. QT nomogram? Yes. Okay. He's from Australia, to be clear. Okay. And who is going to use the QT alone without any correction? I'm not going by book. I'm going by myself, using the QT alone, no correction. No? What about the last one? I would bet this is the largest number. Use whatever reported to you, right? Or whatever number you see on the ECG printout, right? Okay, you are normal. Because I'm going to show my study. This is a survey study among the medical toxicologists in the US, in Europe, and Asia Pacific region, including Australia and New Zealand. Yes, you're correct. The highest number is about half of the one that participated in my study would just use any number reported to them to the poison center or whatever number that were on the ECG printout. But for those who are going to measure the QT themselves, they still use Beset. Even though we know that the Beset formula received continuous criticism for this method because at the fast heart rate, it can cause overcorrection, and at the slow heart rate, it can cause undercorrection. In 2015, a team of cardiologists from Canada, they review most of the existing formula for the QT collection. You can see there the green line, the green box. You can see the Beset is constructed from just 39 cases in 1920. the same year with the Fidelia that is created from just 50 cases. But what about the newer formula by the Rota Haju, the yellow one, is created from 50,000 cases, and Dimitrienko created from 13,000 cases. So this group, they obtained 107 ECG from their hospital, and they plot the QT interval against the heart rate and to see which formula would provide the best method that are not dependent on the heart rate. So the slope should be 0, okay? That would be the best one. So you can see all of this, Bizet, Fidelia, Framingham, Hodges, they have a significant slope. Only two formula that is created from more than 10,000 cases. The Dimitrienko formula in the red box, and the blue box is from Rota Haju. Those provided almost 0 slope. And I did a study from these two formula, compare with the Besset and Fidelia formula, if they can predict Torsades better. And here you go. This called QT nomogram is widely used in Australia, and this the only tool, right? In Australia you use right now? Yeah, they don't use a formula at all. And this is my study just published last year in 2019 to look at the sensitivity, specificity, and accuracy of our tools. And we found that QT Rota Haju with the cutoff at 477 provided the same sensitivity, specificity, and accuracy with the QT nomogram, which is the highest one at 89% for the accuracy, with the highest sensitivity at 91.3%. This is the graph. The green one is those without Torsades de Poix, and the red one are those with Torsades de Poix. So the author conclusion, which is mine, I concluded that at the cutoff point at 477 milliseconds, it provided the best accuracy with the best sensitivity, as same as QT nomogram, as a risk prediction tool for drug-induced Torsades de Poix, and that is the formula. And we know that those who had Torsades de Poix doesn't only have only QT prolongation. You know, you have seen a lot of patients had like QT like 540, 560, but how many of them are turning to Torsades de Poix? Just a few, right? Just a few, like 1%, maybe less than 1%. Why? You know, because most of the cases, when they overdose medication, they are healthy. So sometimes, you know, just they are doing well, you know, after overdose, even they have like QT prolongation. But those who have multiple risk factors like this may be at risk for Torsades de Poix more than anybody else who had no risk factor at all. And we can divide the risk factor to modifiable risk factor and unmodifiable risk factor. For example, female sex, advanced age, heart disease, and clinical silent risk factor like congenital long QT syndrome. Like that, you cannot change it, but you know, something you can change it. For example, the concurrent medication use that has potential for QT prolongation, rapid IV infusion, hypokalemia, hypomagnesemia, hypocalcemia, something like that, you can change it. And then you can, you know, modify the patient risk factor. And I'm going to go over for the treatment over the next 3 minutes. For this is the case scenario with a 41-year-old man ingests a handful of unknown medication 5 hours prior to the hospital presentation. He's previously healthy, and he denies using any medication, alcohol, or cigarettes. His vital signs are stable, and he's conscious. No lab information is available right now, and his ECG shows QTC of 560 milliseconds with the heart rate 52 beats per minute and the QRS 80 milliseconds, and the rest of the ECG is unremarkable. Questions. 1. Would you administer IV magnesium sulfate? We're going to say yes. Raise your hand. Don't be shy. Come on. We're going to say no. and say nothing. Come on. No? No, no, no. Okay, I can see you like, no. All right. Shake your head. I am okay with that. Next one, would you pace him? Yes? No? Okay. Next one, what pacing method you prefer if it is indicated? Pharmacological pacing? No? Transvenous? Transcutaneous? Okay, next one. Would you increase serum potassium to 5 millimole per liter? Yes? No? No. No idea. Okay. I'm going to give you the answer. This is the HA guidelines since 2006. The class 1 recommendation is very clear that you just, remove all the offending agents that cause QT prolongation, okay? And the next one, the class 2A, is to give IV magnesium sulfate only when the patient already have torsade de poor, not for QT prolongation alone, okay? And pacing as well, you only pace them when they already have torsade de poor and also when they have recurrent torsade de poor. If they only have one time of torsade de poor, it's not indicated yet. And the potassium as well, you no need to, give the potassium if the patient only have QT prolongation alone without torsade de poor, but just check potassium, magnesium, and calcium level, just normalize it, not keep it that high. And in 2010, they made it clearer for what to do for the QT prolongation alone, not for torsade de poor. So when you look it up from circulation 2010, you will not see ABC mnemonic like this because I think of it myself and I put it this way myself, okay, so that you can remember it easily. The first one, A, is to assess aggravating drug-drug interaction, assess the bradyarrhythmia, concomitant electrolyte abnormality like hypo-K, hypo-MAC, hypo-Cal, and also prepare defibrillator in case you need to use it when the patient has torsade de poor. And be aware of the QT prolonging drugs and avoid it, if you have some medication on for the patient. And then put the patient on the continuous cardiac monitoring. And what I'm going to do if your patient had torsade de poor already? This is the management for non-sustained and sustained torsade de poor. Firstly, you have to assess the patient if the patient is stable or not. If your patient is not stable, like no pulse, unconscious, you need to defib the patient. But if you can still feel the pulse and the patient is still conscious, and it's not stop itself, you just do the cardioversion, okay? And also you defib as well if it degenerates to BF. But if your patient has repeated episode of torsade de poor, that is the indication to give IV magnesium sulfate. And I would recommend you to give 2 grams of IV magnesium sulfate. And you can repeat it once if it's not terminated. What is the mechanism of magnesium sulfate? Why is not recommended to give for just QT prolongation? Because magnesium sulfate only suppresses torsade de poor without shortening the QT interval, okay? By suppressing the early after depolarization, that triggers torsade. And the early after depolarization suppression by magnesium has been attributed to the calcium channel blockage by the reduction of the lead component of the sodium current. And that is why, verapamil has a limited evidence that it can be effective for torsade de poor stop. And however, because this is just some case report, and verapamil also block the potassium channel, and also verapamil is going to cause bradycardia. So at this time, I would not recommend verapamil until we have more evidence for that. And also magnesium sulfate is also a cofactor in sodium potassium ATPase activity, so it may prevent torsade by facilitating influx of potassium into cells that is to stabilize membrane potential. And this study is the classic study showing that when you give magnesium sulfate, it doesn't shorten the QT significantly, okay? And when your patient have repeated episode of torsade, Another prevention that you can do is to pace the patient, but do not pace the patient with a high rate, because the high heart rate can also cause torsade de pointes as well. So just pace the patient at the 70 beats per minute, okay? You can use medical overdrive, or you can use the mechanical electrical for the transvenous pacing as well. For medication, you can use isoproterenol or aminophylline. And just remember that if your patient also have a congenital long QT syndrome, avoid adrenergic medication. Just use transvenous pacing instead, and keep the potassium high about 455 to 5 millimole per liter, okay? And also be careful if your patient have acute myocardial infarction, angina pectoris, or hypertension. They are contraindicated. This is some new study that mexilitine is a selective sodium channel blockade that can be effective as well, but at this time there's limited evidence as well. Lidocaine has been used as well, but it's not effective when it was infused continuously. Many times patients will have recurrence of the torsade. So in summary, all the older people and those with multiple risk factors, they are prone to have QT prolongation and torsade de pointes. And I recommend you to use the more accurate QT correction formula, because it's gonna make another, different assumption if you use the wrong one. Or if you don't want to calculate it, you use a QT nomogram, okay? And below are the summary for the treatment for the QT prolongation. Mostly you just, place the patient on the cardiac monitoring, stop medication and correct electrolytes. And for the torsade de pointes, you just, do the same with the QT prolongation, and you use electrical termination if the patient has torsade de pointes. Use IV maximum sulfate and water pacing when they have repeated episode of torsade de pointes, and to keep potassium that high. Okay, thank you for your attention.
Thank you. Thank you, Ritrak, for this very nice presentation. Any question from the floor? Maybe just one question. Okay, so it was so clear that we all understood everything.
Yeah, I have asked them so many questions. They have no question at all, actually. Thank you.
Thank you
for your
very
attention.
much. Okay, so we'll move rapidly to the second presentation. Dr. Sevile Vural. So Dr. Vural is Assistant Professor of Emergency Medicine at Yozgat Bozok University in Turkey. Her areas of interest are point-of-care toxicology and medical education. She will talk about diagnosis and management of drug-induced rhabdomyolysis.
Yeah.
Thank you very much.
Thank you. Hello, everyone, and I want to thank you to participate in MENA Talks 2020 in Turkey. And we will be talking about drug-induced rhabdomyolysis in this session. Our goals for the session will be how to recognize and manage the patients with drug-induced rhabdomyolysis, and most importantly, how to avoid drug-induced rhabdomyolysis in these patients. Unfortunately, the literature has very limited specific information about drug-induced rhabdomyolysis, and most of the reported papers are based on case reports, but we can come across with some specific topic which are on specific drugs, for example, statins, for example, propofol or MDMA. So we will talk much about rhabdomyolysis general principles for this issue. Rhabdomyolysis, aka rhabdo, or the other name for it, acute necrotizing myopathy. It's a life-threatening condition resulting from rapid destruction of skeletal muscle cells. So The consequence is release of intracellular constituents into the circulation. Luckily, it's a rare event, but drug-induced rhabdomyolysis cases are increasing in number. If we talk about data regarding rhabdo, majority of the cases are adult patients, and the adults, for adults, trauma and the drugs are the major components. But in some studies, it's shown that most of the time, the cause is multifactorial, not only just drugs, not only immobilization. Generally, more than 2 reasons is present for most of the patients. Incidence for rhabdo is 100,000 per 100,000, 1.6. And incidence, for example, much specific point for statin-induced rhabdo, it's 0.3 to 13.5 per 1 million numbers. Most important concerns about the rhabdomyolysis is acute renal failure development, and it's present in 10 to 40% of the cases. And the mortality numbers are not so low as we expected. Rhabdomyolysis etiologies is commonly classified in 3 major groups, and the drug-induced rhabdomyolysis is belong to non-traumatic, non-exertional group. Most of the time, for physicians, the natural link between this situation and the results going to rhabdomyolysis or acute renal failure is quite evident. For example, in a patient trapped under a rock, of course, you immediately think about this patient will suffer from, is suffering from crash syndrome, and probably he or she will suffer from acute renal failure. But in case of drug-induced rhabdomyolysis, the natural link is not quite easy, even for physicians, even for emergency doctors, even though if you are a toxicologist. And that's one of the reasons that's the more silent presentation. But it's not that, it's not all. For example, again, if you think in general, a target organ for a toxicology, a drug toxicology generally targets an organ, and the most specific ones that we think that it could be central nervous system, it could be liver, it can be kidney, yeah, or it can be even skin. But we do not expect a skeletal muscle cell as a target organ of a toxicological state. So it's a, in summary, it's an unusual organ for us. More silent presentation, as I mentioned before. It was uncommon in the past because, as you know, the drugs we prescribed is such low in number. But in nowadays and in the future, it will be increasing. And another one, that the complications can be prevented and reversed by early diagnosis and the high clinical suspicion. There are some clues that we can increase the natural link for a physician. For example, lack of pre-existing muscular symptoms. For example, lack of any other causes for the myopathy. Or the presence of a reasonable temporal relationship between the start of the treatment or change of the dose of the treatment or the appearance of the symptoms. And lastly, maybe partial or complete resolution of the symptoms after the drug is withdrawn can give us a clue about the, it can be drug-induced. The main groups of drugs that related with the drug-induced rhabdomyolysis is the prescribed drugs by us in our daily clinical routine. And the others are alcohol and the illicit drugs like heroin, like cocaine or amphetamine or what else? Lots of choices. The prescribed drugs or the drugs we use in our clinical routine have a huge list. The list is quite crowded. For example, in the list you can see antipyretics, you can see antibiotics, you can see antidepressants, you can see antipsychotics, you can see analgesics, you can see benzos, you can see lots of drugs that cause rhabdomyolysis. But we have to be extra careful, especially about statins, lipid-lowering drugs. There are some novel drugs about the related with drug-induced rhabdomyolysis. One of the most important ones, I think, the tyrosine kinase inhibitors, which are used in HIV treatments, and maybe you just noticed that propofol that we use in ICU or emergency settings. When I am working on this session, on this topic, I just realized, is there any internet resources for helping physicians, helping me? And I just came across a website, www.adratlas.com. And this website contains info about US FDA approved drugs and their potential for drug-induced rhabdomyolysis, specifically on this topic. So, for example, if you wonder any drug, for example, rovastatin, and what's its potential for drug-induced rhabdomyolysis, you can see such a result on the screen. Pathophysiology, yes, I will talk about with a few slides, but you know the story. The basic pathophysiology is common for all etiologies of rhabdomyolysis. Muscle injury, the origin point of it. And the injury is followed by myotic cascade and then release of all the inside content of the cell. Common steps: damage of ion channels, increased intracellular ionized calcium, activated destructive enzymes such as phospholipase and protease, and finally myolysis, cell death, and the leakage of the contents. And what drugs do? We can look at it in two categories. On direct category, inhibition of calcium metabolism by the sarcoplasmic reticulum. Impairment of the production of ATP causing disruption of the cell membranes and alterations in carbohydrate metabolism. The indirect mechanisms are drug-induced coma causing prolonged immobilization and muscle compression. For example, very long surgery, another one. Seizures, myoclonus, causing increased oxygen demand on skeletal muscle tissue. If we go step by step, yes, the injured cells then leaked into the circulation. One of the most important molecule in this leakage is myoglobin. Of course, it's not the only one. The other substance released into circulation, CK, potassium, sodium, phosphate, AST, ALT, LDH, uric acid, and water. And so we measure high potassium levels, high sodium levels, high CK levels, high phosphate levels. But myoglobin has another thing, a unique feature in this pathophysiology, because it's physically, first of all, obstruct the tubules of the nephrons. And in cellular levels, it's nephrotoxic to the kidney cells. So the finally acute kidney injury is seen. So the primary cause of renal injury is myoglobin. Indirect and direct and cellular and physical mechanisms, it can be seen. And hypovolemia and metabolic acidosis also play a role in renal injury in rhabdomyolysis. Signs and symptoms, yes, we have a classic trait of rhabdomyolysis symptoms. It contains weakness, muscle aches, and tea-colored urine, but only less than 10% of the patients has a classic triad. And more than half of the patients do not complain about any muscle pain or weakness. And tea-colored urine, yes, it's very specific for this situation, but only seen in 3.6% of the patients. So, if we are going to talk about signs and symptoms, we can say that patients probably present without any signs or symptoms. Risk factors: female gender, older age, concomitant diseases, and multi-drug use are the reported risk factors for drug-induced rhabdomyolysis. Also, if we want to risk assessment about which patients go to do acute renal failure, what's the ratio of this, there is McMocan scoring system, but it's not very specific. It's a general scoring system for all rhabdomyolysis cases. Diagnostic tools: we have urinary analysis, blood, EKG, imaging, and muscle biopsy options. And most of the time, we use urinary and blood tests. And of course, EKG. Urinary analysis can be done by macroscopically or microscopically, and dipstick tests. For example, on macroscopic appearance, rarely see tea-colored urine, 3.6% of the patients only. In dipstick tests, yes, there is blood. Dipstick test says the urine has blood, generally 4 positive, but it's a cross reaction because of the globulin part of the myoglobin. It's a cross reaction. In fact, on microscopy, you will see no blood cells. Because of that, this test, urinary myoglobinuria positivity, is not specific. And another point of urinary analysis, myoglobinuria is not always visible or may be resolved early because of very, very short half-life. So this test cannot exclude the diagnosis. Another one, urinary analysis on macroscopic. As we said, we will not see any red blood cells. Diagnostics: we have to check lots of things on blood tests. If you start with serum myoglobin, as the urinary myoglobin, serum myoglobin has some limitations. Because of the short half-life, it rises and drops much faster. It just took 1 or 6 hours after the injury, so it's not very helpful for us, and very low negative predictive value. But serum CK has lots of advantages. Most importantly, it is the most sensitive indicator of the muscle damage. Rise approximately 2 to 12 hours after the onset, peaks within the same day, and declines gradually. Even the declination rate is relatively constant for CK, and degree of elevation correlates with the amount of injury. If you have at 1,000, yes, you have an injury. If you have 5,000, approximately you have 4 or 5 times more injured mass, muscle mass. Electrolytes, we have to check this potassium, sodium, calcium, and phosphorus, and we have to treat them as their specific treatment. We have to check the patient's renal functions and liver tests, and probably you will see high serum liver function tests in these patients. Also, we have arterial blood gas analysis for hypoxia, for electrolyte disorders or acidosis. Coagulation panel for DIC evaluation. Cardiac panel, maybe, but generally falsely elevated, especially in elderly population, and toxicology panel for ethanol, THC, and MDMA. EKG show lots of things regarding electrolyte imbalance, especially due to hyperkalemia. The other options are, for example, imaging. Of course, not the prior one, but it can be needed during the ruling out or differential diagnosis processes. And muscle biopsy, it can reveal necrotic or fragmented muscle fibers, but it's not usually done for routine evaluation of these patients. Until we reach an exact drug-induced rhabdomyolysis diagnosis, we have to deal with lots of conditions as listed here. So you can see you have to differentiate, exclude sepsis, inflammatory myositis, burns, in child abuse, neglect, or ethanol toxicity. And moreover, complications can be divided into two main groups, local and systemic ones. In isolated drug-induced patients, rhabdomyolysis patients, we do not expect so much local complications like second wave phenomenon or compartment syndrome, but please remember that even the patients have drug-induced rhabdomyolysis, the patients may have multifactorial states. The systemic complications divided into two subgroups, early and late. We call them early and late, but one of them is in the first 12 hours, the second one is in the second 12 hours, in fact. And even if it's early, even if it's late, the consequence is always life-threatening. Please remember that. And the complications are, I think you already know all these complications. Management, there is not a defined, approved guidelines for treating rhabdomyolysis or drug-induced rhabdomyolysis, and we still go with the general rhabdomyolysis general principles. And of course, our initial priority is airway ventilation and perfusion. And for drug-induced situation, stop muscle destruction by causation of the drug that causes it. If we go point by point, eliminate exposure to the toxic agent. Begin BLS and symptomatic treatment immediately. Use pharmacological agents to prevent agitation, seizures, and abdominal movements that will cause, because they will cause muscle injury to increase. External cooling in the state of hyperthermia. Benzos to control muscle hyperactivity. Correct control electrolyte imbalances. Alkalinization in the urine and mannitol in some selected cases, and it's not approved totally. Evaluate the need of the dialysis of the patients. Monitor the patients in all the way, hemodynamically, in fluid intake and urine output. Just monitor the patients. And of course, the other things, for example, check limbs for compartment syndromes, further investigation to uncover the underlying causes or possible complications. And avoid prostaglandin inhibitors such as NSAIDs, because they have vasoconstrictive effects on the kidneys. The general principles are that, but I have to talk about just for a few minutes on hydration, bicarbonate, and mannitol, because as I said before, there is no approved general protocol for all of them. in fact. First goal, correct hypovolemia to decrease the risk of acute renal failure. But our target is not normovolemia in this patient. Our target is hypervolemia in these patients, to flush the urinary system of these patients, to exclude the myoglobin casts in the tubules. So more fluid to save the kidneys. Because of that, hydration therapy is generally emphasized as hyperhydration, vigorous hydration, or excessive fluid resuscitation. But fluid types and rates are not well defined, but normal saline is a good option because it does not contain neither lactate or nor any potassium. The goal is a urine output of 150 to 200 milliliter per liter at an infusion rate of 1.5 liter per hour. Sodium bicarbonate and mannitol in some selected cases, but there are controversial information in the literature. Generally, alkalization is helpful because the main goal is a higher pH, urine pH. By that, we can achieve to decrease the nephrotoxicity of the myoglobin with high pH. But mannitol, yes, it's believed that it acts as a free radical scavenger, minimizing the cell injury. Also, mannitol has a vasodilatory effect on kidneys, but it's still controversial. And lastly, one of the controversial information, there are some studies, not just one study, by the way. And for the serious CK levels that indicate serious muscle injury, bicarbonate and mannitol is not found to be beneficial in these patients, for example. So further studies on drug-induced rhabdomyolysis are needed. So we can say new things. Thank you very much.
Thank you very much, Dr. Vural. Any questions? He works in the emergency department of Sydney Medical School in Sydney, New South Wales, and is also the toxicologist of the Western Sydney Toxicology Service. And we have the great pleasure that he will talk about the new N-acetylcysteine regimen in acetaminophen poisoning. This is a very difficult theme because there are so many protocols now. In the past we have just one, it was easy, and now it's too much complicated. So
by the end of this talk, you'll only have one again.
We're happy. Thank you, Naren.
Thank you. Thank you for inviting me to speak about acetylcysteine regimens. I don't know about your country, but we've stopped calling it N-acetylcysteine in the last couple of years. It's now just acetylcysteine. I don't think I need to remind you about the metabolism of paracetamol, but I just get you to keep your mind about NABQI as the hepatotoxic metabolite, which is formed from P450 enzyme metabolism, which then is detoxified. This is the traditional model of paracetamol metabolism and how it's detoxified. NAC is an acetyl moiety that is hitched onto the amino acid L-cysteine. So you can see the colored bit is the acetyl bit, and the rest of it is your normal cysteine molecule. What does it do? It's true, yes, it provides self-hydral groups and promotes the creation of glutathione, but it also has other properties like scavenging antioxidants and provides some level of protection against free radical formation. But what started happening once N-acetylcysteine became a very prominent player in
the antidote for paracetamol poisoning in the 70s is we started seeing adverse effects to acetylcysteine in the early 80s. And predominantly it was GI and skin. They were the predominant adverse reactions that people were seeing. When it started being given intravenously, the commonest error was somebody ordering it tenfold errors. So instead of giving 17 grams in a liter, they gave 170 grams in a liter. And these were not thought to be anaphylactic, and I'll tell you why in a minute, but non-anaphylactic, but anaphylactoid, and non-allergic, so they were termed NAAR or NAR, and I'll talk about what that is. This is probably the first fully sort of going through every single adverse reaction paper, important paper to read by Parkeroven in 2008. And it talks predominantly about people getting abdominal effects, and then skin effects, and then other things like respiratory stuff. So it's the stuff that you're seeing already in your units whenever you see NAR. Why does NAR happen? One thing became clear, it was not IgE mediated, which is why it was not thought to be anaphylactic, and so thought to be anaphylactoid. Although the effects look very similar to anaphylaxis. And it had nothing to do with whether you'd had acetylcysteine before. So it's not like some kind of foreign protein, like let's say the sting of a bee or some kind of venom or some other foreign protein, that if you'd had it before, you were more likely to get it again in an IgE-mediated way. This was not like that. You didn't have to have previous exposure. The other thing was that there was histamine release, but tryptase levels did not go up, suggesting that it was not mast cell release of this kind of effect. When they did levels of NAC, so this is acetylcysteine levels mapped across time, you'll see because we give a huge bolus dose and then the levels go away after that first 15 minutes to an hour. And then if you match that to what was happening to histamine levels, about, depending on how fast you gave that first one, if you gave it in 15 minutes like the original papers, then your histamine levels rose soon after that. And so that's why people often saw that reaction when the second bag started. That was the commonest time. Is, you know, I put up the second bag and the person had an effect. So that's what the nurse would come and tell you. And people were starting to blame the second bag, but it was really clearly starting to think that it was the first bag. This is another excellent paper that Steve Waring did also in 2008, where he confirmed, and it was already suspected, that if your acetylcysteine levels were low, that you were more likely to get an adverse reaction or a NAR reaction to acetylcysteine. But if your levels were high and you really needed the NAC, then the chances of getting a reaction were low. And this started to happen because in Europe and certain places, particularly Denmark and other places, they were giving NAC to everybody. Doesn't matter if you took 5 tablets or 100 tablets, everybody was getting NAC. And it's almost happening like that in the UK now. So this is the standard regimen that everyone's been using for the last 50 years, or 40 years. There was a paper done which compared 15 minutes to 60 minutes, and they didn't find a statistical significance. That was done by Fergus Kerr, was the lead author. They compared 15 minutes to 1 hour as the first infusion dose, and they found that there was no difference, or the difference was too small and they couldn't find it to be statistically significant. So I'm assuming the majority of you are using this. Is anybody not using this regimen? Okay.
You're the only one.
I'm the only one. I'm not the only one. I'll tell you who else is using it in a minute. So with those histamine levels, those acetylcysteine levels, it started to become clear that probably that reaction is happening because of the very fast first bolus dose. So the SNAP study, probably the first big study to tackle a different thing. First time somebody had changed acetylcysteine in 30, 40 years properly. And here they gave acetylcysteine in 2 bags over 12 hours. The total dose was the same, 300 milligrams per kilogram, but not in 20 hours, but in 12 hours. They found a big difference in the NAR rates. It went down from 30% pre to almost 5% afterwards. That study was a little bit complicated because they mixed up the whole NAR situation with the vomiting and the gastro situation, the use of ondansetron. So it was a little bit hard to differentiate the whole gastro versus anaphylactoid reactions in that. Now this is called the SWAMP protocol of what we did in Australia. This is not, the word swamp is not published anywhere, not known to anybody. It was the word that we just used in-house because it was a handful of hospitals in Southeast Australia that were doing this. Sydney West, that was my hospitals. Austin Hospital in Melbourne, where the chief, one of the chief authors works at, which is Anselm Wong, and the Monash Centre protocol. So the SWAMP protocol, you don't have to call it that because nobody else does, but it was just because those were the hospitals in this study at the beginning. All we did was just merge the first and second bags. That was it. So 150 and 50 became 200. 1 hour and 4 hour merged to stayed as 4 hours. That third bag remained the same, 100 per kilo over 16 hours. So the first bag became 200 per kilo over 4. The second bag became 100 per kilo over 16. So the first 2 bags were merged. Total dose is the same. Total duration is the same. 300 milligrams per kilogram over 20 hours. And we're going to show you some data on that. This is our data from Western Sydney. The chief author for our paper was Richard McNulty, who's one of our clinical toxicologists. He, and they worked very hard to make sure that they captured everybody. It was a retrospective study, so that's a limitation, but we're pretty sure we didn't miss any doses of NAC. There was a 66% relative reduction in adverse events if you switched from the 3-bag to the 2-bag. If you just compared severe effects, so that's people who became hypotensive, had breathlessness or any kind of skin swelling, there was a 77% reduction for those people, relative reduction. And there was a similar 60+% reduction in the use of anti-allergy medications like antihistamines and steroids. Now, if you compare that study and do a meta-analysis of other similar studies, so Anselm in Melbourne did his own study. That's the one that's number 4 on the list, that's Wong. Very similar results to ours with the odds ratio 0.39 versus 0.32 for us. Very similar, a repeat study done in Denmark just recently by Dawood, that's the study at the top, also 0.36, so 3 times less chance of having an adverse reaction if you use the same 2-bag protocol. So all of these studies have done exactly the same. They have merged the first 2 bags. The only study that's done something different is Bateman, which is the SNAP study I showed you, which is the 2+10. Okay? But Dawood, McNulty, Schmidt, and Wong have all done the same thing, pretty much. Here is the forest plot on that, on those papers. Now, if you look at this, I don't think any of you should be using the 3-bag NAC ever again. You're going to give me why?
No, because all these are side effects, but what is about the efficiency? That's the problem.
Yep, that's right. So all of these are about exactly that. So we haven't got enough data on the whether there's an inferiority issue. So far, we've been using this protocol in Western Sydney and in Australia for 5 years, and we haven't seen a change. It's not inferior to the previous because the dose is the same and the duration is the same. But certainly, adverse reactions are better. So what are the other advantages to this? The main issue is that there's less interruption between bags, so you have one less bag change, and often nurses will start the first bag. Once one finishes, by the time they start the next one, there's a gap. By the time you chase them down to come and put up the next bag, you've lost a bit of time without NAC. So less medication errors and preparation time. Now, to get this change in protocol across the countries has taken a long time. So Australia and New Zealand changed to the 2-bag NAC in 2019, and so did the Swedish Poison Centre. I'm not sure if anybody else has. I know California is still on 3-bag at the moment, and I assume France is as well. I'm not aware of any other places, but these three. Rocky Mountain has changed? Oh, okay, great. Oh, okay, thanks. Great. And so what we're waiting for are these non-inferiority studies to see whether there's any difference, but I think it's unlikely at the moment. What's coming down the track is NAC Stop. NAC Stop's a study we're just about to publish shortly. Sorry, NAC Stop's been published, and the double NAC and a couple of other. The NAC Stop 2 is the one we're about to publish. NAC Stop was published last year, where for low-risk paracetamol toxicity, we are stopping NAC at 12 hours. So these are people with single ingestion. The LFTs are already normal before you start NAC, and then at 12 hours, you repeat the LFTs, and the paracetamol's under 20 milligrams per liter, and it's at that point you can stop the NAC safely. So that's been shown to not cause any change in hepatotoxicity or death. So we think that in these low-risk patients, that you can probably stop NAC at 12 hours. NAC Stop 2 is still to be published, so I won't talk about that because Ansam should talk about that. It's his paper. The other thing that we're doing is double NAC. I know this is practiced in California and other places as well, and that is if at any point your result is double the nomogram line. So this is the nomogram line that we use in Australia, which is the same as in the US. So it's 150 at 4 hours. Let's say at any time, say at the 10-hour mark, your level is double the nomogram line. At that point, you should double that second bag. The first bag's given, that stays at 200 milligrams per kilogram, but that second bag is doubled. So we're thinking, at the moment, the thinking behind that is that we're not actually giving NAC based on the dose ingested. It's based on weight of the patient. Now, if you say 1 mole of NAC counters 1 mole of paracetamol producing NAPQI, then really for a 70-kilo person, then that fights about 20 grams of NAC. So if someone takes a massive ingestion, more than 30, 40 grams, then you're probably going to need double or more NAC. That's the thinking behind that at the moment. Still controversial, not widely accepted. It is in the Australian guideline as of last year to double the NAC if the level is double the line at any point. Other things, there are other novel approaches that are being thought of all the time. I'm only putting dialysis there so that people don't forget it. There's nothing novel about dialysis. People have been dialyzing paracetamol for a long time. I've just put it there so that people don't forget that paracetamol is a dialyzable drug, and XTRIP has got guidelines on that already. Fomepizole, I don't know if anyone's used fomepizole or 4-methylpyrazole, but it actually, unsurprisingly, works because if you remember back to my very first slide, our old friend that metabolizes paracetamol into NAPQI is our good old friend CYP2E1, which also is the same enzyme that's metabolizing ethanol and methanol and ethylene glycol. Now these are all there's isolated case reports. There's not a lot of data on these other novel approaches. Metformin is thought to do some superoxide scavenging. Methylene blue may also have some effects on the electron transport chain, which may help. And another drug, which I can barely pronounce, which is calmangafodipir, is on phase 1 trials right now as being a promoter to mop up superoxide radicals from NAC-induced hepatotoxicity. So it could be down the track, say in 10 years' time, that you'll be giving NAC with calmanga drug. That's a possibility down the track. Thank you.
Thank you very much, Maren. Any question from the floor? You have many questions. We'll start.
Okay, so thank you so much for this presentation. It's very interesting. I have 2 questions, basically. I know that when it comes to the side effects, though we are giving the same dose and the same duration, but in fact, you are not giving the same rate. So in the case of 3 bags, we are giving 150 milligram per kg over 1 hour, whereas in the other one, you are giving around 50 milligram per kg per hour.
Yes.
Right? So basically, the dose will be definitely less. Maybe that's the reason why you have less side effects compared to the 3 bags.
Absolutely.
And already that study showed that there is no difference between 15 minutes and 1 hour.
Yes, so that was the study showing that there was not a huge difference in adverse reaction rates if it was given between 15 minutes and 1 hour. So it's 150 per kilo over 15 minutes, or 150 per kilo over 1 hour. I absolutely agree with you that giving the first bag slower, not at 150 per kilo per hour, is the reason why that you're seeing less NAC reactions. So the dose is slower, and that's why you're getting less reactions, because that was the reason for getting those reactions. We were giving it very fast. The other thing is, if we think about the way NAC regimen was devised in the 60s and 70s, these were given in Northern England and Scotland to people who presented quite late. They were not coming 1-2 hours after their overdose and saying, I've taken 50 Panadol, please save me. These guys were presenting later. So at that point, giving a big bolus of NAC to someone who's heading down hepatotoxicity road probably made sense. Nowadays, we're giving it to people, sometimes we're giving it to people who've taken hardly any paracetamol. And so I think that also plays into why we're seeing more adverse reactions in our current cohort of population as compared to that published during Prescott time and things like that.
Yeah, but that's the same thing in the study where you said that comparison between the 3 bags and the 2 bags, and there is no significant adverse outcome, and you are advising for the 2 bags, right, instead of the 3 bags. The same thing, the studies did not specify what was the time of the presentation and how much the ingestion was.
Yes, I haven't presented it here, but all of those studies have had matched demographics between the 2 cohorts and are very similar.
Okay.
Yeah. I didn't put that table in my talk, but yes, there is an extensive table in pretty much all those studies about the cohorts between the 2 bag and 3 bag being very similar. Yeah, but that's important. Yeah.
One question from Ritrak.
My question is really short. Are you going to do 1 bag?
Yeah, that's a great question. I think we're going to get there. It's taken us 40 years to get from 3 to 2. I think eventually we'll get to 1 bag. It will be 300 per kilo over 12 hours in 10 years. I'm pretty sure. Good question.
Yeah, I agree in the cases where it's not, the poisoning is not so severe. But what about if the patient is seen with delay? What about if there is already an acute liver failure?
Yeah.
So my questions, is the bolus important or not? And do you increase the dose of NAC or not in these severe cases?
Yeah, good question. I think in those people with either established hepatotoxicity or ones that present late, giving 150 per kilo over 1 hour versus 200 per kilo over 4 hours in that later presentation, I suspect there's very little difference in that. I think it's going to be okay. Because these guys present maybe 12, 20 hours there. So whether they get it within 1 hour or 4 hours is probably not as big a deal as the fact that they need more over a longer period of time, which is why in those scenarios with established hepatotoxicity, we are already doubling that second bag. We are already doubling or tripling if the level is really high.
So you double if there is an elevation in transaminases?
Yeah.
Even though the paracetamol concentration is low?
Absolutely, yeah.
Okay. Yeah. Any other question?
You can double or just give it for longer. Yeah.
All right, longer, okay. Any other question? Okay, thank you very much for this very interesting presentation. And we'll move.
Good afternoon, everybody. And it will be short. It will be different. So I'm going to talk about the concept of are we ready to deal with any botulism cases. So I will start with a small story which has a regional or sub-regional importance, and then come with lessons learned, which is about 3 or 4 points. First of all, it was about 1.5 years ago, my colleague from a neighboring country called us and he said, well, we have suspected case of botulism. Do you have the antitoxin? I said, no, we don't have it. We don't have it because we didn't see any botulism case for like more than 20 years. He said, well, we have one case and we need, and he said, well, you can call others and maybe international centers or other countries, or maybe WHO. Then they called me, they said, oh, it is not botulism. Then I was talking to my colleagues, shall we have some of this antitoxin? What about diagnosis? They said, well, it's an old disease, we don't get it. And this year, a family of Egyptian family in Qatar, the father, son, and daughter were affected, were admitted. It was really a new cluster of cases that are really, we didn't see it for a long time. Many of our colleagues, they say, well, this is in the textbook. So they were calling each other, come see, we have an interesting case, and we don't need to miss it, because we may don't get it for another few years. So it was diagnosed clinically as botulism toxins. They were Egyptians, and we know that Egyptians are maybe one of the most affected countries in our region because they have what they call Shem and Nasim holidays, where they cook fish and make it in, they store it in special jars where it's really anaerobic conditions and it favors the growth of botulism. So we were investigating how to deal with this case. We don't have the diagnostic in our lab. We don't have the antitoxins. We have antibiotics and supportive, and some of them were intubated. And then we want the antitoxin. What shall we do? So I called WHO office, our regional office in Cairo, and they said, we don't have it. Okay, what about the headquarters in Geneva? Well, actually, it finished. There's an order, and it might take a few weeks or so. That was really a bad situation. And we know that Egypt has it, because Egypt always prepared to have some cases, and every year there is 100 vials coming specifically to Egypt. And then we use our, I would say, ways to let the family talk to the embassy and the WHO officially coordinate, and eventually we succeeded to have it. A bit late, more than a week, and it has to be delivered by one person by hand, and it was really difficult. At the same time, we tried to map the producers, the pharmaceutical companies, and we found the best is the Canadian company that Egypt bring their products from them. And immediately we called our embassy to bring 3 vials as soon as possible, and then we made some orders to have more stockpiles. So the lessons or the story is that we were alerted 1.5 years back. We didn't take it serious. We had it in Qatar this year, and we learned from it. And even though there is an Eastern Mediterranean poison net, with some of the colleagues here are member. And we were talking to them, they said, well, we don't have it, we have only the antitoxin A and B, and we discovered that it's not only locally, it's regionally, and even to internationally, we are not really prepared to deal with these cases. So the lessons from these issues is that we need to have the diagnostic capability in our lab in the hospital, the diagnostic capability in the public health lab, or food safety or environmental lab, to diagnose the food and the people. And also to have something in terms of protocol, how to deal with these cases, and also to make our colleagues, doctors and nurses and healthcare workers aware of these cases and this disease and how to deal with it. Also, if we don't have it, it's not, because the antitoxin is very expensive. If we don't have it, at least we know where it is, or regionally in our region where we can find and order these antidotes. So from there, we took it serious, and we started some discussion internally and nationally. And also, we took that serious to our IMRO office with WHO in terms of mapping our region, and also identifying how many vials in each country, and then make it, regularly reported. In case any country needs, we can provide them, even with cost, sometimes without cost. And in our case, Egypt gave it to us for free because it was affecting the Egyptian family. So the lesson or the message here is that we need to have it as a package. Increase the awareness of healthcare workers, decision makers, lab, clinicians, and even international methods or ways to order it. And we use the IHR, the International Health Regulation 2005, as a call for this treatment. So basically, I'm just raising the awareness is that although it is quite rare, but sometimes you will get it, and sometimes you get it in a big volume, not only one or two, maybe three or more. So we were lucky to have three. All of them survived, but took a long time to recover. But we were really worried about them. So they were, alhamdulillah, we had a very equipped intensive care unit. So some of them were the three of them were intubated, but some of them stayed 2 months. The father stayed about more than 2 months, but eventually they recovered. But it is really bad because we didn't give them the treatment initially. Otherwise, it would be speedy recovery. And this is basically what I need to say. Increase the awareness, and thank you very much indeed.
Thank you. Is there any question? So if I understood, you have a project of mapping in the MENA region where the anatoxin are present, where the antidotes are present?
Yeah, we agreed with the IMRO office to start and do it with them together. So it becomes more official from IMRO and with our inputs in it.
Okay. Because I guess that in many countries, there are no supply and no possibilities to get the antidote.
And at the moment, we are in the process of recruiting 12 vials for this year, minimum.
Okay. Any question? Thank you very much. I'm sorry for my mispresentation, and welcome to our Congress.
Thank you. I really appreciate it.
Okay, so I don't know if it will be here or somewhere else. Here, so the walls will be open, the two rooms, or not? Okay, thank you very much.
Welcome, everyone. Sorry for the delay. We ran behind a little bit, so I apologize. But we wanted to just close the main scientific conference with this ceremony. Dr. Hoffman, for the abstract. So we'll keep this short, very concise. We have a few objectives. The first objective is to first have a few thank you remarks. On my behalf, I really want to thank the participants who persevered through our scientific programs, which are quite lengthy this year compared to previous years. I'm very happy with the attendance. You know, we had hoped to have a very vibrant and engaged attendance, and I think we did that. And this is not surprising considering our membership as well as IPAT's membership and passion for toxicology, which was very apparent. We thank you again for your volunteerism. All our speakers volunteered their time and money to come here and speak and participate, so we appreciate that. We also want to thank the company Literature that provided all the logistical support, and thank our sponsors, Toxins, Randox, Response Systems International, Turkish Red Crescent, and the company that markets N-acetylcysteine in Turkey. We also want to thank, on behalf of Minatox, our partners, IPAT, for their support and partnership, and look forward to future programs together and development of toxicology in Turkey and the region. Thank you.
Thank you very much. In the end of the 2 or 3 day, very nice conference, and we take note for this. Toxicology is very important part of emergency. So we will continue to contact, and thanks for Minatox speakers from all the world. They come and join us and share their experience. Very valuable speakers from all the world. It's a big honor for us to see you in Istanbul and to know you, and we hope we will be in contact for the future cooperation. I think this is very useful conference, and around 100 topic, more than 100 topic maybe. 200 parts, no, very much topic about toxicology. We speak about toxicology, everything about toxicology. We will be in contact for the toxicology journal and toxicology textbook and another topic together. And I think don't forget, I think that you give promise for the 2 years later again in Istanbul. Don't forget about that. Inshallah. And I want to invite all these valuable speakers to our big conference. IPAT, very big family, not only in Turkey, in the world. We are in like international society. So I want to invite everybody to international section of IPAT. And we have your detail and email, and we will be in contact. We will send you email from IPAT. And I want to thank my team, my college, and especially Dr. Behjet behind of me always. I am front, and Dr. Behjet come to conference after the very difficult time, and we didn't share this, but I think I should say, because in this difficult time, after difficult 1 week, he never give up from job and working and join us. I want to thank to Dr. Behjet again. Thank you. Great effort. Thank you very much. We have very nice memory with you, and I hope like this, you think like us for the future. Thank you very much.
Dr. Behjet, Dr. Gul, would you like to, Dr. Behjet, would you like to say something? Okay, for the sake of time. What about Dr. Hoffman? Can you help me with the oral abstracts and the awards?
Sure, absolutely. So Ziad, maybe you could actually pose with the person when they come up. But we have a selected best oral research abstract presentation, and that presentation was acetaminophen poisoning resulting from repeated supertherapeutic ingestion, circumstances and outcome, Dr. Bruno Magarben.
Oh, here we go.
At least stand up. Yes.
Do you want to take a photo with me? Come on.
I didn't realize these were. I was looking for them.
Camera right there. There you go. What an honor. All right.
Okay, thank you. And our best, so the best oral presentation of an e-poster was the utility to test the salicylate level for all cases of paracetamol overdose, Dr. Ahmed Alabri.
Congratulations. The next award is actually a memorial award for one of our medical toxicology fellows, Dr. Saeed Al-Mazroui, who was enrolled in a medical toxicology fellowship in the US, at Emory actually, and then who was diagnosed with a brain tumor during the fellowship. And he actually succumbed to his disease, leaving his family behind, unfortunately, and leaving many friends in Oman and the Middle East, North Africa region, and MENA talks particularly. So in honor of his memory, we have an award that we give every year to someone who is passionate about toxicology and has served MENA Talks. This year's Saeed Mazroui Award goes to Dr. Iran Gokta from Istanbul. Last but not least, we would like to thank our speakers with a small souvenir from this conference. And I'm going to actually read the name of the speakers. If the speaker is not here, we will just basically move on down the list and we will save their souvenir and certificate till after the ceremony. We'll start with Mr. Nabil Ahmed, Dr. Ihab Aki, Dr. Peter Akupnunu, if you guys give you a heads up so you can start walking to the podium. Dr. Faride Agul, Dr. Bashatal, you are here already. Dr. Ibtihal Lattas, Dr. Suad Labri, Dr. Khaled Laufi, Dr. Anwar Al-Awadhi, Dr. Hassan Al-Balushi, where's the camera? Dr. Jalal Isa, Dr. Badriya. Somebody can read, and I can stand on the camera. Thank you.
Peter Akamoğlu. Buradan başla, Aylin'den başla.
Aylin Arıcı. Avni burada değil. Ashish, you are welcome.
Right here.
Ashish, Miss Aylin, please.
I have to stand in the same place. I cannot move. This way, please.
Okay.
Also this. Thank you. Congratulations.
Ashish. Sen devam et. Sen devam et.
Ben bunları telaffuz edemiyorum Arap isimlerini.
Okay. Abdul Latif Alumi.
Tamam. Abdülkadir Gündüz is here. Okay. Amal El-Kozai. Amal El-Kozai. Not here. Okay. Andrew Nelson.
Andy Nelson?
He was here. Bruno, he's already here.
Andy is here.
And he's here. Bruno, you are here? You are still here. Bedria El-Hatali is not here. She is here. Ah. Oh, she's here. Who is Bechet Al? This is mine. I'm here. Brent Morgan. In the morning he was here. Brent? Okay. Brett Erickson. He's traveling Istanbul, I think.
No, Brett was in New York. He did the phone.
In New York, not Istanbul. Charles Mackey? Okay, he's here. Ahab Aki? Ahab? Okay. Edwin Kilburney? Charles. Edward? Eva, my friend? He is in Bosporus. Elia Harmonic? Elia? Eren was here. Gökdağ. Gülseren is not here. Gürkan Ersoy? Gürkan was here, yes. Gaylord Lopez? Not here. Jalal Alashi? Jalal not here. Okay. Hussein Hassan? Iranian? Hussein Hassan? Okay. Hanna? Dr. Hanna? She was not here. Hassan Belushi? Hassan kim geldi? Hussein Hamoudi? Where is Hussein? Hussein Hamoudi. He's eating. Ismail Sabei? Not here.
I had put discussion to the end, but I think we've got time for a few questions. If anybody has any comments or questions about Ivali or e-cigarettes. Are you seeing this in Turkey? There's plenty of cigarettes. Don't need e-cigarettes. No comment.
I'll mention one thing that, I took care of a number of these patients, and because they were getting their THC products literally, I mean, they would say, yeah, you know, Johnny 3 houses down, he's the person I go to get my liquid that I use in my electronic cigarette. I would actually counsel them if they really needed THC to just smoke cannabis as opposed to using the electronic cigarettes. It's not the usual advice I would give someone as a physician or as a medical toxicologist, but I felt it was probably better that they use, if they're going to use drugs, that they use it in a way that's safer and than a way that was less safe in these cases. So there was some interesting conversations I had to have with patients about their drug use during this outbreak.
So on that point, Trayvon, we found that in Australia that people who were never cigarette smokers had started taking this fashionable sort of smoking habit up. Is that what you're seeing? And were they tending to be the ones who are more on THC type, or because people shouldn't just suddenly start going on nicotine, you would think?
Yeah, so that actually brings a lot more to nicotine marketing. So these electronic cigarettes were overtly marketed as an alternative to smoking, but were subversively marketed in a way that was attracting new, young nicotine users, primarily teenagers, in very fashionable ways. And as you can imagine, if you get a teenager addicted to nicotine, you've got a customer for life because nicotine is an addicting substance. And so yes, so we were finding, if you were demographically, most of the patients involved were young men, usually late teenagers through early 30s. And many of these people would not smoke cigarettes. They were electronic cigarette users. That's how they took their nicotine, or transitioning to their THC products. But yeah, it's an interesting concept in marketing that these products were marketed towards a younger audience. to get new nicotine users, and then many of these ultimately went on to using THC as well.
Thank you. Excellent talk. I'm emergency physician and clinical toxicologist from Oman. One of the things I'm not sure if it came across to you is, since 50% of my customers are actually pediatric age group, did you come across like that nicotine syrup being ingested by kids? And do you have any data for that? Because it's, when I was in US in San Francisco, we actually came across some of these cases where the kid got into his dad nicotine and that sort of thing. So
yeah, so we do see these cases where, so these, you know, you can imagine if, you know, if this were smaller, you know, you buy your nicotine liquid, your e-liquid to put into your device, you leave this container around somewhere, or a child can get into it and ingest a lot of nicotine and be quite ill. And so yes, that does happen. And so,
have like data for that?
I would imagine we could get that data. I haven't looked specifically for that data, other than I know that has happened. I am aware of at least case reports. There may be case series as well. But that is certainly something that we talk about, and in kind of dealing with harm reduction, when we know of people who are using electronic cigarettes, particularly of their refillable tanks. So many of the products, you can just go buy a cartridge that's got liquid in it, and you just put it in the device and use it. But many times you just get the liquid and you can refill your container. Those are the ones where you really can get into trouble, because that container can just be left around and a child can get into it. And it's a lot of nicotine. This is actually an interesting piece with the electronic cigarette use, is as opposed to smoking a cigarette where you have to light the cigarette, actively smoke it, etc. You can have a lot of nicotine in that e-liquid, high concentration, that you just puff on all the time. And so you're getting exposed to a lot of nicotine. So there's a lot of nicotine in that liquid, which from a commercial perspective is good for the makers of the products, because again, they've got customers who are now hooked on their product. But from a public health perspective, can be challenges for, like in this case, children getting into the liquid.
Okay, thank you very much. Trayvon.
Dr. Hassan Abalushi, board-certified emergency physician from Oman, is accepted, I understand, to Amory for fellowship, and is passion in toxicology and education, and is going to come forth to the discussion on beta blockers and cocaine use. Thank you.
Thank you for the introduction. Assalamu alaikum. Good morning. So my talk will be about beta blockers, cocaine-associated chest pain, and the unopposed alpha stimulation. So to start with, how many of you are supporting the idea of starting beta blocker and cocaine-associated chest pain? Seems we are done. Okay, so how many of you are against it? 2, 3? Okay, how many of you have no idea what we are talking about? Good, that's what I want. Okay, so to start with, I have no conflicts of interest. And during this talk, we'll review the role of beta blocker and acute coronary syndrome, and we'll review the mechanism of cocaine-associated chest pain. Then we'll examine the evidence behind this idea. And at the end, we'll touch on some guidelines and recommendations in the management of cocaine-associated chest pain. So let's go one by one. First, why we need beta blockers in chest pain in general, or in acute coronary syndrome. According to American Heart Association statement in 2014, oral beta blockers should be initiated within the first 24 hours of patient arrival if there are no contraindications. And that was class 1, level B of evidence. And then studies came and they said beta blockers therapy reduces infarct size and risk of mortality if it was started early in the course of the disease. Good? So we'll shift a little bit to talk about the mechanism of action of cocaine, then we'll gather them together. So cocaine has 3 main mechanisms of action. One of the most important mechanisms is this one, which is it prevents the reuptake of dopamine and other catecholamines from the synaptic cleft. So as you see in this diagram, dopamine and catecholamines will go and act in the postsynaptic membrane, and then will go back through the dopamine reuptake transporter to the cell to be degraded by monoamine oxidase. What cocaine does, it inhibits the reuptake or the dopamine reuptake transporter, leading to a surge of catecholamines and dopamine in the synaptic cleft. This surge of catecholamines in the synaptic cleft will go and act or overact or overstimulate alpha and beta receptors. By stimulating the alpha receptors, as you can see, it's causing smooth muscle contraction. And by stimulating the beta receptors, we are ending up having smooth muscle relaxation that opposes the effect of alpha receptors. So simply by blocking the beta receptors, we are ending up having unopposed stimulation of the alpha receptors. So that's the issue theoretically, but we need evidence. Let's go through the evidence. Actually, this issue started many years back. In 1990, Lang et al. Did a prospective randomized double-blind control study, and imagine having an RCT or experimental RCT in toxicology. That's very rare. So he got 30 patients, volunteers, who are undergoing cath lab for chest pain, and they exposed them, one group was exposed to intranasal cocaine, the other group exposed to placebo saline. Both groups were injected with beta blockers, propranolol, and they found that cocaine group had more increase in arterial pressure, myocardial oxygen demand, and coronary vascular resistance. So that supports the idea of beta blocker causing unopposed alpha stimulation. They conclude that beta blocker use should be avoided in early phases of treatment while cocaine's effect is still present. Sand et al. In 1991, again, they tried esmolol here, which is a selective beta-1 blocker, and they concluded that esmolol reliably decreased heart rate but had an inconsistent effect on blood pressure. After that, 1993, Boyer et al., they used labetalol as being an alpha-1 blocker. And they said they saw that labetalol reduced heart rate, blood pressure, but had no effect on coronary artery cross-sectional area. And they concluded that it might be alpha-1 antagonism unique to labetalol that was responsible for these reported outcomes. Then after that, many case reports have been published supporting this idea, in line with many experimental animal studies as well, supporting the idea of unopposed alpha stimulation. So isn't that enough? And why not we stop here and just avoid beta blocker and cocaine-associated chest pain? That's because many retrospective studies came recently and studying patients who received beta blockers and cocaine-associated chest pain, and they found there was nothing happened with them. So are we over-emphasizing the idea of unopposed alpha stimulation? Let's see. We'll go through these studies one by one. I'll just choose some landmark studies of these. So beta blocker for chest pain associated with recent cocaine use. It was a retrospective cohort study involving 331 patients with chest pain and recent cocaine use. 151, or half of them, received beta blocker in the emergency department. And they found that there was no meaningful differences in ECG changes, troponin levels, length of stay, intubation, or death between these two groups. They concluded that beta blockers do not appear to be associated with adverse events in patients with chest pain with recent cocaine use. But the issue with the study, it was a retrospective study, so you cannot control your patients, and they used urine tox screen to detect the use of cocaine. And what's the issue of urine tox screen is that it detects cocaine. Cocaine can be detected in urine up to 48 to 72 hours or even more, so that they are not sure, is this an acute cocaine overdose or no, which is a big issue actually. Then early use of beta blockers in patients with cocaine-associated chest pain. It was also a retrospective review, 378 patients with chest pain and received beta blockers. 28 of them received beta blocker after cocaine abuse. And they found that there was no statistically significant differences between the two groups. So does that mean we are overemphasizing the issue? Let's see. It's a retrospective study again, so you cannot control it. There was no standardized follow-up protocols for the study. And again, the tool that they used to detect cocaine was urine tox screen. So again, the same dilemma. Then there is this meta-analysis of outcomes of beta blockers used in cocaine-associated chest pain. They got 5 studies, around 1,800 subjects, and they found that there was no significant difference on myocardial infarction in patients with cocaine-associated chest pain on beta blockers versus those who didn't receive beta blockers. And there was no significant differences in all-cause mortality as well. They concluded that in patients presenting with acute chest pain and underlying cocaine, beta blocker use does not appear to be associated with an increased risk of MI or all-cause mortality. Again, data derived from these studies were all from retrospective studies. So does that mean there is selection bias? Urine tox screen was the tool they used again. So again, we are in the same issue. And significant heterogeneity between studies included was there. So again, how many of you will go with beta blocker and cocaine-associated chest pain? Now 2. Okay, how many of you are against it? How many of you are still in between? Good. Okay, so this summary might help you. Physiologic and pharmacological studies or principles suggest that it is contraindicated. Good? Animal studies suggest that, experimental animal studies suggest that it is contraindicated. Case reports said it's contraindicated. Randomized trials, experimental randomized trials in humans suggest that it is contraindicated. Retrospective human studies, questionable. So what do you think now? Against? Okay, good. So bottom line, based on available data, beta blocker use is still not recommended in cocaine-associated chest pain or to be avoided. Further research is needed to fully explain the significance of unopposed alpha stimulation phenomenon, which is difficult, I think. Although beta blockers are recommended for patients with myocardial infarction unrelated to cocaine-associated to cocaine because it can lead to lower mortality risks, death from cocaine-associated chest pain are exceedingly low. So you just weigh it. I like the statement or this diagram from American Heart Association and American Academy of Cardiology, where they said that if you had a patient with cocaine-associated chest pain, avoid beta blockers acutely, and you can start it later in the course of the disease. You consider beta blockers, especially if high-risk features are there. Thank you.
Thank you, Dr. Sen, for a very nice summary of literature and this common problem. And it is supposed to be a debate, so who would like to ask a first question?
Thank you very much for your this nice talk. So we have a new question that we have to ask the patient who have chest pain come to emergency department. And just before here, we always ask about the characteristic of the pain.
Exactly.
for the patient who has chest. Now, there is a new question. We have to ask, did you get cocaine or not? Do you recommend us to ask this question to the patients?
How many of them they'll tell you, and how many of them will tell you when they started? That's the issue. We recommend actually, you ask, but how accurate it will be? I doubt it.
Thanks, Hassan, for an excellent talk. I like his comment. Actually, in young age group, it's actually one of the predictive risk factors for having cardiac events. So we usually ask, and sometimes the way that you want, if you want them really to respond to you nicely, tell them like, it will make me save your life. I'm not like, I'm trying to help you, and I'm just want to make sure that you don't have serious issue regarding the drug. And they will tell you. I remember one of my first case of acute MI, cocaine-induced, you know, his friends brought him, and when we actually were dealing with him seriously and he was rushed to the cath lab initially, they got so scared, and it's like, what did he do? And all of them, they were actually high on cocaine, it seems, and they got scared that all of them actually had told us, okay, we were doing this. Are we going to get the same thing? So it's just like to bring to them, it's something that can actually cause serious effect. We are just trying to help you. They will tell you the information. Fortunately, cocaine is not something common in my country. We don't see it just like once in a while.
Anybody else? I'll have one first. So in the US population, at least old data, would say that about 25%, about a quarter of the patients who have evidence of recent cocaine use, again, by a study that doesn't look at its acuity, urine drug screens, will not admit to that, even when confronted with that data. So attitude and asking can make a lot of difference, but and it may be different in different countries, but certainly a good percentage of people are not going to, indicate that they've recently used. And as you demonstrated, a lot of the studies, if you do a meta-analysis of bad studies, you just have a larger number of bad studies to look at, and that isn't necessarily helpful. So how would you want somebody to do a study going forward in terms of, as toxicologists, we should be more involved in some of these external studies that will use the emergency department patients. So what feature would have been important to change from your perspective?
Actually, the best will be experimental studies, but it's difficult in toxicology, as you know. Again, large meta-analysis, more accurate, pooling more studies than rather only retrospective studies. So pulling all the other studies as well, it might help.
If you were going to do a small study or prospectively, we can sometimes work with the laboratory to do some testing that would be more suggestive of recent use. So you can sometimes use the laboratory as a friend rather than just accepting the results. That can sometimes help. But I think some of what you had mentioned, just in terms of letting people know that you're there to help them, you got to tell us the truth. But a lot of the patients with cocaine-associated chest pain are not having an acute coronary syndrome. So for them, those retrospective studies are correct. You could get away with it, but it may not be the best idea if they've actually got an MI and they've had cocaine use within the last few hours. So. Go ahead.
Yeah, I was going to say, would you consider that there may be other reasons to give beta blockers in cocaine toxicity other than chest pain? And in those scenarios, would you consider beta blockers, and which one? Because I accept your data for chest pain, and I don't know what the percentage of people that get chest pain with off the top of my head. I'm sure it's a significant, but it's not anywhere near 100%, obviously.
Yeah.
But what are your thoughts on
Yeah.
other
Other
indications?
issues that we can use, that we need to use beta blockers in cocaine associated, like patients presenting with agitation, hypertension. So beta blockers is one of the choices to relieve this hypertension. So here, and other issues like thyroid storm in line with cocaine. So you need to go ahead with beta blocker to prevent the transformation of thyroxine. The experts here, they recommend phentolamine for beta blocker, for hypertension management, which is an alpha blocker. So we'll avoid the issue of unopposed alpha stimulation. Others also, if that didn't help and the patient went to malignant hypertension, or you can go ahead with nitroglycerin or nitroprusside.
This is more of a comment rather than question, and for all the experts here. I'm not sure if the evidence for beta blocker and cocaine gonna happen the same way that calcium and digoxin happen, where actually the evidence came after people using it unintentionally for people who were in digoxin, and then eventually it turned out to be that, okay, it's safe, people are in digoxin. So I'm not sure if any of these studies were just like screening, kind of drug screen for people who presented with chest pain, and eventually it turned out to be cocaine. I'm not sure if somebody have thought of doing that, or it have been done in literature, because this is what happened to calcium evidence in digoxin. Like, eventually it turned out to be safe because people were doing it, and then later on they figure out, okay, people had digoxin toxicity. So I'm not sure if people presenting with acute chest pain, acute coronary syndrome, and or even an MI, and then they were screened for cocaine and turned out to be positive, and beta blocker was used and there was no effect. I just a thought that came to my cross. I'm not sure if anybody came across any of this literature.
That's a reasonable analogy, and maybe in the larger sense as well, right? We looked at our patient population, and 96% of the patients coming in with digoxin toxicity were elderly with some intervening acute illness that led to renal dysfunction or renal, pre-renal state, and they accumulated digoxin. That's a completely different patient population than the acute overdose of digoxin when they're not chronically on it in somebody who has no reason to have altered renal or potassium status. In the former group, which we see 96% of the time, potassium will not harm them. Calcium, I'm sorry, salts will not harm them. I think that's very similar to what we're seeing with cocaine-associated chest pain. 90-some-odd% of those patients do not have an acute coronary syndrome, and beta blockade will not harm them. Their blood pressure may go up some, but they are not harmed. But just as I would not choose to give calcium salts to a 2-year-old who got into grandmother's digoxin, I would not choose to give a beta blocker hour 1 to somebody coming in with white powder around their nose, diaphoretic, having a chest pain with tombstone ST elevations, because you're now selecting, much as you said with risk-benefit analysis, you're now selecting the group that would be most likely to have the most adverse outcome, and then you're testing it. And generally, we don't like doing provocative tests with patients. But I think that's a very good analogy in that way. And the guidelines, I think, are appropriate. Early use of beta blocker, like the first thing you do, probably not a good idea if you really think this is an acute coronary syndrome associated with cocaine. But 4 hours later, when the cocaine's gone and cleared from the system, maybe a good idea.
Particularly, as you mentioned, for things like a hypertensive crisis or palpitations that are just not settling down, not an acute dysrhythmia, but palpitations and tachycardia. We've certainly used labetalol in those kind of situations where they have a hypertensive crisis. It's not in the acute phase, it's kind of a little bit settled down. They're not having ST elevation. We've had experience in Australia using that, but they're isolated cases and not I think it's going to be difficult to have a prospective study where you are choosing that low-risk population to give it to, particularly in a place like Australia where we don't see a lot of cocaine anyway. Thank you. From Turkey. This is Dr. Umut Ocak. He is an emergency physician in Bursa and also working on clinical and basic sciences research at the University of Wisconsin and Loma Linda University as well. He's going to be talking about prognostic evaluation in carbon monoxide poisoning. Welcome.
Thank you for the presentation. Good morning to all. Today I would like to present prognostic evaluation in carbon monoxide poisoning. And first, let's get to know carbon monoxide briefly. As we all know, carbon monoxide is a colorless, odorless, tasteless, and initially non-irritating toxic gas formed by hydrocarbon combustion, and it's very difficult to be detected. Carbon monoxide is flammable and it's quite toxic to oxygen-breathing organisms, including humans. Here is the layers of Earth's atmosphere. The troposphere is the layer where we live. Carbon monoxide is present in Earth's atmosphere. Carbon monoxide is present in Earth's atmosphere at very low concentrations, but it may be higher in urban areas or enclosed environments, lower in clean air. And carbon monoxide has a typical lifespan of several months in Earth's atmosphere. The gas eventually reacts with oxygen to form carbon dioxide. Actually, carbon monoxide is a natural molecule in human body as a product of hemoglobin catabolism. Volcanoes and the bushfires are the natural, unfortunately, the bushfires are the natural sources of carbon monoxide in Earth's atmosphere. Humans contribute to vast quantities of carbon monoxide to Earth's atmosphere, mostly as a result of automobile emissions, leading to atmospheric carbon monoxide level in typical urban areas are around 10 ppm, which is about 100 times higher than in Earth's atmosphere overall. Carbon monoxide is the most abundant by mass pollutant gas. In areas with heavy traffic, carbon monoxide levels can rise to as high as 50 ppm. There are a lot of other sources of carbon monoxide. As you see, they are all human sources. So, what does carbon monoxide do? Very briefly, carbon monoxide binds to hemoglobin with much greater affinity than oxygen and forms carboxyhemoglobin, resulting in impaired oxygen transport and utilization. The oxygen dissociation curve is shifted to the left. Carbon monoxide binds to myoglobin with about 60 times greater affinity than that of oxygen, and carbon monoxymyoglobin has impaired ability to utilize oxygen, leading to reduced cardiac output and hypotension that may result in brain ischemia. So carbon monoxide has double effect on the heart. The binding of carbon monoxide to cytochrome P450 interferes with aerobic metabolism and efficient ATP synthesis. Cells respond by switching to anaerobic metabolism, causing anoxia, lactic acidosis, and eventual cell death. Carbon monoxide may cause leukocyte-mediated inflammatory changes in the brain, leading to CNS lipid peroxidation and delayed neurologic sequelae. Following severe intoxication, patients may display CNS pathologies such as white matter demyelination, leading to edema and focal areas of necrosis. Carbon monoxide poisoning is a worldwide health problem. For example, fire-related smoke inhalation is responsible for most cases of carbon monoxide poisoning, and non-fire-related carbon monoxide poisoning is one of the leading causes of poisoning death in the United States. And non-fire-related carbon monoxide poisoning likely causes around 400 deaths annually, while the number of intentional carbon monoxide poisonings resulting in death is twice as high. Carbon monoxide poisoning is an important public health in my country, Turkey too. We know that most of the incidents occur in winter, and the Middle Anatolian region is of the highest risk in carbon monoxide-related mortality. Carbon monoxide is known as the silent killer, as the signs and symptoms are highly variable and non-specific. So we must always maintain a high index of suspicion for carbon monoxide poisoning. The main findings are cardiovascular and neuropsychiatric symptoms. Acute poisoning may present with different symptoms based on the severity of the poisoning. Chronic carbon monoxide poisoning may be associated with non-specific symptoms as well. After remembering all these, we can start prognostication. And to estimate the prognosis, we must know who is at high risk and who are prone to long-term sequelae. The mortality rates of the patients with carbon monoxide poisoning at 1 and 3 months are 1.6% and 5% respectively, and nearly 40% of the survivors have permanent neurocognitive and emotional deficits. Who is at risk for carbon monoxide poisoning? Actually, everyone is at risk for carbon monoxide poisoning. However, some individuals are at higher risk. These are especially people using alternate heat sources during power outages, and elderly, unborn babies, infants, also people with chronic heart disease, anemia or respiratory problems, personnel at fire scenes, individuals involved into camping activities, and industrial workers. Many prognostic factors have been studied to predict the prognosis of carbon monoxide poisoning. We will talk about them, and however, very few studies have applied a scoring system which comprehensively evaluates both clinical features and laboratory tests to evaluate carbon monoxide poisoning. The PSS, Poison Severity Score, grades the severity of poisoning according to clinical symptoms in both adults and children. It can be used for different types of poisonings. Here you see the PSS chart, the GI tract, respiratory system, nervous system, cardiovascular system, metabolic status, liver and kidney, blood, muscular system, skin, and the eyes are all evaluated. Although initially it seems complicated, the use of the score is simple. The symptoms are checked against the chart, and the severity grading is assigned by the most severe symptoms or signs observed. I would like to mention another scoring system which is known as SOFA that assesses the severity of a patient's disease by evaluating 6 organ systems which are respiratory, coagulation, liver, cardiovascular, CNS, and renal. It's calculated upon admission and every 24 hours. And in this scoring system, points 3 and above are considered as dysfunction. Although PSS has been studied to evaluate a variety of different poisonings so far, reports on PSS for assessing the prognosis of carbon monoxide poisonings are rare. This is a very recent paper from Korea that revealed a potential role of PSS along with SOFA score in predicting the prognosis following carbon monoxide poisoning. In this study, the PSS and initial SOFA score were calculated at the time of arrival to the ED, and then the second SOFA that was calculated after 24 hours of ED arrival, and the 24-hour delta SOFA score, which was calculated as second SOFA score minus the initial SOFA score, were all found significantly higher in poor outcome group compared to good outcome group. According to this study, all PSS and SOFA scores were significantly higher in poor prognosis group compared to good prognosis group, both on arrival and at 24 hours. The predictive power of SOFA score or PSS were higher than lactate. That is a well-studied contributor to poor prognosis. Also, age, lactic acid levels, and GCS were other contributors of poor prognosis in the study. So how about lactic acid? Lactate is an important marker of tissue hypoxia and responds to several inflammatory mediators. The correlation between serum lactate levels and increased mortality has been shown in septic shock or trauma patients. There are a number of studies supporting the role of serum lactate levels as a prognostic factor in carbon monoxide poisoning. One of the initial studies showed a significant correlation between the plasma lactate concentration and the severity of neurological impairment following poor carbon monoxide poisoning. A more recent study has reported advanced age, altered mental status on admission, leukocytosis, decreased base deficit, hyperglycemia, and increased CK-MB levels together with increased lactate as predictors of poor outcome in patients with carbon monoxide poisoning. The same study reported advanced age, altered mental status on admission, leukocytosis, and increased lactate levels as independent factors associated with medical complications, including cardiac, neurologic, respiratory complications, and death. A more recent study from my country, Turkey, has supported previous findings and suggested initial lactate level as a measure of severe poisoning at admission to the ED. Of course, it should be noted that in poor carbon monoxide poisonings, multiple factors may affect lactate concentration, such as the duration of exposure, delay of treatment, and carbon monoxide-induced cardiac failure. Another study evaluating the outcomes in patients with carbon monoxide poisoning reported that hypothermia, shock, and coma were more common in non-survivors. Also, non-survivors had poorer arterial blood gas profile, as well as renal and liver functions compared to survivors. Carboxyhemoglobin is another one. It does not correlate with the initial severity and outcome of carbon monoxide poisoning. So it's generally not accepted as a predictor of severity, outcome, or mortality. This is for several reasons. For example, carboxyhemoglobin levels are influenced by the concentration of carbon monoxide in the inspired gas, removal from the source of carbon monoxide, delayed sampling after exposure, duration of exposure, and oxygen treatment given prior to the measurement of carboxyhemoglobin levels. How about hyperbaric oxygen therapy? Actually, the literature evidence regarding the effects of HBOT on mortality or morbidity in patients with carbon monoxide poisoning reveal conflicting results. For example, several studies showed that hyperbaric oxygen can prevent the late onset neurological sequelae of carbon monoxide poisoning, reducing the risk of mortality due to acute poisoning. Moreover, a study from Japan showed that the prognosis in the group treated with HBOT was significantly better than that in the group treated with normobaric oxygen. On the other hand, two very recent and important nationwide studies from Taiwan, including more than 20,000 patients, revealed that although HBOT was associated with a lower mortality rate in patients with carbon monoxide poisoning, especially in those who were younger than 20 years and those with acute respiratory failure. The risk for neurological sequelae was higher in patients with carbon monoxide poisoning who received HBOT than in those who did not. The increased risk was most prominent in the first 2 weeks and remained significant up to 6 months later. Then very recently, the effect of hyperbaric oxygen on neurologic sequelae and all-cause mortality in patients with carbon monoxide poisoning was evaluated by a meta-analysis of the 7 available randomized controlled trials. The results of this meta-analysis suggested that hyperbaric oxygen has no significant effects on recovery, moderate sequelae, severe sequelae, all-cause death, asthenia, headache, memory impairment, disturbed sleep, difficulty in concentrating, visual disturbances, behavioral impairment, and resumption of former activity. Moreover, 2-session hyperbaric oxygen increased the risk of memory impairment and difficulty concentrating compared to those who received 1-session HBO. Also, 2-session HBO showed reduced incidence of recovery and increased the risk of moderate sequelae. And metabolic acidosis is another one that contributes to prognosis. Carbon monoxide causes metabolic acidosis by interfering with systemic oxygen transport. And severe metabolic acidosis is associated with mortality. As we all know, delayed neurological sequelae usually develop within some weeks after an initial complete clinical recovery from acute poisoning. Although DNS gradually resolve over the first months, but can be permanent in about 1/4 of cases. These are the signs and symptoms that we can see as delayed neurological sequelae in patients with carbon monoxide poisoning. Although patients' initial presentation does not predict the development of DNS with certainty, some variables have been shown to be associated to DNS. These are older age, duration of exposure to carbon monoxide, longer time to treatment, transient loss of consciousness, seizures, GCS under 9, coma, abnormal results on early neuropsychometric testing, severe metabolic acidosis, early brain MRI abnormalities, and etc. Previous studies on just a minute. Previous studies on conventional MRI have shown that particularly vulnerable areas of the brain include the cerebral cortex, hippocampus, basal ganglia, cerebellum, and that lesions of the globus pallidus are typically seen in chronic phase of carbon monoxide poisoning.
1 minute, please.
Okay. A recent study has revealed that ABL occurred in nearly 27% of the cases with carbon monoxide poisoning, and globus pallidus lesion was the most common pattern, and 1/3 of the patients had multiple lesions. Although all these parameters were associated with DNS, and here you can see the hyperintense acute brain lesions following carbon monoxide poisoning on diffusion-weighted MRI. So in summary, as I mentioned earlier, there are some conflicting results. However, some variables such as older age, altered mental status, increased lactate level, severe metabolic acidosis are strongly associated with poor outcome. However, the results regarding the role of hyperbaric oxygen treatment and the levels of carboxyhemoglobin are still controversial. On the other hand, the results regarding the use of PSS and SOFA scores or acute brain MRI findings in determining the outcome are promising. Thank you.
Thank you. Any questions or comments? Just in the front here.
Thank you very much, Dr. Umut, for this presentation. Probably it is better to mention pregnant patient in risk groups, especially because the intrauterine fetus is very sensitive to carbon monoxide. Even though they are normal in the initial examination, but it is necessary to follow this patient for a long time, because as I said, the intrauterine fetus are very, very sensitive to carbon monoxide intoxication. And another thing, I think the poor outcome is related, associated that you mentioned, older age and previous abnormality or diseases. Sometimes, for example, in my city, the city I'm living in now, has the highest rate of the carbon monoxide intoxication. This is Gaziantep. Just a few simple example. A few years ago, we had only one night, over 900 carbon monoxide intoxication. we have some reasons. I will not explain them. Sometimes it is personality. What I mean, for example, 3 people, they sleep in the same room, and the exposure to carbon monoxide intoxication, one is on coma, the other are normal. They bring their friends. But I don't know the reason. Sometimes it depends, it is a personality. They are sleeping in the same room, one is in coma, the second one is moderate, and the third one is normal, totally normal. There is no any problem. And just a question, what do you think about plasmapheresis for the treatment of carbon monoxide intoxication? Especially erythrophoresis. Do you have any comment or explanation for this, for treatment?
Actually, it can be helpful, but I think it's still controversial because it depends on the patient's severity. So you can try if the patient is under coma.
Okay, thank you very much.
Thank you. An associate professor of emergency medicine, Ankara City Hospital in Turkey, with, I understand, has the largest ED in Europe. And he's also a member of the Institutional Clinical Research Board at Ankara City Hospital, published more than 50 articles in peer-reviewed journals, and is interested most in ultrasound and toxicology, and he's talking to us today on air pollution and its effect on health. Thank you.
Professor Makki, thank you very much for introduction. Good morning, ladies and gentlemen. Welcome to our country and this amazing city. First, I would like to express my gratitude to the organization and scientific committee of this great conference. It's a big honor for me to speak in here. Today, my topic is emergency department visits related to air pollution. As everybody knows, air pollution is a serious public health problem that we encounter in the world. We treat more than 1.3 million patients in the emergency departments of our country. You heard it correctly. It's true. More than 130 million patients in a year. Our population is 93 million, so it's a huge number. A certain percentage of these patients are critically ill patients, especially in the winter conditions. The diseases related to cardiovascular and respiratory systems are very often. Increasing evidence has demonstrated adverse effects of short-term exposure to air pollutants on the risk of cardiovascular and respiratory diseases. Most previous studies examining short-term associations between ambient air pollution and various health outcomes have measured ambient air pollution on a daily time scale, which provided important information for better understanding the acute health impacts of air pollution. A few recent studies have observed a more acute health effects of air pollution within a few hours of exposure. It's important to assess the hourly health effects of air pollution exposure. By this way, we can obtain important information for future air quality standards at hourly level. Most of monitoring stations measure the hourly concentrations of air pollutants, such as fine particles with a diameter less than 2.5 micrometers, respirable particles with a diameter less than 10 micrometers, PM10, sulfur dioxide, nitrogen dioxide, and carbon monoxide. The level of particulate matters increased during the cold months, and it played an active role in the respiratory system pathologies. The response to infection decreased due to increased inflammatory activity and immunosuppressant effects with the emission of PM. Particles causing air pollution show inflammatory and anti-inflammatory effects by adhering the epithelium in the respiratory tract and alveoli, by impairing biological membranes and cellular barriers. The studies showed that particulate matters were associated with respiratory diseases. For example, the frequency of respiratory diseases was stated to be increased in school children due to low level of air circulation in classrooms. Another study in China's Pearl River region reported a significant association between the increase in PM 2.5 levels and respiratory mortality. Canlı and colleagues showed that increased ambient levels of PM 2.5 were significantly associated with increased risk of out-of-hospital cardiac arrest within 1 to 2 days of exposure, which had a dose-response relationship. Subjects with conventional cardiovascular risk factors were more susceptible to harm of particulate matters. The authors reported sulfur dioxide increased the frequency of respiratory tract infections by reaching peak concentrations during the cold months. A study reported that sulfur dioxide level affected respiratory tract infections at an insignificant level. In a study conducted by us, we did not find significant relationship between SO2 level and pneumonia. In a recent study, in the dry season, sulfur dioxide was associated with a 2.5% increase in the risk of respiratory morbidity, while no significant association was discerned in the wet season. Additionally, a stronger effect of sulfur dioxide on respiratory morbidity was observed at the lag period of 48 and 72 hours. Substances such as nitric oxide, nitric dioxide, and nitric oxide are the chemical substances which are produced by the toxic gases, coming especially from vehicle exhaust and leading to the formation of ozone gas. Ozone, a strong oxidant pollutant, increases the susceptibility to infection and inflammation in the respiratory tract. Some authors stated that exposure to ozone played a role in the admission to hospitals with pneumonia during both hot and cold days. Nascimento et al. Determined that the frequency of pneumonia at urban level was related to ozone gas. In our study, the frequency of pneumonia was significantly higher in the patients with high levels of NO2, NO, and NOx in Ankara City, which we conducted our study. The significant associations between NO2 and all-cause and respiratory morbidity were observed in one central Chinese city, Luoyang. You can see the cities in this slide. According to the studies, sulfur dioxide and nitric dioxide were also significantly associated with immediate risk of cardiovascular related emergency ambulance calls. the concentrations of carbon monoxide increased during the winter months and caused infections. Fusco et al. Reported that during the months when the concentration of carbon monoxide was high, the frequency of asthma, COPD, chronic obstructive pulmonary disease, and pneumonia was increased. Because the largest pollutant of respiratory tracts was stated to be carbon monoxide. In one of our studies, the frequency of pneumonia was significantly higher in patients with high carbon monoxide level. Fortunately, I have some good news for you. Federal policies in the United States aimed at limiting air pollution costs over $80 billion per year. So, pollution control policies in Atlanta City in the United States were effective in reducing ambient pollutant levels and cardiorespiratory emergency department visits. And these impacts were stronger in later years after the pollution control policies had been fully implemented. Abrams and his colleagues investigated this issue and found that pollution control policies resulting from the 1990 Clean Air Act amendments led to substantial estimated reductions in ambient pollutant concentrations and also cardiorespiratory emergency department visits in Atlanta area. You can see the levels of pollutants and the reduction in the emergency department visits in this slide. In conclusion, there is a growing awareness of adverse effects on health of air pollution following both acute and chronic exposure, with a rapidly expanding body of evidence linking air pollution with an increased risk of respiratory and cardiovascular disease. And this is my great team from Ankara City Hospital. It is the biggest hospital in Europe. And 5 precious members of this team are with us today. And thank you very much for your interest to my speaking.
Thank you, Dr. Kepma. So we have time for questions, if there are any from the audience.
Yep, I was going to.
Okay, Dr. Afshin, thank you very much. Do you think the air pollution or deserves dust increase the emergency physician admission?
I think so. I think so.
I wanted to make a comment. Coming from Australia, we've had probably one of the worst bushfire seasons in living memory, and I've lived in Australia for 40 years in the last 2 months. And I wonder if you'd make a comment. So there was some data coming out that there was a few days during January when Sydney and Canberra had worse air pollution AQI index, air quality index, than Beijing and Delhi. But I wonder if you would comment on the size of the particles and what that means to different kinds of presentations and visits, if you may, and whether you've noticed in Turkey itself whether different parts of the country have different patterns of ED presentations.
Yes, absolutely. According to urban, for example, in urban areas, the particulate matters 2.5 and 10 are really increasing. At the suburban levels, the particulate matters are less. So it depends on the area where do you calculate the particulate matters or other pollutants. So if you are living in the city center, the particulate matters and other pollutants are really important risk factors for emergency department visits. Maybe some suburban places or villages, the emergency department admissions decrease, or it doesn't depend on the pollutants like city centers. So the location of the pollutants or location of the measuring stations also affects this factor.
I mean, we saw primarily respiratory. I mean, Australia's also got a very high incidence of asthma-related illness across the country. And there is a region of southern New South Wales which has got the highest rate in the world. And we tended to see a lot of respiratory. What kind of cardiovascular disease presentations are you seeing?
Coronary, acute coronary syndrome, heart failure are the most common cardiovascular diseases.
I'm just going to follow up on your comment or your point about the monitoring stations, which becomes a big issue, especially when you're trying to sort a generally improving air quality over the last decades with some of the rise in chronic disease incidents. So those monitoring stations are fixed, but they don't really address some of the point source pollutants that might be coming from traditional cooking methods, and in our country, some increased use of things like pellet stoves and other kind of things that are not going to be reflected in a community-wide monitoring station, but they will be, still important for the family and maybe the neighbors directly affected. Is that in Turkey, and given the diversity of the urban versus rural, are there any special populations that you're targeting, either for education or prevention measures?
Especially for the big cities, like Ankara, Istanbul, Izmir. Air pollution is a big problem. After the start of the use of natural gas, the air pollutant levels went down. So, starting from the big cities, and we have to be careful about air pollution and also education for this issue in the schools. And day by day, we try to do the best for this issue in Turkey.
Okay, one last question before morning tea. Yes, please.
We also had having a study. This study included over 1 million people, and it was during 10 years. We did it in emergency department and check if there is any relation between the emergency department admission and stroke, pregnant, and cardiovascular diseases, respiratory diseases, as you see. We found that as a result on dust storm, during the dust storm, we checked 3 days before dust storm and 3 days after dust storm, what happened to the admissions. The dust storm decreased the emergency department admission, but increased the hospitalization. There was a significant relation between the strokes, cardiovascular diseases, and pregnant diseases between the dust storm and emergency department admissions.
Interesting.
It includes more than 1 million people.
Very interesting study.
All right, thank you, and thank for all our presenters and your attention. Please go enjoy tea at the break. Thank you.
This forum that we're going into now is a forum on drugs of abuse and withdrawal management. Our first speaker for the morning is Dr. Brent Morgan. He'll be speaking on opioid addiction is a chronic brain disease. Dr. Morgan is a professor and vice chair of emergency medicine at Emory University in Atlanta, Georgia, in the United States. He's an emergency physician and medical toxicologist, director of the Medical Toxicology Fellowship, and chief of the section of medical toxicology there at Emory. So, Dr. Morgan, welcome.
Thank you so much. So today I'm going to talk a little bit about substance use disorders and how they're having their impact on the central nervous system and our brain. This has been an area of practice that I've gotten into as far as addiction medicine over the past few years, and has kind of helped me kind of reinvigorate and reinvent my career at my age. So, how many of us used to think this way, you know, that addiction, individuals are just kind of weak-willed, they're weak-minded, and just not strong enough mentally to quit. You know, I know I used to think this way with some of my interactions with people who had substance use disorders when I was taking care of them in the emergency department. But, you know, this has really been shown by a lot of scientific evidence that this is just not the case. That's really a chronic brain disease, that the substance use disorders have had dramatic changes on different neural circuits and pathways in our brain, and so I hope to show you some of these. So our objectives, again, are try to understand the science behind substance use disorders and how they cause some of these chronic changes in our brain, and then to identify the areas of our brain that are involved in substance use disorders. So addiction, just a little bit of terminology. Addiction is characterized by compulsive engagement in rewarding stimuli, despite the fact that there could be adverse consequences. And so, you know, we think of this a lot with substance abuse, but then addiction can also be gambling, for example, or sex addiction would be another example as well that we categorize as an addiction. And these disorders arise in the brain reward system, and we're finding more transcriptional and genetic mechanisms that are being activated that start us down this addiction pathway. And we'll get into that just in a little bit. Our individuals, our patients who have substance use disorders, you know, in general, our patients are not starting substance use with the goal of becoming an addict. Usually they're starting them in a social setting or because of risk-taking behavior, curiosity, or because of peer pressure. And so all of these are kind of, you know, about being a human and normal behavior. Then subsequently, this intoxication that they experience from using these substances start stimulating our reward pathways, mostly through a dopamine, and this causes that positive reinforcement and the one to continue to use. Then over time, this repeated long-term use undermine our voluntary control of this drug use, and then this transitions to compulsory drug use, and that's the hallmark then of substance use disorder. And I mentioned about transcriptional and some epigenetic mechanisms. This is some things that are just starting to be understood. It's really in its infancy as a science about how this works. But there's a protein that they've found called delta phos-B, and this functions as a sustained molecular switch or sort of a master control protein. And so once it gets turned on or sufficiently overexpressed, this delta phos-B triggers a series of events that ultimately produce an addictive state and helps cause some of that craving that people have for this compulsory use. It's also been shown to be elevated in people who develop other compulsive habits, you know, not just drugs or abuse, being people that have like compulsive exercise or compulsive runners can show to be having a high amount of this protein that's being produced through genetic stimulation. And then the problem is, even though when they stop their drug use, this protein has a really long half-life. So it's still there. You know, it can be there for months. And that's why even though they've stopped their drug use, and if there was a withdrawal syndrome, they've gone through the withdrawal syndrome, they still have this craving and urge to use, again, because of this protein still sitting there and causing the stimulation. And then this cycle addiction can really be described as having 3 stages, and each stage is particularly associated with a certain area of the brain, and we're going to go over these. And it's well supported through scientific evidence that there's disruptions in these areas of the brain are particularly important for the onset, the development, and the maintenance of substance use disorders. And so the 3 areas of the brain that are involved in the substance use disorders development include our basal ganglia, our extended amygdala, and then the prefrontal cortex. And then they get involved again in this circle of addiction where they can become binge, intoxication, and then they can start getting some negative effects or withdrawal, which is involved with the extended amygdala. And then there's the anticipation or the preoccupational thinking about the drug constantly, which is involved with our prefrontal cortex. So this binge intoxication is a stage in which the individual consumes this intoxicating substance and then experiences, the reward and the pleasurable effects. And then you start getting into some negative effects, again, from continued use or withdrawal. And at this stage is which the individual experiences negative emotional state in the absence of the substance. So if the substance is not there, they feel actually, worse. The anticipation stage is one seeks the substances again, after this period of absence, and so this goes along with sort of the cravings. And then the cycle becomes more severe as a person continues the substance use, and it produces these changes in the brain function that reduce a person's ability to control his or her substance use. So looking a little closer at these areas of the brain that we believe are involved in this circle, the first is mentioned is the basal ganglia. The basal ganglia is involved with us developing habits and routines. It's our reward circuit, so that when you do something that's pleasurable, that you get this dopamine release, and then you want to continue to do this. And so that can be anything from developing friendships to food to sex. Gives you motivation. And then also, but then drugs will overactivate this circuit and produces the euphoria of the drug high. And then repeated exposure to drugs in this circuit adapts to the presence of the drug, and then we'll have a diminished response from it. So that you down-regulate some of the receptors on it, and even though you're releasing the dopamine, you won't get as much of a response for it. And then it's harder to feel pleasure from anything besides the drug, because the drugs releases a lot of this dopamine. But then normal life experiences we would find pleasurable are not getting any effect from the dopamine that's normally being released, and so they're having a lot of apathy and just not feeling really good about life. So this person will feel flat, without motivation. They can be depressed, and they're really unable to enjoy things that were previously pleasurable. Our amygdala plays an essential role in stressful feelings like anxiety and irritability. This circuit becomes increasingly sensitive with increased drug use. And then after the drug use fades, the stressful feeling of withdrawal will motivate the person to seek the drug again, just to be able to calm that stressful feeling down. And then over time, the person with opiate use disorder really won't even be able to get high anymore, get that euphoria from the drug use. They're really chasing that drug just to get relief from this discomfort that's being caused by this overstressed amygdala. And then the last part of our brain that's involved in this is our prefrontal cortex, which is involved in some of the higher brain functions, such as the ability to organize our thoughts and activities, to prioritize tasks, to manage time, to make good decisions, and also is involved in controlling impulses. This is the last part of our brain that matures. So really, adolescents are at really increased risk then if they start drug use as far as developing addiction from this, and may not become fully mature until our mid-20s. And so whenever if you started using these substances, you really start amplifying the signals coming from the basal ganglia and the amygdala, and don't develop these circuits as well in our prefrontal cortex to try to control these impulses. And these CNS pathways are responsible, we believe, for all the substance of abuse, because they all kind of involve this dopamine system. So even though ethanol and opiates will have effects on other receptors, namely like GABA for the opiates, or I'm sorry, GABA for ethanol or benzos, or opiate receptors for opioids, the stimulants, marijuana, will also augment this dopamine system as well. And this is how you can get the substance use disorders from their use as well. So in a situation people are using, they will become intoxicated from it. They're releasing this dopamine, and then they're going to get this reward system in their basal ganglia and feel really good. This euphoria that occurs. And sometimes this reward is not just the neurotransmitter that's causing it, the dopamine. It can also be an acceptance by your peers if you happen to be with a peer group or also using drugs and you feel like one of the group. And so that can be also very rewarding for patients. It also can be just decreasing stress from this. This drug use helps you feel not as stressed, decrease depression, decrease anxiety. And so all of those can be kind of rewards for using the drugs. And then you get some neuroadaptation, because again, our receptors weren't put there to get stimulated by all this dopamine from substance use. And so you would downregulate some of these receptors, won't have as many there to receive that dopamine, and then not get as much response. And then you don't feel as good, right? And you sort of develop tolerance. And this is kind of our phenomenon of tolerance, that they have to keep using more of the drug to get even close to getting a similar response or to feel even normal. You get a decreased sense of satisfaction and decreased rewards from other things that used to be pleasurable for you. And then in addition, you get the withdrawal effect, which we're probably pretty familiar with withdrawal that you get from, say, opiates or benzodiazepines or ethanol, which have a clinical syndrome, but they still get a withdrawal effect from this dopaminergic system as well, that you could see with like cocaine, you can see with amphetamines, and so that may not be clinically apparent, but they will have apathy, anhydronegia, anxiety, emotional dysregulation. Again, that can make them feel really awful, and then again drive them to start using the drug again. Looking at some of the imaging studies, and again, all this is occurring really at a microscopic level, and we don't have a great ability to kind of see some of the changes that are occurring there. But when we're looking at the macroscopic level, looking at MRIs, you can see here's someone who has a substance use disorder, and this is published by the NIH. You can see the activity of the brain, if it's in yellow and red, looking at brain metabolism of glucose, compared to someone who has cocaine use disorder. And you can see just the metabolism is quite different as far as their glucose uptake and how they utilize glucose. Exactly what this means, we're not 100% sure, but other again, just showing that it has some chronic effect on their brain. Similarly, here's some imaging studies, functional MRI, using a radio-labeled neurotransmitter that will bind to D2 dopamine receptors. And you can see a normal image here where someone's lighting up in their basal ganglia, and then someone who has cocaine use disorder in the middle photo. And then even 4 months later, after they haven't used cocaine, that their scan is still not normal. And so how long these changes, last or occur, can vary, and we're not 100% sure, how long until this can get back to normal, if it completely does. And so I think, really it's good to have this knowledge. It can help us, approach these patients in a non-judgmental manner. It can help us reduce the stigmata of having these diseases. We can approach them again with compassion and then implement proper treatments for them. Similarly, how if I have a patient who has emphysema because they've been smoking 40 years, I don't blame that person, right? As a physician, I'm not judgmental. I give them the best care that I can, even though the smoking led to their disease. And so I think we still need to take that approach with our patients who have substance use disorders as well. This is not to say we're not supposed to hold them accountable, for their treatment going forward, and have strict protocols and make them adhere to the guidelines, because that's something that can definitely help them get them on their path to recovery. And I think we have time for some questions.
Thank you, Dr. Morgan. That was a wonderful talk to enlighten us on the neurobiology of addiction and substance use disorders. Any questions from the audience? About medical toxicology, a lot of us in the audience are medical toxicologists. What would you say is the role of the medical toxicologist in managing addiction patients, or maybe in an addiction clinic, that sort of thing? What role do you see medical toxicologists playing?
I think it's an area of growth for our specialty. At least in the U.S., it's hard to sustain a practice just by seeing acetaminophen overdoses that are presented to the hospital. You're getting just a couple of those calls a day, if maybe not even that many. And so we've seen this as it was an unfilled area at our hospital. And we were able to integrate it, into our practice. If we're going over to the hospital to, again, see an acetaminophen overdose, it's easy for us just to pop in and see the opiate use disorder patient who's interested in getting started on Suboxone. And then we also started a clinic in our practice as well that will follow up, have these individuals follow up with us, and then we'll see them there. Continue to do routine drug screening on them. We have counseling services that are embedded in our clinic. And so it's been a real interesting area of growth for our practice, and I know in several other medical toxicologists in the U.S.
All right, well, maybe I'll ask one more question then. In the overall management of a patient who does have a substance abuse disorder, are there particular times when an addiction patient may be at more or less risk for an acute overdose?
So we're certainly concerned about our individuals that we have in our clinic who then suddenly start becoming non-compliant. They've had over a course of several weeks that they've been seeing us, they're losing their tolerance, and so then suddenly if they start becoming non-compliant and go back to using street heroin, which can be easily have a lot of fentanyl in it. They may go back through their usual dose, and that potentially could be a lethal dose to them, even though 6 weeks earlier they were tolerating that with no problem. And so those are patients that we're really concerned about at that time.
Thank you. Any questions from the audience? So in our schedule for this morning, there's Dr. Rebecca McDonald is listed as the next presenter. She could not make it, so we will move on to the next presenter. Is Dr. Kamour available? Perfect. So apologize for that little change in the agenda, was it? Okay, good morning. Alrighty. So as Dr. Kamour comes to the stage, Dr. Ashraf Kamour will be talking to us this morning on music festival drugs. Dr. Kamour is an acute physician and clinical toxicologist in Abu Dhabi. Welcome this morning.
Thank you. Thank you for having me, and thank you for a nice introduction. Okay. So welcome, everybody. Try to talk to you today about an epidemic which we have been seeing over the last, well, it's been going for 50, 60 years, as long as the festivals and parties and gatherings, outdoor gatherings and indoor gatherings has been going on, there is a problem with drugs. But what we start to see over the last 20 years is the introduction of new substances to which the experience is lacking for managing them or handling them. So basically, sorry. Yeah, so basically, in recent years, there is a new concept that we've been having, of new drugs called novel psychoactive substances. And this changed the scene, the drug abuse scene worldwide. And that's involved also in Turkey. I have some data I'll share with you later. But it has been a problem, especially in the Western countries. So why people use drugs in festivals? Now, in UK, they've done a survey of people who goes to festivals and found that apart from alcohol, which is legal and people can use it and that's fine, marijuana, 40% of people go to festival use marijuana. And what is concerning, the next most common substance is the novel psychoactives, the new things to the market. Ecstasy been there for a long time, but you talk about the Molly, the MDMAs, the MDAI, the MD, the methylene dioxymethamphetamine, amphetamines, etc. And that's are going up and up. This was in UK. And if you go and look at what happened in America, the same pattern is there. And you can see the cocaine is low, because it's expensive, you can get hold of it. The other drugs, this novel psychoactive, you can buy them online. You can just go on, just try, you go to a website, buy it, it comes next week. And this is the reality, not only in Europe and America, in Asia, in the Middle East, and Arabic countries. I work in Abu Dhabi, in UAE, and this has been an issue. With a patient comes to hospital, overdosed on novel psychoactive, in extreme bad shape, and you go dig into the story, and you find he bought something through the internet, and he have the receipt from Aramex, DHL, or whatever, and it is easy to get. So in 2015, just to study the people who goes to festivals, what they think about drugs, there's a charity, it's drugabuse.com, which belongs a subsidiary of American Addiction Center, done a study on Instagram post, which has hashtag drugs, hashtag festivals. And they found the second most common drugs they talked about is mollies, MDMAs, the ecstasies, the novel psychoactives. And then you have your cocaine, your crack cocaine, and mushroom, and etc. So it is popular. And we're talking about good percentage of people who go to festivals have these drugs. And now, if you can, one would wonder what sort of drugs these people would use. And this has been studied extensively in the last 10, 15 years. And if you look at the slide, the graph on the right side from UK, under Freedom of Information Act, the police released the information of which drug they got from which festival. And you can see Glastonbury, mostly it was, I think mostly it was, sorry, I can't see, my eyesight is, yeah, sorry, piperazines. And the second one was cannabis, followed by ketamine. If you go to another festival, Isle of Wight, the most common one was cocaine, and that was followed by ecstasy, MDMA. So, and this pattern actually is followed in America as well, the slide on the left side. What's genre of festivals, rock, metal, whatever, you find different drugs people use. And probably that makes sense. I'm not a festival person and I don't use drug, but probably makes sense which drug you want to use for which festivals. It's just pick and choose. This has scientifically been proven, actually, in several studies has been conducted in several countries, including US, that they've collected wastewater, urine from areas, wastewater pools that collect from the festivals, and they would analyze them. And they would find, sorry, and you would find that some festivals like Metals has more cannabis, methamphetamine, Bob Rock has, the Rock has MDMA and ecstasy, etc. And this study has been done in Czech Republic and Slovakia and 6 festivals. And as I said, this has been emulated in several countries around the world. Now, if we want to talk about Turkey, so your prevalence of drug abuse is you're still with the traditional market. Turkey is a traditional people, and they still stuck to their marijuana, stuck to their traditions. But it is coming. The drugs are coming. So if you look at the right side of the slide, the fifth most popular amphetamine, and that was 2017 study. And I'm pretty sure if you, the next data, which is coming from European Monitoring Center of Drug and Addiction, drugs addiction. That does 2017. So the next one is going to be 2021, I think. Or 21. It will be going up, amphetamine and new and novel drugs of abuse. But what's the most worrying here, if you can look at the slide, that you have the death secondary to drug of abuse is remarkably increased over the last couple of years. And that's very, very significant. HIV rates is increased as a result of drug abuse. Moving forward, this is your amphetamine. You see the slide. So this is the years. So over the last 3 years, jumped in Turkey. So this is something you need to know about. This is something you need to know how to manage, how to handle. It is not a problem for toxicologists. It's a problem for all healthcare physicians. And why it is a problem? Because these drugs kills. There is, unfortunately, hundreds of cases of deaths in festivals secondary to drug of abuse. And I'm going to later on tell you my experience with festivals, not my personal experience, but as a treating physician. But this is a problem that people get to hospitals very sick, and some of them die. I'm not going to dwell why people use drugs too much, because Dr. Brandt covered that indeed in a nice way. But I don't know if you've seen the movie Candy. It's a fantastic movie if you haven't seen it. It's about heroin abuse, and it is about triangle of heaven, earth, and hell. That's what drug is. It's not. I'm not worried only about people who use drug in festival that they die or get sick acutely, but the problem, they experiment, and then they become purposeful use, and then they become intensify use, and then they end up addicted. So. Let's go to the traditional classifications of drug. This classification of drug of abuse of sedative, stimulant, and hallucinogenic was there for hundreds of years. So you have your opium, you have your coca, you have your mushrooms. That's remained true till late part of the 20th century. Then things start to change, and we start to have more classification: stimulant, hallucinogenic, analgesic, and depressant. As in the last 20 years, drugs start to come to the market, we start to have the other category. And that other category started to have a lot of drugs into it. We cannot classify them. The old classification does not fit them. And as time goes by 2012, 2013, the market of drug of abuse, novel psychoactive substances exploded in Europe and America. And then you start to have things that you start to have new classification: the dissociatives, the empathogenics, the drugs, the cannabinoid, the synthetic cannabinoid. And that's become a problem because people don't know what they're dealing with. Physicians, authorities, they don't know what they're dealing with. They're catching up, they're playing catch up. There was a study back, I think 2015, suggested that every week there is a new drug enter the market in Europe. Every week, a new drug. So this is what's brought people to think about a drug abuse wheel. So if you think about drug of abuse as a wheel, okay? And you can classify the drugs that you have into stimulants, empathogenic, psychedelic, dissociative, cannabinoids, depressant, and opioids. And what you do is stimulants. What's the stimulants? The drugs that give you the high, they become very energetic, you want to fight the whole world, and those are the stimulants. And you have the depressant, make you feel relaxed, chill, buzzing. The opiates make you feel confident and visible. The psychedelic give you the spiritual trip and feel your senses are highlighted. The cannabinoids, stoned, calm, the munchies. And you have the dissociatives, the out-of-body experience, euphoric and floaty, like you're floating in the sky. And empathogenic, you feel loved and you feel cuddly. I'm making it very appealing, aren't I? Anyway. So if you look at the outer circle, this is the old drugs, and the inner circle is the novel psychoactive. So these drugs, I'm not going to dwell into this too much, but you can see a lot of drugs coming into the markets, and this is just probably 2% of the drugs are there. The list goes on and on and on and on. And what are they? What's the novel psychoactives? These drugs are being brought to the market to bypass drug laws. So if the drug law say you can't, cannabis is or cocaine is class A drugs or it is illegal, they will change the structure and they will go into making a new drug that's not covered by the law. If you can look at amphetamine and you can look at the ephedrine, it's almost similar structure. Just change one atom to another and Bob's your uncle, and you bypass the law. So why they are a problem? The second, you go back to the same question. Because nobody knows what you're taking. The guy who's selling you the drug doesn't know what he's selling you. The guy who's making it doesn't know what he's making. The guy who's using it doesn't know what he's using. The adulterations, there is no quality control. And you can look at the user websites, and there's some drugs testing websites. You can send them the drugs in Europe and America, and they test it. And you'll be amazed what you find in these drugs. So, and some of them, they have paracetamol in them, all of it paracetamol, some starch, and some have a mix of these drugs, which is very, very lethal. So what do you need to know? So I'm now scared you enough to tell you that there is hundreds of drugs out there. You're not going to remember every one of them. You're not going to remember what is each one of them going to cause. What's the clinical feature of each one of them? No. So for you, do you need to know what is this drug and what's the problem with these drugs or not? Now, another thing I just want to mention, and I don't know what's in the situation in Turkey, but for example, in UK, where I used to work, the single substance has different names.